पास जाके बोल के आना पड़ेगा।
सर टेलीग्राफ ग्रुप में मैसेज डाल दो कि सेशन इज अबाउट टू स्टार्ट, थोड़ी देर डाल दो।
सरस्वती के भंडार की बड़ी अपूर्व बात, जो खर्चे त्यों तो बढ़े, बिना खर्चे घटी जात। दिस मीन्स Saraswati's treasure grows when shared, but fades away if left impaired. Last year, we began a journey, and what a beautiful beginning it was. In 2024, Department of Pharmacology conducted a zonal conference on artificial intelligence in healthcare, which was a resounding success. The response was truly heartening. From the overwhelming number of registrations to the enthusiastic participation across sessions, the event surpassed our expectations in every way. Encouraged by that success, we felt it was time to expand our reach with National Conference Medipharmacon-2025 with even greater energy and participation. Imagine a world where the smallest organism could unlock the biggest breakthroughs in medicine. Welcome to that world where the human microbiome is rewriting the rules of pharmacology and where our shared knowledge can drive health for all, beyond every border.
I, Dr. Jyoti Khanna.
And I am Dr. Monica Verma. A very good morning to all.
Ladies, gentlemen, distinguished guests, esteemed faculty members, pioneers in pursuit of leadership and better health, and all the participants. Welcome to the conference on Pharmacology Beyond Borders, Harnessing the Microbiome for Health for All, organized by Department of Pharmacology, PGIMS Rohtak. It's an honor to welcome you all in the important gathering today. As we explore pharmacology beyond borders, we turn our focus to something small but incredibly powerful, the human microbiome. These tiny organisms within us are changing the way we understand medicine, offering new hope for prevention, treatment, and healing across the world. In this conference, there will be 6 sessions comprising of lectures, along with oral and poster presentations and panel discussion, followed by valedictory function. So without any further delays, we'll start with the sessions today. I request Dr. Jyoti Sharma and Dr. Sonal Dogra to take over with the session 1.
Thank you, Dr. Jyoti Khanna and Dr. Monica, for the warm welcome extended to our delegates. In the world of ideas, we all are explorers, journeying through knowledge, unlocking new doors. With every step forward, we learn and we grow. Together we'll shine and make the world glow. This simple poem reminds us that knowledge is not something we merely collect. It's a powerful tool meant to be shared for the betterment of the world. So let's begin this voyage together with bright minds and open hearts. I, Dr. Jyoti Sharma,
and I, Dr. Sonal Dogra,
will be your companions in this intellectual journey.
Dr. Jyoti, I must admit, the word microbiome used to scare me. It brought to my mind superbugs and the dreadful diseases. But today, I'm genuinely excited to learn how these tiny microorganisms can be transformed into therapeutic agents that can revolutionize the treatment of countless conditions.
Absolutely. We are about to embark on a fascinating journey into the world of microbes and uncover their incredible potential in enhancing human health.
We are thrilled to present today's highly anticipated sessions. Prepare yourself for an engaging and thought-provoking lineup as we dive deep into the microbiome, exploring its growing role in pharmacology and beyond.
Let's now invite our esteemed speakers to share their insights into current trends and future directions in diagnosis and treatment.
In the first session, we have two captivating lectures ahead. Isn't it remarkable how these tiny microscopic organisms live in harmony with us, helping regulate the homeostasis and even modulating our immune system? Our opening lecture will explore the intimate relationship between microbiome and human health.
To chair this session, I invite eminent professionals from interconnected fields. Please welcome Dr. Sanjay Marwa, Senior Professor and Unit Head, Department of General Surgery, PGIMS Rohtak. I now invite Dr. Antariksh Deep, Professor, Department of Microbiology, PGIMS Rohtak. Please welcome Dr. Garima Bhutani, Professor, Department of Pharmacology, BPS GMC, Kanpur Kala, Sonipat, to kindly join us on the stage.
It is now my pleasure to invite Dr. Pushpinder Malik, Professor of General Surgery, BPS GMC, Kanpur Kala, Sonipat, to deliver the first lecture of the day on human microbiome and microbiota, dysbiosis in human disease. I request our respective chairpersons to introduce our distinguished speaker.
Good morning. So I welcome you all in this opening session of today's scientific program. And first speaker today is Dr. Pushpinder Malik, who is a professor in the Department of General Surgery at BPS Government Medical College, Kanpur Kala, Sonipat. And about his brief biodata, he has done graduation from Government Medical College, Surat, Master Surgery also from Surat,
Hello.
and he is gold medalist from South Gujarat University, and he has won S.H. Pandit of Indore medal in 2011 and Rasik Lal M. Parekh medal in 2011 again, then Seva Ratan Award SVHM 2020 and 24. Then after doing his post-graduation, he did his senior residency in Department of Oncosurgery at our institute, PGIMS Rohtak. And he then joined BPS Government Medical College, Kanpur, and rose to become professor as of now. And he's trained in AIMS New Delhi at Braij, short-term course. Then regarding his membership, he is life member of ASI, IAGES, CELSI and MRC. Presently he is Vice President of NMO Haryana, Secretary Haryana Chapter of Association of Surgeons of India, and total publications to its credit are 25, out of which 7 are international and 18 are national publications. And he has presented 9 papers. So these are his credit scores. So I request Professor Dr. Pushpinder Malik to start the presentation.
Thank you, sir. Thank you for nice introduction. Good morning to everyone. And at the outset, I would thank the organizing committee to invite me for this important and emerging field of microbiomes. So to deal with, I just reading this book, Gut Check. This is one of the best-seller book for microbiomes by Dr. Stephen R. Gundry. He's a cardiothoracic surgeon, but he has a very interest in these microbiomes and microbiota. He told that there are so many surgeries we are doing nowadays that can be avoided if we understand the microbiomes, microbiota and dysbiosis in various surgical diseases. So I'll just give you a simple example of appendicitis. Sir will agree that appendicectomy is one of the most common emergency done in our times. But now there is a shift towards the conservative management of appendicitis. And it is still, there are so many studies which are saying that we do not need appendectomy in every case of appendicitis, and it is included in latest edition of belly also that appendix has an immune role. It has an immune role by maintaining the gut microbiota. So that's the importance of this topic, microbiome, microbiota and dysbiosis, that we have to understand. Being a surgeon also, when Dr. Sunil called me, I have just gone through 2 or 3 pages of this book. But I am able to understand the importance of this topic. I'll start this lecture with a small story of Toxoplasma gondii. Everybody is aware of it, and it has a definitive host and a intermediate host. Humans are the accidental host in this, and we are more aware and more concerned about this. Why? Because the pregnant females are getting affected with the Toxoplasma gondii, and it transmits through the placenta, and there are various defects that are occurring in the newborn childs. So it goes to the humans through cat feces. So that's why when there is a cat in the family, so doctors advise the father to scoop the poop, not the female. Why? Because it transfers through the feces of the cat into the human beings. Then because definitive host is cat, so Toxoplasma gondii can reproduce itself only in the cat. And every animal, being it a microorganism, be it a human being, they have a tendency to multiply and then pass on their gene to the next. That is the purpose of life. So they need a intermediate host from where this Toxoplasma gondii will come to the cat. And it is coming from the rodents, rat. And it makes sense also that cat will eat rat. Okay, but over a millions of years, this Toxoplasma gondii, a single-celled microorganism, has changed totally the rat physiology. How? Because rat have a fear in mind of the cat. But what Toxoplasma gondii infection will do? It will go to the amygdala and it will wear off the fear factors. Now, Jerry is not afraid of the Tom. So it's the same way rat is not afraid of the cat. And second mechanism, the rat has a fear response from the smell of the cat's urine. Everybody is aware of this. But when it is infected with Toxoplasma gondii, what is happening there? That smell in them increases the level of dopamine. So there is increased desire, for sexual desires are increased. So now rat will run towards the cat. So can you imagine this? A single-celled microorganism has totally hijacked the brain of a rat. So think about this. And when I was reading this book, and I came across so many articles in last 2-3 years, and that proves the relevance of this conference. I think microbiome, that is an emerging trend in our medicine history. There are so many studies in last 2-3 years are there. So understand it. I think learning objective for my today's lecture will be, we should be able to understand about microbiome, microbiota, and dysbiosis. I will focus only on the surgical disease, being a surgeon. So we should be able to understand what is microbiome. Human microbiome consists of trillions of microorganisms that live in and on the human body with genes they carry. That constitute the microbiome. And what is microbiota? Microbiota is the community of microorganisms that lie in a particular ecosystem or body site, like gut microbiota, skin microbiota, and respiratory system microbiota. We will be amazed to know that the species of microbiota contains more than 150 times number of genes when compared to human genome. And therefore, it is sometimes called the forgotten organ, integrated along with the other organs for proper homeostasis. I will tell you, it is a forgotten organ, but with advent in last 2-3 years, it is going to become an essential organs. When we are in our residency, we used to learn about peritoneum and mesentery. Now it is considered as a separate organ. The importance is so much in microbiome also that it will be going to become not the forgotten organ, it will going to become an essential organ. So major phyla, 90% of the major phyla in human beings, human gut composed of Firmicutes and Bacteroides. There are some species, important species I will enumerate. These are Ruminicoccus and Eubacteria, Streptococcus, and Lactobacillus will know. In our time, we used to know or discuss only about the Lactobacillus. IBD is there, Lactobacillus. Whenever there is a loose motion, stop milk, give Lactobacillus. So, but nowadays, different microorganisms are coming into the pictures, like Bacteroides. Bacteroides has an important role to play. Then, Prevotella, Proteobacterias, Actinobacterias, Uric Archaeotas, and Varicomicrobias. Now, this is about a brief view. All microbiotas, different organisms lies in the different respiratory system, has a different microbiota, skin, vagina, oral, gut, and then we used to know that stomach has a acidic pH, so bacteria will not grow here. But there comes the role of H. pylori. H. pylori used to live in the stomach, leading to various gastric disorders. Then, but there is 10 raised to power 1 to 10 raised to power 3 coloniformic unit per ml, and Firmicutes is one of the common bacteria or microorganism that is living inside the stomach. Then the load according to the part of the intestine is increasing. It is increasing from stomach to the small intestine. From small intestine, it is going to the large intestine. And large intestine has a maximum load of microorganisms, that is 10 raised to power 10 to 10 raised to power 12 coloniformic units per ml. Then how this microbiota? Madam told that there is a symbiosis, there is a mutualism between these. But various factors are affecting the microbiotas. These can be extrinsic factors as well as the intrinsic factors. Extrinsic factors that are affecting the gut microbiota is age, genetics, antibiotics, diet, infections, geography, antimicrobial, and even the delivery pattern affect the microbiota of our gut. The gynecology peoples will understand that now there is a trend towards more of the cesarean, and government is focusing on not to do cesarean to promote the vaginal delivery. So why? Because I told you previously also, there is lactobacilli in the vagina. So when there is a vaginal delivery, lactobacillus is a useful bacteria. So when there is a vaginal delivery, the newborn is exposed to lactobacillus, and gut is rich in the lactobacilli. That is not happening in cases of cesarean delivery. Their skin microbiota is firstly exposed to the gut of these newborn childs. So that is the importance. These are certain extrinsic factors that has a very important role to play. We'll discuss it when we'll be discussing the diseases individually. Then there are some intrinsic factors like anatomy, physiology, pH, oxygen tension, flow rates. As I told you, from stomach to the large intestine, the gut microbiome is increasing because food remains there in large intestine for maximum time. Then substrate availability and host secretions also affect the gut microbiota. Then stomach microbiota I will be just telling briefly that there are Firmicutes, Bacteroides, Proteobacteria, Fusobacteria and Actinobacteria in stomach. But in healthy there are also Streptococcus, Prevotella, Villanella, Rothia and Haemophilus are common inhabitant. And when this food goes from the stomach to the small intestine, what is happening there? pH and bacterial load are low. Because there is acidic pH in the stomach and it is going into the small bowel, then there comes the alkaline, alkaline secretions. The small intestine is lined by simple columnar epithelium tissue covered by a mucous layer and has a large surface area because of the villi and microvilli. The small intestinal mucosa are home for members of the phyla Bacteroides and Firmicutes. Food is blended with bile, bicarbonate and digestive enzyme in the duodenum, and when the intestinal content reaches the large intestine, the food blend has been converted to neutral or alkaline pH. The small intestine provide a more challenging environment for the microbial colonizers given a short transit time of 3 to 5 hours and a high bile concentration. Large intestine has complex bacterial diversity in GI tract, I told you earlier, because of its larger volume, moderate to less acidic pH, low concentration of bile salts and longer retention time caused by the slow peristalsis. There are 5 microbiota. They are more prominent in cases of large intestine as Firmicutes, Bacteroidetes, Actinobacteria, Vericomicrobias and Proteobacterias. Clostridium, Fusobacterium, Bacteroides, Actinomyces and Propionibacterium are associated with large intestine. Other gram-positive associated with are the micrococci, peptococci and peptostreptococci and ruminococci. These inhabitant has a role when we are operating on small bowel and large bowel. Then we should be able to understand this concept of microbiota signature. What is this microbiota signature? It is a distinct composition and functional profile of the gut microbial community, reflect the healthy status of an individual and provide insight into a disease mechanism. So what certain authors have compared this microbiota with the rainforests. Like rainforest, better rainforest is having maximum diversity living in harmony with together. The same is with these microorganisms, that they should have a proper diversity and they should live in a proper harmony. So likewise, that if one is increasing, second will help it to decrease. Like in food chain also. Same is happening with these microbiomes. The signatures are shaped by the interaction between host genetics, diet, environment and microbial ecosystems. Healthy signature is marked by diversity, resilience and presence of key functional taxa that support the metabolic and immune response. Then once we are aware of what is microbiome, what is microbiota, then we should be able to see what is dysbiosis. That is a cause of so many diseases. Dysbiosis is a state characterized by distinct microbiome alterations that results in imbalance in the microbiota modification in their functional composition and their metabolic performances. The impact of microbiome on human physiology and pathology is so extensive that microbiome has been considered as an essential organ of the body now. The human gut microbiome is a complex mixture of microorganisms including virus, archaebacteria, yeast, fungi interacting with each other and with their host in complex ways. These interaction involves either symbiosis, mutualism, antagonism or even predations. So we'll discuss a little bit about the common surgical diseases and dysbiosis in those. So one is inflammatory bowel disease. I'm not talking about inflammatory bowel syndrome here because I think my fellow speaker will speak on that. So dysbiosis in inflammatory bowel disease. There is normal gut microbiomes. We have seen that it is Firmicutes, Streptococcus, Villanella, Clostridium and so on. But studies has proven that in ulcerative colitis, there is increase in the colonies of Proteobacteria, Escherichia, Klebsiella and Bacteroides. And there is decreased colony of rest of the microorganism. That important one are two here. One is Firmicutes and second is last one Bifidobacterium longum. These are most studied bacteria nowadays. So what is happening in the inflammatory bowel disease? Intestinal bacteria transform the simple sugars into organic acids, short chain fatty acids. This is the role of microorganism, that whenever the complex food like fibers, everything is coming, the microorganisms survive on the nutrients that are not helpful to us but helpful to them. Like fibers, we used to take fibers more, so bacteria will ferment them. Similarly, oligosaccharides that are not absorbed by our body, that bacteria will convert them to the lactate, acetate, propionate and butyrate. This plays a very important metabolic role. Acetate produced by bifidobacteria can suppress the virulence of Zika-like toxins from virotoxigenic E. coli. Acetate is used by muscles and aid in the byproducts of the fiber fermentation. Propionic acid has a ability, this is very important role of propionic acid and butyrate. Propionic acid has a ability to switch off the hunger signals from brains, serves as a satiety molecule, and it also helps in ATP production in liver. Butyrate induces apoptosis in malignant epithelial cell that lines the large intestine, therefore lowers the level risk of the bowel cancer that we will be discussing in colorectal cancer and dysbiosis, and this provides energy to the gut cells also. So this loss of short chain fatty acids and increase in bile acids, fecal amino acids, lipopolysaccharides are seen in inflammatory bowel disease, and it triggers the toll-like receptor 4, which stimulates NF-kappa B pathways, inducing the inflammatory response that activates interferon gamma and tissue necrotic factor alpha, which will further lead to the inflammation and lead to these diseases like inflammatory bowel disease. Short chain fatty acids reinforce the intestinal barrier functions, maintain proper immune response with regulatory T cells, and promote gut microbial hemostasis and mucosal tissue regeneration. What is there? They're linked with the modern lifestyles are cigarette smoking, antibiotic uses. I have told you that repeated use of antibiotics will change the gut microbiota, and reduced exposure to the microbiomes throughout the childhood by urbanization and hygienic practice. The same has been proven with the tetanus also, that certain diseases are on rise because we are very aware of not to play in the soil nowadays, and so many bacteria we are getting from the soil. Now there comes the role of naturopathy, where we used to go mud bath. We have to go to our basics again. Increased risk of, these all factors will increase the risk of inflammatory bowel disease. Then antibiotic driven dysbiosis. There is lot of role about these superbugs, and everybody is discussing antibiotic resistance is there, and we are more concerned because in surgical patient we used to give long cycles of antibiotics that lead to pseudomembranous colitis due to this Clostridium difficile infections. These spores are very tolerant to the extreme of the temperature environments, and these utilizes this to colonize disrupted or altered microbiome. This produces two lethal toxins, toxin A and toxin B, which causes infection in the gut, responsible for dysbiosis by proliferation of bacteria and mucosal disruption that causes the diarrhea. It is a basis for pseudomembranous colitis. Then treatment is also based on this. That treatment with antibiotics like vancomycin and fidaxomicin is successful against inflammatory bowel disease and Clostridium difficile infection. But now there is emerging role. I am thankful to the organizing committee that I go into the detail about this fecal microbiota transplantation. I used to keep going for lecture, and I used to say IBD, okay, in some cases we go for fecal this microbiota transplantation. But ma'am, thank you that I have read it again and just give you about the brief history that what is there in this fecal microbiota transplantation. There is transfer of the stool from the person with a healthy and diverse microbiota to a patient who has a distinct dysbiosis or inflammatory bowel disease, and it has a proven role. It has a proven role that fecal microbiota transplantation is used in the inflammatory bowel disease and gut dysbiosis. Then there comes when we are talking about fecal microbiota transplantation, there are restoration procedures. This is also called a restoration procedure. It is in some cases used to treat and reverse pseudomembranous colitis that are resistant to antibiotics. So that's why this is important of FMT is there. The donor's beneficial microbes potentially colonizes the damaged mucosa that is causing the diarrhea. of the patient to regulate intestinal flora and start to reverse dysbiosis, and subsequently it lead to healing. So that is a basis for FMT. Then certain latest drugs are also there, but we have learned only the name. Now there are Rebiota, RBL. It consists of live microorganism. I told you there are 2 microorganisms that are most studies. And with advent, this is possible because of advent of certain the 16S ribosomal RNA techniques that are used. These are consist of Bacteroides and Firmicutes phyla. These are collected from healthy human stool samples. Then spore delivering SCR109 drug consists of bacterial spores of healthy individual and used to combat the recurrent Clostridium difficile infections. This is very important because nowadays when we are sending the pus culture, everything it is coming R, resistance. So what to do? Then we empirically give, okay, give it Septran, we give it amoxicillin, but that is not the way. We should be looking towards this microbiota decomposition now. And there is also, it has an important role in obesity. High fat diet increases the pro-inflammatory macrophages in the gut. Obesity is associated with inflamed gut, fluctuation in the gut microbiota, and developing disease such as diabetes, cardiovascular disease, cancer, and digestive disorder. I will be focusing only on the surgical diseases. Obese patient has reduced abundance of Bifidobacterium longum, which contribute to glucose and lipid metabolism. Bifidobacterium bifidum contribute to decreasing the weight. Now everybody, good bugs, whenever we are opening the TV, take our phone, we are getting good bugs, take good bugs, I have taken good bug without my diet modifications. So what is this? These are the different microbiota we are instilling into the patient's gut. For type 1 diabetes patients, an increase in Bifidobacterium adolescentis has been suggested to be implemented in diet for nutritional modifications of these diseases. Then there comes the concepts of, from this arises in treatment concepts of probiotics and prebiotics. Everybody, for me, probiotics is lactobacillus only, but it is not true. It is not limited to the lactobacillus. It is Lactobacillus acidophilus, Lactobacillus casei, Saccharomyces boulardii, Bifidobacterium species. These are considered, and I told you there are different drugs. Then what is prebiotics? Prebiotics are non-digestible foods that promote the growth and activity of beneficial microorganisms as well as healthy dietary fibers that are used by the fermentative bacteria. Everyone is saying like that kanji is very good, we are taking rice, soaked it, eat the yogurt overnight and then take it, that fermented food is better, idli is better than the roti. So these are various causes because these have a prebiotic role to play. Then psyllium, everyone knows that increased level of Lachanospira, Roseburia and Faecalibacterium improves the abdominal discomfort, epigastric pain and constipation symptoms. Kimchi, Dr. Gundry is very fond of this kimchi. Increased level of actinobacteria, improved cholesterol levels and insulin levels. Yogurt, everyone knows that it also not only lactobacillus, it are increased level of Bacteroides, Streptococcus, Boletias, Saccharomyces, NK cells are increased, B cells, interleukin 5 and improved constipation and immune system. Then there comes the kefir, that is also more born of lactobacillus. Then in cancer, it will be dealt in detail by my fellow speakers, but I will give you a brief that 20% of the cancer are linked to the gut dysbiosis. Butyrate, I told you previously, is an important nutrient for healthy colon, absent in colorectal cancers. So whatever is producing, decreasing the butyrate is increased in cases of colorectal cancer. There are two hypotheses. One is alpha drug hypothesis and second is bacterial driver passengers. There are enterogenic bacteria by Bacteroides fragilis that disrupt the colonic microbiota. There are inflammatory response like interleukin 17 and tissue necrotic factor alpha. They promote the cancer progressions. There are certain genotoxins like CDT, BNF, etc. They also causes the cell proliferation and mutation leading to the adenoma formations. Here is also a concept of enterotoxins and genotoxins is also there whenever we are studying about the microbiome and microbiota. Then one important role in colorectal cancer is about the bowel preparations. We have so many topics, whether to go for bowel preparations or not, preoperatively for rectal cancers, whether we have to go in anterior resections or when to go for bowel preparation and when to go. There are so many studies are there, even protocols are there. This is first by the Watanabe et al. In 2010. Published a study based on Japanese population. They reported decreased population of Bifidobacterium, Clostridium coccidis, Clostridium leptum, Enterobacteriaceae and Lactobacillus postoperatively. They said that bowel preparation has no impact on the colorectal surgery outcomes. But we used to give it every night. For night we have to give the Peglac, and then morning we have to give the enema to the patient. But no change has been seen in Enterococcus, Staphylococcus population. Causes the reduced level of short chain fatty acids. This resulted in impairment of intestinal bacteria, leading to bacterial translocation and possible infectious complications are there. So there comes the role of miracle trial. I told you that they said that bowel preparation has no role. But what Miracle has done, they have added the probiotics to it. This is microbiota implementation to reduce anastomotic colorectal leaks. This is very troublesome in our surgery parts, that if rectal anastomosis are leaked, then we have to manage it in a different way. So what in Miracle protocol they have used oral antibiotics, mechanical bowel preparation and preoperative biotics they have added. And they have compared 500 patients and there is only one leak in 500 patients. And this shows encouraging results with reduced anastomosis leak, superficial site infection, reoperations and postoperative mortality. I'll tell you that because of this protocol, now Mobile 1 again started to do it, the Mobile 2 trial to add the probiotics and then studies it. Then compositional shift of intestinal microbiome is there in the fecal samples of 43 colorectal cancers as compared preoperatively and postoperatively.
Pushpinder, please make it quick, huh? Running out of time.
Okay, sir. Thank you. There are gastric disorders also. I told you that it is there in the H. pylori infections also. That H. pylori, there are certain bacteria like Streptococcus has also a role in cases of gastric disorders also. So what is there in the gastric disorders? That PPI treated patients have more Streptococcus than patients with normal gastric mucosa. The Takayama et al. Said vancomycin reduced the abundance of actinobacteria and Bacteroides phyla. Then there is also a role, this is stomach, there is also a role in esophageal disorders like Barrett esophagus, gastroesophageal reflux disease and esophageal adenocarcinoma. Then we have this total pathophysiology that is going on, that esophageal microbial dysbiosis induced the esophageal barrier dysfunctions by this interleukin-6 lipopolysaccharide pathway. This will increase the acidic environment and this result in the onset of GERD symptoms. So there is a debate whether this dysbiosis has lead to GERD or GERD has lead to dysbiosis. But I will tell you both are working simultaneously together. Then dysbiosis can lead to GERD and GERD ultimately can lead to the gut dysbiosis also. So this indicates that so many diseases are there that are linked with this gut dysbiosis. Barrett esophagus has an important role, that there is a dysbiotic shift of Bacteroides to Firmicutes, which are also observed in patient taking the high diet. That's why there is a role in obesity also that has been proven. Cholelithiasis is most common operation done in the elective setting, and there is so many gut dysbiosis in cases of cholelithiasis. There is Klebsiella, Rosorella, Coccinella, and Enterobacteria were significantly decreased, and there is an increased in asymptomatic gallstone diseases, Streptococcus, Lactobacillus, and Fusobacteriums. There is a complex relationship between these GIT symptoms, liver disease, and this biliary tract disease that is altered by whenever we are doing the endoscopic sphincterotomy for CBD stones. So what is going on, that gut microbiome is going into the biliary tract and altering these various biliary disorders. So gallstone disease, as the age increases, these are also increasing, but in cases of these cholelithiasis patients, as the age increases, the number of gram-negative bacteria is increasing and positive is decreasing. That is leading to the gut dysbiosis and leading to the cholelithiasis. So I told you in sphincterotomy laxity also, patient with increased phenotypes of family like disulfovibrio. This has more studied in these cases.
Dr. Pushpender?
Then how to prevent it? I'll get only 2 minutes.
Kindly rush through so that the timelines cannot not
sir.
missed.
Yes, sir.
Thank you.
So what is there, that all this dysbiosis has led to the prevention by oral supplementation of nanoscale iron sulfide supernatants, reduced bacterial activity and disrupt biofilm structures, inhibiting the gallstone formation. Lactobacillus species are among the most common probiotics and associated with healthy benefits, including the antimicrobial activity and tumor suppression. The asparaginus polysaccharides have immunomodulatory and anti-inflammatory and anti-cancerous effect in several diseases, inhibit gallstone formation by improving the gut microbial diversity. So it is not only about the surgery, we have to study about whether symptomatic or asymptomatic gallstone, what microbiota we should be looking at. So thank you very much, and sir, I think I have been allotted 35 minutes for my lecture, and it is not 35, it is 30 minutes, and I finished my lecture. Thank you, sir.
Thank you, Dr. Pushpinder, for a nice, lucid presentation. Your topic reminds me of a story, as you said, about toxoplasma. A decade ago, I was just going through recent advances, and I came on a topic saying that in cases of resistant ulcerative colitis, role of fecal microbiota transplant having this Ascaris eggs. So these Ascaris eggs were transplanted and they had definite good outcome even in resistant cases. So it was quite surprising for me when I went to detail. So it was written that, as you said earlier, developed countries were developing countries. That time they had similar infections as we are having, all worm infestation.
Exactly, sir.
Amoebiasis. So that time they didn't have these high-end diseases like inflammatory bowel. They also had worm infestations. Now we are in developing stage. Now later on, when the infections went away, they developed autoimmune diseases. Now we are on the same path. Our children, they are not getting these RO water and all. They are not exposed to these infestations. So the incidence of inflammatory bowel disease increase. So these are the infections. They create a balance in the body and keep us safe from these autoimmune diseases. So you have presented it very nicely. So with that note, I open the talk for discussion.
Exactly, sir. That's why I am focused more on inflammatory bowel disease. There are so many diseases I cannot enumerate. I have totally fixed my time that I will be stopping at 32 minutes. And I think I have stopped at 30 minutes, sir. So, but we cannot include each and every disease in this, but inflammatory bowel disease, definitely, sir, with RO, less exposure to soil. Even we do not walk barefoot nowadays. We do not want our children to play into the soil. There will be infections, but that infection is important for the biodiversity in our gut microbiome, our skin microbiome, our respiratory microbiota. Yes, sir, very true.
Thank you so much, Dr. Pushpinder. You have laid a perfect foundation for rest of the sessions. And on behalf of organizers, I am thankful to organizers also for putting us three together on the stage as co-chairs. And thank you so much for the nice talk. Grateful to you.
Thank you, sir. Thank you very much.
Thank you, Dr. Pushpinder, for your very nice talk, very knowledgeable. You have made us much more knowledgeable. And in a nutshell, I have just understood from your presentation that health is not just regarding the human cells. It is all about the harmony of the microbial ecosystems within us. That is also of utmost importance.
Yes, ma'am.
Thank you so much for your presentation.
Thank you.
Thank you so much, sir, for an enlightening talk. Now time for felicitation. For the felicitation of our speakers and chairpersons, I now request Dr. Jyoti Kaushal, Organizing Chairperson, Medipharmacon, to kindly come to the dais. Dr. Savita Verma, Organizing Co-Chairperson, Medipharmacon. Dr. Sunil, Organizing Secretary. Dr. Janelle Singh, Professor, Pharmacology. Kindly come to the dais for felicitation.
A huge round of applause for our speaker and the chairpersons.
Thank you so much, everyone.
I hope everyone is seated comfortably as we move into the next set of lectures presented by the leading experts in their respective domains.
The first lecture truly highlighted the critical role microorganisms play in maintaining our health and influencing disease outcomes. Dr. Sonal, did that insight expand your understanding?
It certainly did, Dr. Jyoti. I never imagined microbes from that perspective. Tiny creatures all around. In soil, water, they abound. Some are friendly, some are mean. In places we don't even glean. Though small they be, they play their part. Microorganisms, they are truly science heart.
Beautifully expressed. But let's remember, this is just the beginning. Science, after all, is full of surprises. And our next talk perfectly captures how our invisible allies might transform the future of medicine.
From microbes to medicine, our next speaker takes us on an eye-opening exploration of gut's role in cancer therapy. We often call gut our second brain, but could it also be a potent weapon in the fight against cancer?
Who else can explain it better than a pioneer in radiation oncology, Dr. Vivek Kaushal?
To chair this session, I invite eminent experts in radiation oncology. Dr. Rakesh Dhankar, Senior Professor and Unit Head, Radiation Oncology, PGIMS Rohtak. Dr. Harmeet, Senior Consultant, Radiation Oncology, Kainos Super Speciality Hospital, Rohtak. And Dr. Rajiv Atri, Professor, Radiation Oncology, PGIMS Rohtak. I welcome all the chairpersons on the dais.
I now welcome our next speaker, Dr. Vivek Kaushal, ex-Senior Professor and Head, Radiation Oncology, PGIMS Rohtak, to deliver his talk titled Gut Warriors, Microbiota Shaping Anti-Cancer Outcomes.
I I now invite the chairpersons to introduce our eminent speaker.
Very good morning. I'd like to introduce our speaker, Dr. Vivek Kaushal, is MD DNB, is ex-senior professor and head of Department of Radiation Oncology, Regional Cancer Center, PGIMS Rohtak. Dr. Kaushal did his MD radiotherapy from PGI Chandigarh. He was silver medalist, first order, Commonwealth scholar, ex-senior resident clinical oncology, Royal Marsden Hospital, UK, ARI Overseas Fellowships in San Diego, UCLA Hospital, USA, and he's founder, editor of Radiation Oncology for 12 years, and he has around 480 publications. Sir, please.
Okay. Good morning. The topic assigned to me is Gut Warriors, Microbiota Shaping Anti-Cancer Outcomes. First of all, what is the microbiota? The microbiota refers to the trillions of microorganisms, bacteria, viruses, fungi, etc., living in and on our bodies. They may be commensal, mutualistic, or pathogenic. Microbiota refers to the living organisms, while microbiome, on the other hand, encompasses both the microbiota and the surrounding environment, including microbial genome, structural elements, metabolites, and environmental conditions. So, if microbiota are people living in a house, microbiome is the house. It has got some other things along with the people, like furniture, etc. Approximately 40 trillion microbial cells spanning 3,000 species inhabit the human body. 97% of them are bacteria in the colon, 2 to 3% are extracolonic bacteria, and 0.1 to 1% are the archaea and the eukarya. Human cells, what about the comparative size of these? Human cells range from 10 to 100 micrometer in diameter. Bacteria are typically 1 to 5 micrometer. Viruses range from 20 to 400 nanometers. So bacteria are about 1/10 the size of a human cell, while viruses are significantly smaller, about 1/100 the size of bacteria and about 1,000th the size of a human cell. Humans play host to trillions of microorganisms that help our bodies perform basic functions like digestion, growth, and fighting disease. And commensalism and mutualism exists. Commensalism is when two species live together, one benefits and the other has got no effect. And mutualism is when both benefit. Then coming to the intertumoral microbiota are mostly intracellular and are present in the cancer cells as well as their surrounding immune cells. Microorganisms within the TME are very low compared to their gut counterparts. Individual tumors range from no bacteria to nearly 70% bacteria by cell count, but usually it's just about one microbial cell may be found in about 10,000 tumor cells. Gut dysbiosis has already been explained in detail. It happens when the normal thing goes and abnormality happens. Of the estimated 10 raised to power 12 distinct microbial species on the earth, just 11 are labeled human carcinogens or oncomicrobes by the International Association for Cancer Registries. These oncomicrobes, they cause an estimated 2.2 million cases per year, which is approximately 13% of all the cancer cases. The gut microbiota is the most densely populated and most studied community with a major impact on immune function and systemic health. Microorganisms within the gut influence cancer immunosurveillance, cancer development, progression, and response to chemotherapy and immunotherapy. Immune elimination and immune escape are hallmarks of cancer, both of which can be partly bacteria dependent in shaping immunity by mediating host immunomodulation. Mechanisms of microbes in tumorigenesis are inducing DNA damage and epigenetic alterations, interference with DNA damage repair, triggering aberrant signaling pathways, and eliciting immunosuppressive effects. First of all, inducing the DNA damage, bacterial strains isolated from patients with inflammatory bowel disease exhibited DNA damaging activities associated with malignant transformation from IBD to colon cancer. Colibactin, a genotoxin expressed by PKS positive E. coli, can cause colon cancer, and this is also detected in some other bacteria like Klebsiella, Enterobacter, Citrobacter, H. pylori, Bacteroides, Salmonella, etc. So what are epigenetic alteration as a cause of tumorigenesis? Study of changes in organisms caused by modification of gene expression rather than alteration of the genetic code itself is the epigenetic alteration, and these bacteria, they cause cancer because of these mechanisms. Interference with DNA damage response is the cause of cancer by Chlamydia, Trachomatis, and H. pylori. And triggering aberrant signaling pathways, F. nucleatum for colon cancer and Salmonella typhi for gallbladder carcinoma. Eliciting immunosuppressive effects and escape from the immunosurveillance is caused by certain bacteria like F. nucleatum and H. pylori. And certain fungi also can cause it, like Aspergillus fungi, fumigators, and Candida albicans. The initiation and progression of many of the cancer has been linked with the gut dysbiosis. These are gastric cancer, colorectal cancer, hepatocellular carcinoma, breast cancer, pancreatic cancer, and gallbladder cancer, etc. So, for knowing the mechanism of the association between gut and the cancer, we have to understand the immuno-oncology microbiome axis. Gut microbial metabolites and byproducts influence host lympho and myelopoiesis, including during allogenic stem cell transplantation and during radiotherapy, and certain byproducts, they can save us from the side effects of radiation therapy. Enterococcus hyrae, a gut bacterium, has been found to enhance the efficacy of cyclophosphamide in cancer treatment, particularly in animal models. Gut translocation of bifidobacterium species or its antigens can increase anti-tumor immunity. Microbes within the tumor microenvironment can be either immunosuppressive or immunogenic. Gut microbiome has the potential to be used as a biomarker for cancer diagnosis, cancer prognosis, and cancer therapy. And we can know which patient would be recurring and which patient would not be recurring if we have got the complete picture of the gut microbiome. Opportunities for microbes to impact cancer care are diagnosis. Cancer-specific blood-borne microbial DNA may complement cell-free tumor DNA. Prognosis can be assessed by gut and intratumoral microbiota. They may stratify patient outcomes. And therapy, intratumor injection of CD47 nanobody producing E. coli may create systemic anti-tumor immunity. TP53 mutations can indicate host cancer status for cancer microbiome diagnostics, but this implicates more than 25 cancer types, whereas Streptococcus gallolictus bacteremia can reflect host cancer status and type based on its gastrointestinal origin. So, gut microbiome helps to detect colorectal cancer. Contribution of microbes from different dimensions in cancer development are contact development, direct contact with the microbes, or non-contact development through outer membrane vesicles circulating in the blood. Lipotecoic acid and deoxycholic acid, a cell wall component and a metabolite of gram-positive gut bacteria, promote the development of hepatocellular carcinoma. Mechanisms of microbes in tumor suppressive effects are direct tumor suppressive effect by certain bacteria like Clostridium, Pseudomonas, Salmonella, Clostridium difficile, etc. They generate certain toxins that can display anti-cancer activity, and then there are positive immunoregulatory effects based on the cancer-preventing effects of the gut microbiota. 11 bacterial strains have the potential of microbes for cancer therapy. Typical cancer-promoting microbes are Helicobacter pylori for gastric cancer. It has been identified as a class 1 carcinogen by WHO in 1994. Fusobacterium nucleatum for colon cancer, Bacteroides fragilis for carcinoma of the colon, and Epstein-Barr virus, which was the first virus to be associated with cancer for lymphoma, gastric cancer, and esophageal carcinoma, etc. Cancer-inhibiting bacteria are Lactobacillus, some of the species of it, Bifidobacterium, Faecalibaculum rodentium, and Streptococcus thermophilus. Then there exists cooperative or competitive relationship among microbes in cancer development. Like Fusobacterium nucleatum and Streptococcus gordoni have the cooperating relationship, while carcinogenic microbes can be antagonized by some of the probiotics. For example, Bifidum strain BF1 can suppress the expression of H. pylori-induced cancer. Targeting the gut microbiota in clinical cancer treatment, the gut microbiota can be regarded as a special organ. Its composition can be modulated in various ways. Strong correlation exists between gut microorganisms and the anti-cancer treatment efficacy, can reduce therapeutic toxicity of anti-cancer therapies. Antibiotics decrease the efficiency of several types of cancer therapy, chemotherapy with platinum compounds, and immunotherapy with CPG, because microbiota was depleted with antibiotics or when experiments were done in germ-free animals. So a healthy gut is needed in most of the cases to have the normal response to anti-cancer treatment. Cancer immunotherapy, including immune checkpoint blockade, appears to have heterogeneous therapeutic effects in different individuals, partially attributed to the microbiota. The gut microbiome and cancer response in immune checkpoint inhibitors is a topic which is very popular with the researchers. These are the immune checkpoint inhibitors, and their date of FDA approval, and these work better if there is a normal gut. So gut bacteria that promote response to ICI in preclinical models have been listed here in this slide. Coming to cancer immunotherapy, L-rhamnosus stimulate the anti-tumor activity of PD-1 immunotherapy, and Bifidobacterium plays anti-tumor roles by inducing the maturation of the dendritic cells. And gut bacteria definitely influence effectiveness of a type of immunotherapy. Modulation may alter the efficacy and toxicity of cancer chemotherapeutic drugs, 5-fluorouracil, cyclophosphamide, irinotecan, oxaliplatin, gemcitabine, methotrexate, etc. Gemcitabine, gamma proteobacteria metabolizes gemcitabine to inactive form. So if that is present in the gut, gemcitabine effect would not occur. So sometimes antibiotics against gamma proteobacteria are given along with gemcitabine to get the better effect, whereas cyclophosphamide is dependent upon normal gut to have its effect, because germ-free mice would not respond to cyclophosphamide, and Enterococcus and Barnesiella can restore its anti-tumor efficacy. Erlotinib is dependent upon Bacteroides species for its effect to occur. Oxaliplatin butyrate, a product of dietary fiber fermented by gut microbes, increases the anti-cancer effects of oxaliplatin. Coming to bidirectional relationship between gut microbiota and radiotherapy, RT kills cancer cells, but we know it has got some side effects. It causes gut dysbiosis, decrease in favorable microbes like Bifidobacterium, and increase in harmful microorganisms such as Fusobacteria and Proteobacteria, which leads to radiation-induced enteropathy. Working on mouse models of breast cancer, Shio et al. Found that depleting the gut bacteria with an antibiotic cocktail before radiotherapy resulted in faster tumor growth and shorter survival of tumor-bearing mice than RT alone. So RT effect is better if there is normal gut microbiota. So there are many publications which substantiate that. Protection against irradiation-induced hematopoietic injury. Microbiota-derived compounds can protect against irradiation-induced hematopoietic injury through production of propionate and tryptophan metabolites and release of MAMPs, which is microbe-associated molecular patterns known to maintain bone marrow-derived myeloid cells and neutrophil function. So radiation-induced neutropenia, which is a problem in clinical practice, can be countered by this. And this is the MAMP's mechanism of the immuno-oncology microbiome, which has been shown earlier, which can protect the bone marrow from the effects of radiation. So health of the gut microbes has got a better effect even after the bone marrow transplantation. And one multi-center, multinational clinical trial has demonstrated that high diversity of intestinal microbiota is significantly associated with lower patient mortality following allogenic hematopoietic stem cells transplantation. Abiraterone efficacy in prostate cancer is also dependent on the presence of the normal gut, and these are the bacteria which are responsible for that and for its effect to occur. Then what is the role of gut microbiota in the therapy-related side effects? Immune checkpoint therapy can cause severe colitis. Probiotic lactobacillus cures it. Irinotecan can cause gastrointestinal toxic side effects. Probiotics like E. coli strain Nissel 1917 prevents it. Radiation therapy, probiotics can reduce side effects of radiotherapy. Probiotic L. rhamnosus and probiotic VSL3, a probiotic preparation of bifidobacterium species Lactobacillus and Streptococcus. Then coming to the role of gut microbiota in oncosurgery, it is usually complicated by postoperative complications, which are surgical site infections and anastomotic leaks, which are Bacteroideaceae and Lachnospiraceae families. The question is there any kind of commensal microorganism that can promote anastomotic healing and prevent surgical site infections? Probiotics, some strains of Lactobacillus and Bifidobacterium are capable of inhibiting postoperative infections. What are the current and emerging microbial interventional therapeutic strategies for cancer therapy? Fecal microbial transplantation, microbial consortia and probiotics, targeted antibiotics, bacteriophage-based strategies, diet and prebiotic strategies, nanotechnology modulation of the gut microbiota for cancer therapy, spore-based anti-cancer strategies, and cancer microbiota in clinical trials. So that would be discussed. So first of all, coming to the fecal microbial transplantation, it is the transplantation of the functional flora of the healthy donors into the intestinal tract of the recipient for the purpose of treating diseases, first used to treat severe diarrhea more than 1600 years ago in ancient China, when the Chinese doctor issued a prescription called Huanglong soup. So the carry-home message of the talk is, if in China somebody offers you Huanglong soup, don't drink it. In fecal microbial transplantation increases favorable microorganisms, Ruminicoccus and Bifidobacteriaceae, improved clinical response in malignant melanoma, decreases immune checkpoint inhibitor-induced colitis, decreases tyrosine kinase inhibitor-induced diarrhea in renal cell carcinoma. So fecal microbiota transplant helps patients with advanced melanoma respond to immunotherapy. And the current status has shown that a lot of studies are going of fecal microbial transplantation, and the summary of studies is given here. Most of the studies are experimental studies, some are randomized controlled trials, some are observational studies, and some are case reports. And fecal microbial transplantation factors that influence success are either recipient related or donor related or technique related. Then some of the researchers are scared that if we do FMT, then even pathogenic strains would be given to the person who is receiving the transplant. So why not give defined microbial consortia and probiotics? A consortium of 11 bacterial strains from the feces of healthy donor was isolated and found to enhance the therapeutic effects of immune checkpoint inhibitors. In metastatic renal cell carcinoma, patients treated with immune checkpoint inhibitors, a bifidogenic live bacterial product, were found to have significantly longer progression-free survival and higher response rate. Probiotics, as has already been told in the morning, are the live organisms that provide health benefits by improving or restoring the microbiota in the gut. A probiotic compound consists of 4 strains could significantly improve the prognosis of gastric cancer patients having gastrectomy. Probiotics can reduce cancer treatment-related side effects, but these should not be given indiscriminately because one study has shown that it can decrease the response rate in melanoma. Prebiotics are the molecules that promote the growth of beneficial microbes such as resistant starch, inulin, and mucin. They improve anti-tumor immunity and give better response in melanoma and colon cancer. Carefully selected antibiotic regimens could indirectly exert anti-cancer effects and reduce complication during cancer treatment by targeting oncogenic or pathogenic organisms. Then there are bacteriophage-based strategies. Modified phages with irinotecan-loaded dextran nanoparticles inhibit Fusobacterium nucleatum, playing a role in the tumorigenesis of colorectal cancer, enhance the efficacy of chemotherapy drugs for colorectal carcinoma. Then diet strategies are available because dietary intervention is an indirect and a more moderate strategy than fecal transplantation. Relevant dietary strategies include fasting, mimicking diets like cyclic fasting, low carbohydrate diet, calorie restriction. These can shape anti-cancer immunity in cancer patients. High fiber diets and ketogenic diets are very useful in cancer patients. So high fiber diet can be very helpful in melanoma patients and it gives better response to immunotherapy. And so this is strongly associated with the reduced occurrence of many types of cancer. Ketogenic diet suppresses colorectal cancer through the gut microbiome long-chain fatty acid stearate. Nanotechnology modulation of the gut microbiota for cancer therapy has also been tried. The membrane of the Helicobacter pylori has been used to fabricate a nanoparticle which could compete with H. pylori to inhibit pathogen adhesion. Yeast cell wall have been used to create nanoformulations that could suppress tumor growth. Spore-based anti-cancer strategies are available. Spore now refer to specifically to the dormant body of the bacteria and the fungi. The dormant spores of Bacillus coagulans can be used as better drug delivery system. It can resist the harsh acidic environment of the stomach. Then Clostridium butyricum spores are very useful as an oral drug delivery system for chemotherapy because it has got anaerobic nature. So we know in radiation therapy that cause of recurrence is the hypoxic areas of the solid tumors. So these spores can reach those hypoxic areas and can complement radiation therapy when chemotherapy is given with these spores and leading to more cure rates. And they decrease the side effects of chemotherapy because drug is released near the tumor. There are 2 types of clinical trials going on for the manipulation of gut microbiota in cancer. One is to improve the therapeutic efficacy, and second is to reduce therapy-related toxicity or side effects. The study design for characterizing cancer-associated microbiota and their functional impacts are very complex. Multi-site sampling is needed. We need the blood samples, we need the fecal samples, we need the tumor samples. Then multi-omic, multi-kingdom data generation is done. Then experimental validation of the hypothesis is done. So engineered microbes as cancer drugs have also been used in preclinical models and shown to be useful. And these genetically engineered versions are of Escherichia, Bifidobacterium, Listeria, Shigella, Clostridium, Lactococcus, Vibrio, and Salmonella species. Cancer therapy using exogenous bacteria, microbiota, some such agents have FDA approval, like oncolytic viral therapy for advanced melanoma using the T-VEC drug, and bacterial cancer therapy for high-risk non-muscle invasive bladder cancer, which is the BCG vaccine. Future outlook is that now we are seeing a new discipline, which is oncologic pharmaco-microbiomics, which explores the relationship between the gut microbiome and cancer treatments, aiming to personalize cancer therapies by understanding how the microbiome influences drug efficacy and toxicity. So this is a paper published in the Lancet February this year, which has given the guidelines for the international consensus statement on microbiome testing in clinical practice, because everybody was doing it according to their own protocol, and there was no standard international protocol how these studies should be conducted. So now this problem has been solved by this publication. So to conclude, therapeutically targeting the microbiota composition may provide new tools for cancer prevention and treatment and for improving therapy efficacy. Diet-based interventions, prebiotics, probiotics, targeted antibiotic approaches, and fecal microbiota transplantation, etc. are feasible, yet their full potential is yet to be explored. Many challenges remain for now in microbial modulation therapy in cancer, yet future is promising. The biggest hurdle is still unidentified taxa of bacteria and the corresponding genetic levels at which they act. Thank you very much.
Thank you very much, sir, for a very insightful presentation. It was wonderful. You have wonderfully presented the role of gut microbiota in causation and treatment of cancer. I would like to invite any comments or questions from the audience.
Indiscriminately use. So how to decide actually the proper use of this? During the active phase of the treatment, or once patient recovered from the treatment and then it should be used? Because these cancer drugs are highly, you can say, toxic, and during that phase can decrease the count, this resulting into this activation of this gut microbiome from the non-pathogenic to pathogenic actually. So when to use, what should be the appropriate use actually? That is.
Till date, most of the studies are experimental studies which have been conducted in germ-free mice. For example, cyclophosphamide, if it is given to germ-free mice, then it would have no effect on cancer. And gamma protobacteria can disintegrate or make gemcitabine into inactive form. So this is also an experimental study. So at the moment, most of the data is experimental studies. This is being taken to the clinical level in some of the randomized studies, but as I had shown, randomized studies are very minimal until we get complete results from that. So this is a new tool for the cancer physicians to treat the patients, but till now we don't have any guidelines that these things should be given.
Okay, sir. Thank you.
Because if you look at the Ayurveda, everything is pitta, and something is going wrong in your abdomen, and that is what is responsible for the responsible for the various disease processes, and that's what we are looking at it even in the intensive care units. One of those, when we find a cryptic sepsis, not site, most of the time it is the gut which is the source. Same way we are looking today at inflammatory bowel disease. Similarly, if you start looking at it, whether it's a gluten enteropathy, IBS, so many other things which even to that extent, Alzheimer's and all, everything now is being put to gut microbiome. So I think somewhere we have been, can we manipulate it or can we do it for the cancer prevention rather than treatment? What's your viewpoint on this?
Well, it has been established beyond doubt that a normal gut is if it is there, then the chances of cancer occurring would be very less, because this has been corroborated by the experimental studies. Regarding the ancient wisdom of Ayurveda, or as I told that in ancient China they used to do the fecal transplant, Huang Long soup they used to give for treatment of severe diarrhea which was not controlled by anything else. So ancient wisdom we must keep in mind. We must corroborate it by the new studies, and then we should take into the daily practice. That is very correct that there are many things in Ayurveda which are correct, which are not yet fully established by the allopathic medicine. But because I am not an Ayurveda expert, so I cannot say much on that. But it's an area which should be explored scientifically, that has got a lot of potential. Correct.
It is because colonic cancer suddenly we are seeing it happening in the people who are young. And one of the things in the Western countries today, they are talking in terms of the pattern and change in the diet, which is responsible. Obviously, host pathogen interactions are going to be important, but nevertheless, this is something. So probably diet, besides cardiovascular disease we are talking about, may have to do much more. And yesterday I was reading the news reports. And here itself we are reporting around about 5,000 cancers a year. You know it's better. But 60,000 reported cancers in Haryana in a year. I think somewhere the diet or other things, it is important, and that is where gut microbiomes become far more important now.
That's very right. We have a committee had gone comprising of me, Dr. Gehlot, and Dr. Karwastra, because in one village it was reported that cancer incidence is very high. So we stayed there for 2-3 days and did all the studies and found that the incidence is not higher than the national incidence. But Dr. G.K. Rath, who was head of AIMS, he was very fond of showing a slide. He showed that in 1930, the average age in Indians were about 30 years, because most of the patients used to be die by diarrhea, dysentery, plague, or cholera, etc. But now the average age has gone to about 69 years. So because we have controlled most of the infections, then it has become apparent that cancer has come as a cause of death. So that also is one of the reasons, because the average age has increased, and previously we did not have the time that for the cancer to develop. Patients used to die much earlier. Average age of death was younger. So that also is one of the reasons. But there is no doubt that a gut microbiome healthy can control cancer. Thank you.
With this, we conclude this session. Thank you very much, Dr. Vivek Kaushal, for this lecture. Thank you.
Yeah, I just want to comment one thing. That yesterday when I was going through this microbiome, what Dr. Dhruv has said, same came to my mind, that it is all like the Ayurvedic treatment. But now I can say that Ayurvedic, there's no evidence is there. They say we should take खट्टा मीठा साथ नहीं लेना, रात को ये नहीं खाना, सुबह ये खाना है, इतने दिन की फास्टिंग रखनी है, and all that in an indirect way affects the gut microbiome. But now I think with this allopathic we are trying to prove the things in a scientific way. So that will be proved in the scientific way. We are just isolating definite microbiomes and doing the studies like the Dr. Vivek has already said 11 are very useful microbiomes which can be transplanted. I don't know the name because they're very difficult names to remember the names of these microbiomes. But yes, he told the 11 are the beneficial one and very few, 12 are only the hazardous one which can cause the cancer. So that Ayurvedic, that might be in the way that promote the beneficial microbiomes and other one are decreased. So very right, and it's a very good initiative. Congratulations, Dr. Jyoti.
Thank you, sir, for such a thought-provoking session. To extend the token of appreciation to our speaker and chairpersons, may I request Dr. Jyoti Kaushal, Dr. Savita Verma, Dr. Sunil, and Dr. Vivek Sharma to please come to the dais.
Please give a huge round of applause.
Thank you, everyone.
Dr. Sonal, does the very mention of superbugs still evoke a sense of alarm?
Indeed, it does, Dr. Jyoti. It's a reminder that while the microbiome holds great promise, we are still learning how it can help us tackle global threats like antimicrobial resistance.
Let's now begin our session 2, comprising of 3 impactful lectures.
As the global medical community faces the rising challenge of antimicrobial resistance, innovative solutions are more urgent than ever. Our next distinguished speaker, Dr. Dhruv Chaudhary sir, will address a topic of critical global relevance, superbugs and the potential of microbiome.
To chair this session, I invite accomplished experts from diverse fields. Please welcome Dr. S.K. Dhattarwal, Senior of Forensic Medicine, PGIMS Rohtak. Please welcome Dr. Sudhir Atri, Senior Professor and Unit Head, Department of Medicine, PGIMS Rohtak. Dr. Vivek Malik, Professor, Department of Anatomy, PGIMS Rohtak.
This talk will highlight how the microbiome offers exciting opportunities for microbiota-informed innovations in the battle against resistant infections. We are honored to welcome Dr. Dhruv Chaudhary, Dean Academics Affairs and Senior Professor and Head of Pulmonary and Critical Care Medicine, PGIMS Rohtak, to the stage. Welcome, sir.
Although Sir hardly needs an introduction, but going with the protocol, I now request our chairpersons to formally introduce our renowned speaker, Dr. Dhruv Chaudhary.
I think Dr. Dhruv Chaudhary needs no introduction. He is a person who can speak on any topic. But formal introduction, he is at present Dean Academic UHS Rohtak plus Professor in Charge Research UHS Rohtak. He is President of Association of Commonwealth Scholars and Fellows of India. He is past President of Indian Society of Critical Care Medicine. He is Chairman of Ethics Committee, Central University, Haryana. Plus, he has been the chair and member of various task forces. Regarding the award and achievement, he has been given FMS award, multiple orations of various professional bodies, Commonwealth Fellowship in Pulmonary at Liverpool, UK in 2009 and 10, plus Hansraj Nayyar Award and many other awards. He is having around 154 publications, 55 chapters in many in books, plus he is editor of 4 books. He is editor and textbook of critical care medicine, and he is co-editor of postgraduate medicine 2023. Welcome, Dr. Dhruv.
Thank you, Dr. Dhatrawal, a colleague, a senior in the college, and like an elder brother. Also, Vivek and Sudhir, and both of them have, all 3 of them actually are distinguishing themselves in their fields, my colleagues and friends. First of all, I am thankful to Professor Jyoti Kaushal, Savita, and Sunil for giving me this opportunity to come and discuss about it, because it helps me reviewing it, what we are knowing it, because that's what we are trying to do and work through Sepsis Forum of India at different levels. But this was something which I looked at it critically and discussed with my colleagues throughout the country. We were missing into it. And it is a problem which we are all talking about. And if you today look at the sustainable goals, which have WHO has come up, this is one of the sustainable goals where we are talking about antimicrobial resistance as one of the things which can actually wipe up all the advantages which we had developed over years, which Professor Kaushal also talked about in terms of longevity, in terms of good health, in terms of reduction in infant mortality. Everything will go away. If one thing which modern medicine has given us is the antibiotics. And the consequence of that, what is happening is we are realizing it gradually, everything going down the drain because of the development of antimicrobial resistance. And obviously the life expectancy, he said, in the world it has also increased up to 73. In India now it's around 71. And obviously the women are living longer than the men. And one of the major reasons besides the nature selection has been taking care of now the maternal mortality which used to take place earlier. And today because of the taking care of tetanus and purpurine sepsis, because that is the way the second age we used to say, we are finding much more life expectancy even in the ladies also. And they are actually living and outsmarting the men, and in fact they are the real stronger sex and gender. Still, all said and done, throughout the world with the WHO data, 1 in 5 deaths are caused by infections. And if you really look at it, if you look at low-income country, in India so varied, right, starting from the thing you will see in South Delhi, South Mumbai, you will see in Gurgaon, or you may see it in Bangalore, right up to the villages which we are seeing. And it's unfortunate that like today, 3 patients with me in the ICU are of the tetanus. So which was, we are seeing now 8 tetanus patients in last 8 months, which we have not seen in between. So probably there is a recrudescence of infectious diseases. Same thing we are seeing, we saw the small little epidemic of diphtheria among the pediatric, and we saw a few doctors getting involved in Mewat. Therefore, all of us have gone through the pandemic of the COVID, and earlier we had again a pandemic of influenza. So multiple things are there. With the onset of the summers, diarrhea is also not uncommon. And I have not seen amount of pneumonia which we saw this time, and severe pneumonia which has come up, and there the bacterial pneumonia associated with fungal pneumonia, and I think Sudhir is sitting there and other colleagues there. What we are also seeing, that uncontrolled diabetes which has come up, and whether it is a COVID which has to do more diagnostics which has to do, or there is an alteration also occurring within the body as a result of dysbiosis which has taken place because of COVID, causing and precipitating higher incidence of diabetes, somewhere an immune defects or immune dysfunction leading on to it. We don't know, but this is something area which we intend to look at it. Now when you start looking at it, you have a viral fever, what all of you do. How many of you, when you have a viral respiratory infection, pop azithromycin? Anybody can raise the hand, don't shy of it. Everybody is shying it, but the data shows nearly 2/3 of the people do it. The day one the people come to us, Sudhir will also let you know, sir, we have taken the azithromycin, but it has not sorted out. How does an antibacterial work in antiviral? A common person says it's fine, I can understand. But when our own colleagues who have done MBBS, who have done this thing, if they talk about it, it means there is something wrong somewhere. And what is the consequence? What is happening? We all love our chicken, large number of people, Khasar Punjab, kukkad, everybody likes it. But without realizing how much is the antibiotic used in the poultry. Similarly, they're looking at the growth promoters. Same thing is happening in the arms of food chains. Therefore, it is very important for us to understand. That's why the concept of One Health has taken place, which unfortunately the medical profession are laggard and not very happy to take up, because our health is intimately related with the environment. Therefore, health, sometimes they say, to the charging of my colleagues and friends, that health is too serious a business to be left to the doctors, because it is a multifaceted things which we need to look into it. And when we look into it, you realize what harm we have caused it up. And the harm which we have caused it, I still remember Professor M.C. Gupta teaching us antibiotics. They used to talk to us in 8s about tetracyclines. They used to talk to us about sulfonamides. I find sometimes that the younger generation, when we talk about it, now it has acceptance come in a scrub and other things, they look up to you with a disbelief, what are we talking of? Because they have not seen it. Seeing is believing. And what is the consequence of it? What is it is happening is that we are seeing drug-resistant organisms. I do remember doing a study along with Professor M.C. Gupta about antimicrobial resistance in intensive care unit with the Vidu, who is now the Associate Professor of Cardiology at Mayo Clinic. What we found at that time, she was doing an MBBS with us. At that point itself, I could not depend in 2008 and 9 of single drug. That was at that time third generation cephalosporins, which practically in intensive care unit where I practice are not possible to use today alone. So you need to have something top up to it where we use beta-lactam inhibitors, and there also I'm not very certain of. I go to any corporate hospital, they won't like to use aminoglycoside because they're not got trained. It's very toxic. Every day we are using it up with good results. So a lot of misinformation, etc. is there, but primarily point I'm trying to make is that with the use of these indiscriminate use of antibiotics by us, in poultry, by veterinarians, the consequences that these drug-resistant organisms are there, and the place where I practice, that is intensive care unit, is pain in the neck. I don't know which antibiotic I need to use, and we are getting into the area of pre-antibiotic era, where all the things which have been done till now have been lost. You come to us, we did one study with the Department of Microbiology, and looking at it, how much from the community we are getting it up. We did the anal swabs of the patients who came to us in the intensive care unit day 1. Out of the 89 patients where we did the swabbing, you will be surprised 39 were having drug-resistant gram-negative bacteria in their stools on day 1. If I put it up 90 to 39, practically 40% of your cases which are coming on day 1 itself, you are getting a drug-resistant bacteria, and this is to carbapenems. You also have to other beta-lactams which are anti-pseudomonal. So you can look at the rampant thing which is there, and it is your gut where you are coming through, passing through. And the data again which came up in the light of NDM study which was published in Lancet in 2010-11. And I saw Dr. Madhu, she was there, she was part of that, and she faced a lot of harassment because of that. I have no harm in saying it, but what they said the truth. They found out later on that is where the NDM New Delhi metalloproteinase disease came up, and then along with it, what we found out when they did a study in the water of the sewage water of Gangaram Hospital, it was full of bugs which were drug resistant. So practically carbapenem has become useless for us as a first-line drug, which were the saviors for us in extended spectrum beta-lactamase inhibitors. And this is nobody else has done. This is the environment has done. This is we have done it, and we have to accept it. Why I am speaking? Because this is how the superbugs have been formed. And the superbugs are the drugs which are the bugs which are resistant to all traditional medications. Today, for me, the choice of drug when NDM comes are very limited, and I am left only using either ceftazidime, avibactam with azithromycin, or most of the time we are using polymyxins, which are the old drugs having their own toxicity. So my dear friends, why I am saying so is these superbugs are no longer a theory. It's a reality, and we are dealing it for so many years, and we are looking at it, what they do. If you see today, we are finding it up in 2010, 1/5 of the patients had it. Today, we are looking at in our ICU, practically anything Acinetobacter, which we call as a crab. Why we call as a crab? It is a carbapenem resistant Acinetobacter baumannii. Practically 90% of them is coming resistant to meropenem or carbapenem. 75% it is resistant coming to piperacillin tazobactam. 80 to 90% it is coming resistant to aminoglycosides, quinolones practically 100%. So what drugs are you left with? That is one thing which is extremely important. And you look at the cost to the economy. It is going to cost you 100 trillion of economies in terms of the numbers of death. It is going to increase by 10 million or 1 crore extra death because of drug resistance which we are seeing today. And these are not the problems. And when you see it, 1/4 of the patient, this is the WHO data coming from across. But when I look at it in my own country, we wrote a paper how our bugs are different from the West, wrote with Brajesh, and we found out our 95% of our problem is coming from Enterobacteriaceae. And in that you will have a Klebsiella, you will have a E. coli and non-fermented Acinetobacter and Pseudomonas. That is what we are looking at. So these are the common type of superbugs. In gram-negative, you have, basically I talked to you about the crab and the carbapenem-resistant Enterobacteriaceae and carbapenem-resistant Acinetobacter baumannii. On the other hand, when you see in the gram-positive, it is MRSA, that is methicillin-resistant Staphylococcus aureus. That is very important. My daughter had some small little problem in UK. The drug which was given to her was amoxicillin, or the flucloxacin. That's what they did it. Here, if it would have been there, we were given with amoxiclav, etc., 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 because this would not have acted otherwise. The drug resistance pattern in UK is less than 5%. And as a doctor, when we try to control it, nobody likes the control. So self-discipline is the key, which unfortunately, less is said, the better it is. And the other drugs which are becoming more and more important, it's not only mycobacteria. We are seeing CRE, that is, we are seeing also resistant enterococcus, which is coming up, which is not responding to aminoglycoside. The only drugs which you can use is either vancomycin glycopeptides, or you can use, in these cases, teicoplanin or linezolid. And linezolid today is a reserve drug for the TB that practically also gets out unless you rule out TB. Then along with it, we are also seeing number of other drugs which include fungi, which we are seeing it, Candida auris, even the Candida albicans has been replaced by these things. And the net result is we are living in an area, in a time when we are, where you cannot a single drug, you can be confident, especially in the sick patients. And that is what we are facing in terms of it. Similarly, this Neisseria gonococcus, there was a rampant surge of it, localized pandemic though in Europe. I think it's important for us to do it. And when you use antibiotics, chronic diarrhea, which persists, or during acute care itself you get a diarrhea, which is blood stain, which could be mucus stain, or which may be otherwise also. The drugs which you commonly use as a clindamycin, you use in these patients also. Doxycycline, if you are using it up, or you are using other beta-lactam inhibitors, or carbapenems, you do get a diarrhea. Antibiotic, if it is not, look at the pus cells if they are present. We always look for C. difficile toxins, which again is an issue. And that is where I will talk about fecal microbial transplant, which Dr. Kaushal spoke about in the Chinese thing, where we are using a normal flora to treat it. Now, these are Indian priority. I think I've already talked about it. It's Enterobacteriaceae, it is Klebsiella and E. coli. You can see it. We are seeing now a resistance even to tigecycline, which is a fluorinated tetracyclines. Colistin is the one which we use, which is a polymyxin E, but again there is a resistance. Then obviously high priority for us are Staphylococcus, Enterococcus, and also you will see salmonellosis. And what we are finding it up is that initially they were sensitive to cotrimoxazole, they were sensitive to chloramphenicol, sensitivity is there. But nevertheless, people are scared to use it, but we are not scared because in our era we used to use a lot of chloramphenicol, which was there. And in this case, we are finding they're even becoming resistant to third generation cephalosporins. Sensitivity to the old drugs is coming back. That's an interesting phenomena I shall be discussing little later. And CDC categorization is urgent. Again, they are looking for the crab, they are looking for the Candida auris, Clostridia, and then again CRE, that is what we use it called as the carbapenem-resistant Enterobacteriaceae and Neisseria gonorrhoeae. And also along with it, you need to look at it, Campylobacter. And you must have heard recently that there was an epidemic in Pune of infective polyneuritis or LGB syndrome. It was all related to Campylobacter, and this was a Khadagwasala dam from which it was spilling over. They were getting the water in the water tankers, putting into a tank. in a local well from where they were taking it up, and it was full of it. And that's how Campylobacter jejuni, because it altered the microbiota of the gut and was responsible, which overcame up and leading on to where you have a molecular mimicry leading on to infective polyneuritis. And this whole concept of finding out the disease fits very well with the One Health. Veterinarians have taken a lead, and I am happy that our community medicine is talking about, but for the zoonotics, Madhu has taken a lead and doing a good things in this part of the country. Now, how antibiotic resistance happens? Basically, what you find is there will be inherent resistance always is there, what is called as the innate resistance. But when you put them into the antibiotic pressures, two things happens. You kill the normal flora, and at the same time, because somebody, if you put somebody against the wall, has to find out tactic to survive. And that's what they do it, and that's what happens. And then you start seeing it because the continuous use of this antibiotics, which is killing them, the local microbiota, these ones who have got now the resistant to survive. Every nature has three things for every human being, not for the human being, for all the things which have the life. They have to feed themselves, they have to recreate, they have to procreate. So procreation is survival of the fittest, the Darwinism comes into play. And that's exactly what is happening. And then what happens is, then there is a crosstalk between the bacteria, and all of us has read in the third year to us taught by Dr. D.R. Arora and Madam Sabharwal, and I think now and all talking about how the horizontal transmission takes place of the genes which are responsible, which could be basically through the plasmid mediated. That's what we have been saying in eukaryotic cells. And it is very important for us to understand why it is happening. So the net result is then this plasmid related, you can have a genetic direct, you can have a horizontal, all these things can happen, leading on to working on different mechanisms causing drug resistance. Now let's shift gear and come to microbiome. Already Professor Kaushal has talked about it, but let me look at it. It is a combination of, it is a sandhi of micro and biome, which refers to what? What is the habitat of organisms? What is the genomic sequencing? And what are the environmental conditions in which they are there? And we are not only talking about the gut microbiome. In my respiratory medicine, we are all talking about looking at it, what is the microbiome of a respiratory system? We think it is sterile, but now the new molecular techniques are there, the new sort of organisms are being found which line it and ensure its healthiness. If it is not there, you start colonization with Pseudomonas, you start getting colonization with Staphylococcus and other ones. That's what you see in bronchiectasis. Besides other things, that it tends to persist, causing recurrences, and that's what you see also in AECOPD. Similarly, you said that the upper airway and the nasopharynx, you may have Streptococcus, you may have other organisms, H. influenzae. When they go into the lung, they go into the tracheobronchial tree, they cause pneumonia and tracheobronchitis. That's what we see. So in these cases, looking at it, one genome you have got, the second genome or other genome, what we see and what we talk about today in medical terminology is of the genomes which are of the floras which we are inhabiting in our body, our skin, in our nasopharynx, in our gut. That's fundamental. And if you see it is usually said that 97 plus of our DNA is nothing else but is a microbial DNA. It gets intertwined and gets become part of our DNA, though majority of them may be silent, and that's why you see molecular mimicry, where you have a cross-reactivity of antigen leading on to autoimmune disorders and also neurological disorders. So Human Microbiome Project Consortium was done. They found out human faces contain more than 4,000 species. Earlier it was considered more than 10,000 species is there. You can have in a buccal mucosa, you have more than 750 species. In anterior nares again, you see so many number of microbiomes which are there. Even within the gynae itself, in the vagina, in the posterior fornix, you are seeing 255. Now vaginosis is being labeled as a STI because you alter the flora of these. What they do, they maintain the local milieu and homeostasis. And one of the reasons which I very strongly felt always was that the black fungus of the mucor which happened post-COVID was because of alteration of local microbiota besides use of anything else. because that alters that pH, that alters the environment, and that lead to more production of fungal spores. They got germinated and we had that disease, and that's what it shows. Similarly, meta-analysis revealed 3.3 million microbial genes in human feces. Look at the amount of genetic pool which is there, and we have never ever looked at these things, and we are all talking about it. And obviously 150 times more than the human genomes of 23. So you are overpowered by these microbiomes, and we think they have no role in the life. Answer is no. If you have a deficiency, what you get? You all get fat absorption, vitamin deficiencies. So you need to give vitamin K. Why you give vitamin K? Because child doesn't have it, that kind of neonate doesn't have it. After that, the body picks up. If you have a fat malabsorption, you get all fat soluble vitamin deficiencies. That means all these things have an important role to play. So let's look at a human microbiome. It is in the gut, it is on the skin, it is in the mouth, it is in the vagina, and you will see person 1, person 2, and this is a prevalent microbial taxa, which we unfortunately, this won't work it up, but if you see it from here, give me a minute. Yeah, if you see it there, this will, you will see in these persons they have mixed pattern, and this is the prevalent microbial taxa which we see. And then when you go up further, in all body sites, broadly they will be responsible for enzymes, they are for metabolite pathways, and that's how they maintain the local milieu. If you disturb them, what will happen? Obviously, somebody has to come and replace. Nature never keeps things wicked. And when the other thing starts coming up, they change, they altered the milieu of that place, and the diseases which we are trying to see, and the emergence of superdrugs which we are taking place. So this is, how many of you heard of this Otto-Breri syndrome? This is something interesting. This is all related with microbiomes. It has been a story after story where you are seeing that people have been brought to the casualty in a drunken state. Dr. Dhatrawal, you must be quite interested in as a forensic person. If somebody comes to you with an alcohol in the OPD or in the casualty, doesn't mean he's an alcoholic. And what did you find? That there has been an overlap of more fungi, or there have been certain species of Klebsiella or certain species of other bacteria which came up, and when you taken a large carbohydrate, like if you've taken a bunch of pizzas, if you have taken a lot of ghee shakkar, if you have taken it up, with any binge of, if you have taken off a carbohydrate diets, they specifically convert it into alcohol. And as a result of that, it seems that person, it is there. So I think the forensic guys should know it, that if somebody comes, if you want to save somebody, he says, no, he has not taken the alcohol, it is an Otto-Breri syndrome. So it can be to your help, to the help of your friends and the people. But nevertheless, that is in the lighter vein. But you need to know about it, how the microbiota influences you. I think that is very fundamental, and that is the point I want to make, nothing more, nothing less. So it is important for us to understand gut immune axis. That's what Professor Kaushal was also talking about it. Again, what you see in this is dominance by potentially pathogenic bacteria, and therefore translocation can help to explain the occurrence of nosocomial bacterial infections, especially if you are not finding there is a VAP. Now today we know, and the data has started coming up, that where you find abnormality in immune gut axis, or there is an immune senescence happening because of the patients admitted in intensive care unit, you're finding a higher incidence, and this is also contributing significantly to it. I will not go into more details about it. This is a gut lumen, and we need to know that organ crosstalk is a norm than exception. I always say the subcellular function makes a cell function. A cell function makes a tissue function. A tissue function makes an organ function. And when the organ functions in cohesion with each other, the song of life goes on, whether it is a plant life or whether it's an animal life. And therefore it is very important for us to realize that all of them are acting each other. And when you are sick, when you are ill, what your mother does, कि बेटा बेटी खाना खा लो, ठीक खाना खा लो. हम लड़ते हैं उनसे बैठ के कि मॉडर्न मेडिसिन में नहीं करना. जिसके भी टाइफाइड हुआ, माँ हमेशा घिया की सब्जी खिला देती थी, कभी पसंद नहीं आती थी. आपको डायरिया है, आपको हम क्या बोलते हैं, राइस ले लीजिए, because it absorbs. आपको हम क्या बोलते हैं कि केला ले लीजिए, not the different shades of bananas are there, but which is a little kacha, means thoda tight, which is there, not then because it has a pectin kaolin. You see, these are the things which you do it. And if you see and go it up, and when you say the weaning the child, when you start putting them the cereals, they start having a trouble in the stomach. And it reminds me of a story, how the gut works. There was a gentleman who used to write, but he said कि मेरे को 6 महीने में अपना ग्रंथ पूरा करना है. वो हर रोज बैठ के लिखता था, हर रोज फाड़ देता था. माँ बड़ी परेशान हुई, बुजुर्ग के पास चली गई, जी क्या करें? कहते इसको खाते पिलाते क्या हो? उसने कहा साहब गाय का दूध पीता है, मूंग की दाल खाता है, और कहता ज्वार की रोटी लेता है. दूसरे कहता कुछ मत करो, इसको भैंस का दूध दो, इसको गेहूं की रोटी दो और उड़द की दाल खिलाओ, ग्रंथ इसका अपने आप 6 महीने में पूरा हो जाएगा. And it happened. The reason I am trying to say is what you eat makes you what you are, besides the thought process. Therefore, it is very fundamental for us to realize and understand how what we eat, how the body acts on it, where the body acts on it. It acts in the stomach, it acts in the gut, it acts in the abdomen. From there it goes to your factory, that is the liver, and that is formed there, and that circulates in the body. Kidney is your STP, where it throws out the junk. So I think it is very important and fundamental for us to understand that part. Now let's look at it. Again, it is a thing, you have a health, you have a gut microbiome, you have a display. So what you are finding is, if your health and gut microbiome are good, they are in harmony with each other, you have got a good and resilient person, good health. On the other end, there is a dysbiosis. It's not good, the gut is not good. You are having a problem with your microbiomes. Today in IBD, inflammatory bowel disease, we are looking at it as one of the factors. What do you find? You find that the person will be having the disease. And you see it if you have got a microbiome dysbiosis, whether because of the quality of the milk, whether you are having a diet, or whether you're having a pathogen, antibiotics, all these things can actually, if not appropriate, can lead to gut dysbiosis, including development of superbugs. And if you're taking if you're taking milk, along with it you're taking red meat, white meat, if you have used, the veterinarians have used as a growth product, the antibiotics, what do you expect? If you are finding today chemicals, insecticides in the mother's milk, what can you talk about it? We are seeing it that when there is an animal mastitis, when you take it up, what will happen? If you look at it, गाँवों से हम लोग तो गाँवों से उठ के आए हैं सारे के सारे, धार लेना बड़ा अच्छा लगता था छोटे होते, कि भी वहाँ बैठे भैंस को या गाय को आप धो रहे थे, you used to take it up, and you realize that number of people used to get brucellosis with that, and today that incidence with the pasteurization has gone away. I think it is very fundamental because it changed the character, it infected the gut and caused the things, and that's what happens. If you are a non-colonized, you have got pretty good. First stage will be colonization, and then it will lead to infection, disease. That's how we are looking at today. I hope I'm not boring you. So this is what happens, and I will quickly now go for it. Therefore, potential of microbiome in the gut, we are talking in terms of other places is, you have microbiome, antibodies, superbugs, and that colonization resistance goes both ways. And in this way, what you are finding is that there is a development of superbugs, and that's what we are talking. So we need to respect our gut, we need to respect our microbiomes. If they are there, we are healthy. If they are there, we are active, we are productive. I think that's fundamental message. So what you are finding is in microbiomes, you have a gut immune axis, you have a phenomena of colonization. In summary, if I give it to you, that is what is happening. Now, once you have a drug resistance, you have a horizontal gene transfer, you have a biofilm formation, you have a metabolic interactions, and another interesting word is called as a quorum sensing. We all think the bodies don't talk to each other. When you start looking at it, there's a transmission of energy which is happening between us and all. And I will give a very classical example. If somebody walks in, you feel very happy. The environment becomes energetic. He or she has not talked to you. It's an exchange of energy which is taking place, which is a positive energy. On the other hand, somebody comes and you says, "Ki bimari kahan se aa gayi?" Because the negativity comes up. From where it is coming up? Same way it is here. The quorum sensing is something where the bacteria talk to each other. where they're speaking it up, how their functions are coming up, and that ultimately leads to what we call today, what we see today is how they interact, how they form, and what you see, their survival instincts, their activity, and their effect on it, on us. I will not go beyond that. So these are the pathways resistance. This is a antimicrobial gene transfers where you can have got across. So when you are having these antibiotics, you must have this, even the normal microbiome stick around which has a drug resistant gene, or through the horizontal gene transfer, that is through which you can either through the mitochondria or either through that plasmids, you can transmit each other and they get into part and parcel of it. So it is, now what is happening is now what the scientists are thinking, can we actually manipulate the microbiome for therapeutic significance, and they can potential to overcome onset of disease by interacting with the host. Please remember, it is not the bacteria. It is always host pathogen interaction in an environment. I think that is fundamental, which we need to understand, and that is what decides and defines what we are seeing. And then obviously therapeutic strategies, you can have a microbiome therapeutics. I welcome Dr. Pankaj Mutneja, I think he's HMC observer here. Welcome Pankaj. So what we see is a microbiome therapeutics. Here you will have a substantiated therapies where you will have a bacteriophages, you will have a modulatory therapy where we will have a microbial DNA separation will be there. That is leading to bioactive compounds through the diet, probiotics, prebiotics, lifestyle modification, and antimicrobials. We can develop it up, and as an additive therapy, what Dr. Kaushal talked about, we are talking here about fecal microbial transplantation. It is not theory any longer today. It is being done to treat infections of Clostridia difficile and now being tried in inflammatory bowel disease. And obviously, then you have to have native engineered probiotics. I will come to that. Now, additive therapy, you can use it up. These two things we are using as of today now. When you start talking in terms of fecal microbiota transplantation, this is restoring gut balance. This is not a theory. In India itself, a trial of nearly 275 cases have already taken place in the setting of intensive care units, and where we find out that the success rate with the first one is 76%, and if you look at overall, the success rate is nearly around about 90%. I think that is important. It looks very bad. Now there are instruments which have come up. The kits come up which cost 15,000 rupees as of now. You take out the feces from a person who is healthy. The screening is same as you do for the blood transfusions. You try to look at it. Once it is not there, either you give it through the Ryle's tube or you create capsules, etc., and give it, or through the colonoscope, it is being put into it. So it is no longer theory. So what you are finding is a healthy microbiota is taken it up. Infected microbiota is there in a person concerned in C. difficile, and we restore. Our first line of action is metronidazole. If recurrence is there, we use oral vancomycin. Still, if it is life-threatening, this is what people are now, the first line of treatment, which is becoming, if not responding to metronidazole and all, restore the balance, and it is being practiced in few centers. I can only practice here if my gastroenterology colleague are, and along with it I get a support a little bit from my friends in the blood bank and other places, because you have to ensure no infections goes. And this is a story which was published in PLOS Biologica. They took out the stool from the healthy people and they engineered from out the pure form of E. coli. And then they try to manipulate against different things. There are 3 different strains, they look at it. And what did they find? That when they were exposed to antibiotics, in one group, it's the patient, again the difference in the microbiota in the individuals also. What did they find out? It was 54% in one person, 20% another person, which it remained normal, you reinforced, it was 88%. Therefore, it says that microbiota, which is there in every individual, may not be the same. But having said so, because that will become on the diet, that will become your genetics, that will depend upon the environment which was there. So multiple factors starts coming into play. Now, that has led to the formation of probiotics, prebiotics, symbiotics. This is the intervention how you can do besides FMT, the things, and that's what we practice. You will see the prescriptions of physicians, they write antibiotic, and along with it they put a probiotic. One of the best probiotic which we all have is a curd, if it is proper. It's because it is rich in lactobacillus. And that's why during the diarrhea, your mothers along with the rice or the khichdi give you, besides other things, the third. That's what happens. This is the rational, this is an observation over years, which we need to respect, practice, and give an evidence. And that's what we find out. Probiotics are the live microorganisms that provide health benefit to their host when consumed in sufficient quantity. There are different ones. They will do the internal health improvement. Prebiotics are the ones which are non-digestible food compounds, which stimulate the growth and activity of beneficial intestinal bacteria. But be careful one. If somebody is immune suppressed, these gut bacteria, which we never used to see, today because of automated things, are causing the disease in patients of immune suppressed. Therefore, all of these are live things which we are sending it up. So you need to be careful. If person is severely immunosuppressed, they may not end up causing sepsis in those patients. And symbiotic is when you have a combination of probiotic and prebiotic. I hope it is clear, and the expected outcome is an increase in the therapeutic outcomes. Subtractive therapy is another one which we are using it up. It's a fascinating tool in the microbiome engineering. And the aim is to reduce the deleterious pathogens from the microbiome with the help of antimicrobial activity of bacteriocins and bacteriophages. And that's what we are trying to say. Okay, out of them, there will be like an NIA or CIA or KGB. Go find out what is wrong, pick up, destroy it, let the normal work. That's how the principle is. And this is the bacteriocins. These are the ribosomally sensitized peptides which are exhibiting antimicrobial activity. And this is the one you will see working against multi-drug resistant Enterococcus, Clostridium difficile. All of them now in the trial phase which are going, and they are looking at it. Similarly, bacteriophages is another interesting thing. These are the ones which stay on the bacteria, and this is going to be the future of personalized medicine in coming time in terms of when you are managing it. And here you will see that you can have a bacteriophage, you infect the genome, and what you will see that it goes, it replicates, and it leads to lysis of the cell. On the other side, it goes into the cell and become part of the genome. And then again that leads to dysfunction, switching off of the false gene which is working, and it is working like a gene therapy, the bacteriophage is there. That's what we see it. And the phage antibiotic synergy means you combine it with antibiotic and phages. Together they do far better, and that is what is expected for us, that this will go into the phage antibiotic synergy can lead to addition of, reduces the minimal inhibitory concentrations of antibiotic, bringing sensitivity back. Then antibiotics increasing plaque size, which further results in faster phage amplification and enhanced pus size. Similarly, you have multiple decrease the number of bacterial mutant resistance. It will kill bacteria which are resistant to phages, and phagicize bacteria that are resistant to antibiotics. So they're working in a synergism to it, and that's what we need to look at it. So when you start looking at bacteriophages and antibiotics, the bacteriophages can act on the antibiofilm activity, specificity to the bacteria. That's a personalized, you pick up a bacteria, you give a phage, and it can take care. Then obviously the dosing, all these patterns, we need to look at it. Environmental effect as of today is minimum, but we need to see it in future what it is going to go. And this is something, quorum sensing inhibitors, which are coming from the microbiomes. This is cell-to-cell communication which we need to look at it. Can we pick up, can we see what microbiomes which are good, the way they are communicating, or the way the bad quorum which have got your satellite satcoms, they are there, how they are talking about, can we pick them up and do it? That is what quorum sensing does it. I will not go beyond this. Therefore, my dear friends, the challenges in microbiome therapeutics, because it is basically of a pharmacologist, it opens up a large vista for research, for challenges, and as a clinician, it gives me the potential role of how I can exploit these to the benefit of my patients. I think we need to sit together, and that is where the interdisciplinary thing also come up when I put it up Ayurveda, because Ayurveda basic principle is what? Is the pitta. That everything starts from the stomach, everything starts from the intestines. And that's what we never look at it. Now today, by a retrospective extension, everybody in the Western world started looking at it. What is, how the microbiome, which are 150 times genes than us, are manipulating the human body. And my dear friend, this is the last one, and this is the summary of it, that friendly bacteria of the human gut, then they are saying it to the next cartoon, which says this, I am fine, I don't need to eat pizza, and that is in the heaven. They go in, he says, we don't want to come to you if you are coming with the superbug. That is the message. Thank you very much for patient listening.
Thank you, sir, for very exhaustive lectures. And really, superbugs are really a problem actually, more in the ICU, but in the medical ward also. Almost, sir, every month we are getting 2 or 3 cases with pen resistance. Either it is Acinetobacter or it's a Klebsiella basically. And it's a very devastating for the physicians actually. We know the organism, but we don't know treatment actually. And the gut microbiome, if it is helping in those, it will be really new idea of research in this. Thank you very much. If there are any comment or questions from the audiences or any expert that is invited, otherwise we will invite the next speaker for this.
Madhu, any comments? You are a microbiologist sitting with us. अब मेरे को भी हाइपर एक्यूसिस होने लगा. I am now 60 now. Datarwala has a sharp ears.
Sir, thank you for the wonderful
very excellent lecture.
Yeah. Okay, sir.
Yes.
Sir, please. Sir, please.
I think our dean or director, they would like to ask some questions.
Dean has come with a tongue in cheek in a lighter vein. He has come like a Bombay police in the movies. So he will take some time. Welcome, Dr. Singhal and Dr. Lalad.
Actually, sir, the antibiotics, everybody is almost using indiscriminately, but there is no, you can say, there is no exact line of action actually, when to avoid and when not to avoid actually.
You see,
so this is one of the reasons actually.
No, the answer to this is not things have become easier. If you see, most of the time what I am doing in the OPD is cutting it down, and I am sharing it with the whole open house. I use only 2 antibiotics in the OPD. One is tetracyclines, working beautifully in respiratory diseases. There is no need for, I see my blood boils the moment I see ferropinum somebody has written it. For what? One. Second one which is working very well is azithromycin with us as of now in the respiratory. We have both these things and then we go to amoxiclav. We do not use quinolones by nature because we know out of 10, 9.5 will not use. Where it is required, we will use like resistant sinusitis, etc., provided we have the data. Unfortunately, we are not using the lab as much as we do one. Similarly, if you see now, the department has a facility both for diagnosing respiratory viral infections. They have the facility through the blood also. They have practically everything, they are doing it up. And we have, our department use of antibiotic in viral infections has reduced significantly. When it becomes purulent, we send the culture, we find out what is the resistance pattern and use the antibiotics accordingly. I think we need to be prudent when we are using antibiotics. The most difficult people I found out to convince physician, the best actually first use actually are the pediatricians. They are very respectful. Followed by internal medicine, yes, reasonable. But the worst are the surgeons and the orthopedics and the CTVS surgeons. They will give, wherever you put an implant, they are scared. So I said, and Pankaj is there, so I will simply say that we need to spend much more time on hand wash and how we can do disinfection and do our surgical techniques. My daughter has undergone a surgery, she has undergone cesarean section. Not a single antibiotic given except for the first day in UK. You see, we have to learn that tactic because we are not talking about it. We think that antibiotic is answer to everybody. So we need to change the culture of prescription, culture and idea of our own. Simply making guidelines will not work. Now Kerala has come up with us, the first state in the country where you cannot describe indiscriminately. They have an excellent public health system. Therefore, what we need, and I will request Dr. Pankaj sitting here, that Haryana Medical Council should read what they have said it, recommend to the government, we are all with you, that we need to cut this menace. Otherwise, God forbid, some of us need it, nothing may not work. I think that's what we're looking at it. Madhu, you were saying something.
Thank you, sir.
Sir, excellent talk. Just I wanted to say that we know that antimicrobial drug resistance is here to stay. The only thing is that, as you said, it has to be judicious use, empirical treatment when started. After knowing the antimicrobial susceptibility pattern, please come down to the antibiotics which are sensitive and minimize the use only when it is indicated.
Thank you so much. Now, Dr. Singhal is sitting here, our director. Request to him will be that every quarterly there should be a meeting. I still remember they used to send us the antibiograms. So we need to sit down together and we need to come with an institutional policy. Which antibiotic can be used where? Unfortunately, with the spread of, horizontal spread of intensive care high dependency units, there is no check and balances, but I think we always can it if there is a will. Thank you very much.
Sir, can you explain again about quorum sensing inhibitors you told?
You see, as a quorum sensing, basically cell-to-cell contact. This is the quercetin is the molecule which is doing it, and depending upon the cells, they can work at different levels. Like suppose the cell has to connect to the cell, how do they know I have to connect? So they will send signals. Some of them are RNA based, some of them based on the proteins which are being secreted by the material. So they come together, and on the basis of that, the functions are stimulated, they come together. Now when you look at the quorum sensing ones, I will show it to you, which is there. They will look at it what? Motility, conjugation. Then they will also look at the tolerance which is there, biofilm development. All these things are the biological functions which a specific, you can say a messenger RNA is sending a specific function to that. And that is what is happening. You try to block it up, and these are called as the quercetin bodies. Now this is the future, where people have started using this in the labs, in the clinical trials. It has still to come, but already in the labs it has been working in the animal models. So I won't be surprised in the next 5 to 7 years, you will start coming up with this. So that's how it is. So practically it is looking at the whole cellular function and what are the signal transduction which is taking place, and identifying that, and if possible to block that. That's what it is all about.
Thank you, sir.
I hope it is clear.
Thank you, yes.
I think we should close the session because you know Dr. Dhruv can speak for hours together. You can ask so many questions, but our authority for inauguration has come, and the organizers and even the relatives of the organizer appear to be tense. So we should close this.
So this is imitable Dr. Dattarwal style. I don't call them authorities. They're first among equal, they're friends, they're colleagues, and we are happy that they're around, and I think together as a collective part one can always develop under their leadership. Thank you very much.
Thank you so much, sir. That was a masterfully delivered session with key takeaways for us all. To present the gesture of gratitude to our speaker and chairpersons, I invite Dr. Jyoti Kaushal, Dr. Savita Verma, Dr. Sunil, and Dr. Sarita Goyal to the dais. Round of applause for our speaker for such an enriching session. Thank you so much, sir. Thanks to our chairpersons for the active discussions.
Ceremony, I warmly welcome Dr. Jyoti Khanna and Dr. Monica back on stage.
हाँ नहीं वो वहीं करवा लो हाँ चंद्र
नीचे आती हूँ। थोड़ा लग रहा है, देखो थोड़ा पीछे करवा दें, रहने दे अब, इसको थोड़ा सा बंद कर दूँगी।
ले आऊँ?
डिग्निटरीज हैं, तीनों को बुला रहा हूँ। हाँ, कौन है थे? डीन अकेडमी के पेरेंट्स और डायरेक्टर। सबसे बड़ा डायरेक्टर होता है ना, नहीं बुला है तीनों को।
Coming together is beginning. Keeping together is progress. And working together is success. With these inspiring lines, a very good morning to one and all. I, Dr. Jyoti Khanna,
And I, Dr. Monica Verma,
on behalf of Department of Pharmacology, PGIMS Rohtak, extend our heartiest welcome to you all in the inaugural ceremony of Medipharmacon-2025.
Medipharmacon-2025. It emphasizes on the theme of harnessing the microbiome for health for all. It involves understanding and manipulating the vast community of microorganisms that live within and on human body to improve health and well-being. As we all know, microbiome plays crucial role in digestion, immune function, mental health, metabolic health, and personalization of medicine. It thus has potential application in treating wide range of applications.
We are deeply honored to have with us our esteemed dignitaries. I take immense pleasure to invite our dignitaries on stage. I extend my heartiest welcome to visionary leader, our worthy director, Sir, Dr. S.K. Singhal, whose guidance continues to inspire academic excellence and innovation. Under his expertise, our institute has flourished into a beacon of excellence, thereby paving way for the next generation of leaders in healthcare. I request respected Dr. Jyoti Kaushal ma'am, Chairperson Medipharmacon, to kindly accompany Sir to the dais. Sir, your unwavering dedication to education and medicine has transformed countless lives and continues to inspire us all. Sir and ma'am, please be comfortably seated.
We have amongst us worthy Dean Academic Affairs, Dr. Dhruv Chaudhary sir, whose constant support has strengthened our academic pursuits. I request respected Dr. Savita Verma ma'am, organizing co-chairperson for Medipharmacon-2025, to kindly accompany sir on stage. Sir, your meticulous attention to details and staunch dedication has been instrumental in ensuring smooth operations at the institution. Your commitment to excellence and professionalism sets a shining example for all. Sir, please have your seats and be comfortably seated.
It is with great respect and honor that we extend a warm welcome to our respected Dean, Dr. K.S. Lalad sir, whose unwavering commitment to academic excellence and visionary leadership continues to inspire us all. I request Dr. Sunil Kumar sir, Organizing Secretary Medipharmacon-25, to kindly escort him to the stage. So please have your seat.
We are honored to have with us Vice President of Haryana Medical Council, Dr. Pankaj Mutneja sir, a pillar of support and guidance in all our endeavors. May I now take the privilege of inviting our esteemed Vice President of Haryana Medical Council on stage to grace the occasion with his presence. Please join me in welcoming him with a warm round of applause. I request Dr. Jyoti Sharma ma'am to kindly escort him to the stage. Thank you so much, sir.
I humbly request respected Dr. Jyoti Kaushal ma'am to welcome worthy Director Sir Dr. S.K. Singhal sir with the sacred Bhagavad Gita.
Can we have a warm round of applause, please? Now I would request respected Dr. Savita Verma ma'am to welcome our worthy Dean Academic Affairs, Dr. Dhruv Chaudhary sir, with the book.
I request Dr. Sunil Kumar to welcome worthy Dean Sir Dr. K.S. Lalar with the sacred book.
Now I would request Dr. Jyoti Kaushal ma'am to welcome Vice President of Haryana Medical Council, Dr. Pankaj Mutneja sir, with the sacred Bhagavad Gita. Thank you so much everyone. Please be comfortably seated. Saraswati Namastubhyam Varde Jnana Rupini Vidyaram Krishyami Siddhi Bharvatu Me Sada. This means, O Goddess Saraswati, I vow to you, the giver of knowledge and wisdom. As I begin this pursuit of learning, may I always be blessed with success. I request all the respected dignitaries to please come together for the lamp lighting and commence this event.
या कुंदेन्दु तुषार हार धवला या शुभ्र वस्त्रावृता या वीणा वरदण्ड मंडित करा या श्वेत पद्मासना या ब्रह्माच्युत शंकर प्रभृतिः देवै सदा वन्दिता सा मां पातु सरस्वती भगवती निशेषजाड्यापहा 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 शुक्लां ब्रह्म विचार सार परमा आद्यां जगद्व्यापिनी वीणा पुस्तकधारिणीं भयदा जाड्यान्धकारापहा हस्ते स्फाटिकमालिका विदधती पद्मासने संस्थिता वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदां बुद्धिप्रदां शारदां बुद्धिप्रदां शारदां या कुन्देन्दुतुषारहार धवला या शुभ्रवस्त्रावृता या वीणा वरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युत शंकर प्रभृतिभिः देवै सदा वन्दिता सा मां पातु सरस्वती भगवती निशेषजाड्यापहा निशेषजाड्यापहा निशेषजाड्यापहा
Thank you so much, students, for such a melodious Saraswati Vandana. Can we have a Kulgit? I request all to please stand up for our university Kulgit.
पुष्टिवर्धनम् उर्वारुकमिव बन्धनात् मृत्योर्मुक्षीयमावृता In the name of humanity, we will be always with humility. In the name of Hippocrates, our knowledge and honesty will never be separated. With this of knowledge, we will serve, we will devote this we all pledge, this we all pledge. संस्कृत ऋषि के शल्य ज्ञान का देखो कैसा है वरदान। उस ज्ञान की हमने दीक्षा ली, जग का हुआ रोग निदान।
चिकित्सकुल के हम प्रहरी, मानव सेवा ही परम धर्म है।
भारत को हो व्याधि मुक्त रोगी की सेवा अपना कर्म है। राष्ट्र सेवा को रहे समर्पित, अपने जीवन का सार ही हो। में रहे सांसों की डोरी, चिकित्सक का संस्कार यही हो।
भारत को दे हम स्वस्थ नागरिक, तन मन कर चरणों में अर्पित।
स्वर्ग धन्वंतरि के वरद पुत्र, हम जीवन कर पूर्ण समर्पित। परंपरा और तकनीकों का समावेश हम सब में है।
विश्व जानता अपना कौशल गुण विशेष हम सब में है।
सेवा की शिक्षा करे कुल का हम वंदन।
नत्वहं कामये राज्यं न स्वर्गं न पुनर्भवम् कामये दुःखतप्तानां प्राणिनामार्तिनाशनम्।
Thank you, everyone. Please take your seats. Lifelong learning is not just a requirement, it's a privilege. With this note, I would like to invite respected Dr. Jyoti Kaushal ma'am, Chairperson Medipharmacon-2025, who have always emphasized the need for professional development and continuous improvements among us, for the welcome address.
Thank you so much, Dr. Jyoti. A very good morning to everyone. Worthy Director, sir, esteemed Dean Academic Affairs, respected Dean, sir, respected Haryana Medical Council Vice President, sir, learned speakers, esteemed faculty members, all delegates and participants, my dear residents, and one and all present over here. A very warm welcome to everyone of you to this esteemed gathering, the National Conference of Pharmacology, Medipharmacon-2025. On the theme, Pharmacology Beyond Borders, Harnessing Microbiome for Health for All. It is with immense pleasure and pride that I stand here before you as organizing chairperson to inaugurate this scientific session. First and foremost, I extend my warm welcome to worthy Director Sir, Dr. S.K. Singhal, for gracing us with his esteemed presence today. Sir, your great support and encouragement has played a great role in making this conference a reality. You're always a source of inspiration for all of us. I also take the opportunity to welcome esteemed Dean Academic Affairs, Dr. Dhruv Chaudhary, for his constant guidance and support. We know all, sir, that you have a very, very busy schedule, and yet you could spare your valuable time to come here and provide us physical as well as moral support. Thank you, sir. I would like to extend my greetings and welcome respected Dean Sir, Dr. Kuldeep Singh Lalar. We all know that you have always taken a keen interest in motivating everyone to organize and participate in such academic activities. I would like to extend a warm welcome to Vice President, Haryana Medical Council, Dr. Pankaj Mutneja as well. The theme of the conference, Pharmacology Beyond Borders, is very much relevant for today's scenario. And we know that the theme, Pharmacology Beyond Borders, Harnessing Microbiome, Health for All, is so relevant as microbiome significantly affects the drug effect in the body. It affects drug absorption, these microbiomes, they affect drug absorption, drug metabolism, and the drug action as well. There's also inter-individual variation in drug response because each person has got unique microbiome composition. So that is why there's a need of personalized medicine in today's time. Microbiota, especially the gut microbiome, we have been listening since morning that they have got a key role in various areas. For example, regulation of immune system, providing nutritional and metabolism, nutritional support, as well as in metabolism, disease prevention and management. When there is imbalance in microbiota, which we call as dysbiosis, it is linked to varied sort of conditions, which could be obesity, diabetes mellitus, cardiovascular diseases, cancer, neurological disorders like Alzheimer's disease, psychiatric disturbances like anxiety, depression, and so on. Our distinguished speakers and experts will enlighten us with their insights, research findings, and practical applications which will help in patient care and improving the clinical outcomes. So I would like to welcome all the learned speakers for this gathering. I'm sure the lectures are going to be of extreme utility for everyone in the healthcare field. Hereby I also welcome esteemed faculty members from our institution as well as other institutions who could spare their invaluable time and they have come here to attend the conference. Welcome you all. I also take the opportunity to welcome the attendant delegates and all participants who have come from far off places. I'm sure that they will be benefited from the deliberations of the conference. Now, I would like to welcome the organizing team of my department who have worked day and night to make this conference a success. I would like to welcome my organizing co-chairperson, Dr. Savita Verma, organizing secretary, Dr. Sunil, co-organizing secretary, Dr. Jyoti Sharma, and joint secretaries, Dr. Himani and Dr. Monica Verma. I also extend warm welcome to other organizing committee members who are heading one or the other committee, Dr. Janal Singh, Dr. Vivek Sharma, Dr. Sarita Goyal, Dr. Rakesh Mittal, Dr. Niti Mittal, and Dr. Jyoti Khanna. They have given constant support to organize this event. I welcome my residents, senior residents as well as junior residents of my department who have contributed a lot to make this conference a resounding success. They have really worked hard day and night to make this event a success. May the next few hours be filled with insightful presentations, stimulating discussions, and meaningful collaborations. Thank you and welcome you all once again for a fruitful and enriching experience at the National Conference of Pharmacology, Medipharmacon-2025. Welcome you all.
Thank you so much, ma'am, for the insightful speech. You have truly set the tone for today's upcoming interactions.
The future belongs to those who believe in beauty of their dreams. I now invite our organizing secretary, respected Dr. Sunil Kumar sir, to deliver the introductory address.
Good morning, esteemed dignitaries, respected speakers, delegates, and dear colleagues. It gives me immense pleasure to welcome you all to this prestigious national conference. We are truly honored to host over 145 delegates from 7 different states, representing a rich diversity of thought, expertise, and experience. This year, we are proud to present a total of 99 scientific presentations with a mix of oral and poster presentations, highlighting the depth and breadth of research being undertaken across the country. We also begin our proceedings with a day with online presentations yesterday, ensuring broader participation and accessibility. Once again, I extend my heartfelt thanks to all the dignitaries, faculty members, presenters, participants for being a part of this academic celebration. Let us look forward to a day filled with inspiring ideas, engaging discussions, and fruitful collaboration. Thank you.
Thank you so much, sir. Now it's my honor and privilege to invite our esteemed Dean, respected Dr. Kuldeep Singh Lalad sir, our guiding light in our academic journey, to grace the stage and share few words of wisdom.
Good morning to all of you. The Honorable Director, Professor S.K. Singhal, Dean Academic Affairs, Professor Dhruv Chaudhary, our guest from HMC, Dr. Pankaj Mitneja, the Vice Chairperson of the HMC, the organizing team led by Dr. Jyoti Kausal, Dr. Savita Verma, Dr. Sunil, and all the faculty and resident of the Department of Pharmacology, all the invited speakers, guests, the faculty of PGMS, Rohtak, and all the delegates from other colleges, and our guest from city of Rohtak and outside. On behalf of Dean Office, I thank you very much for taking out time to attend this conference. The conference covers a lot of topics and which are very pertinent. The challenges we are facing in various spheres of the pharmacology, but like especially antibiotics, other drugs, anti-obesity drugs, and all other areas which are covering various aspects in the medical fields. As Professor Dhruv Chaudhary was talking about the resistance part, he was mentioning something about the maybe use or overuse of antibiotics. But I can tell you this, that when we use implants, many departments use implants. Cardiology also uses implants like pacemaker, ICDs. Cardiac surgery also uses prosthetic valves in form of metallic valves, bioprosthetic valves, and orthopedics also uses many implants. What I know from my experience is that if there is any infection in any implant, it is hell time for the patient as well as the treating doctor. So many times we are overcautious and use combination of antibiotics, because if we can prevent any infection, that is worth it. But of course, all the steps are important, like during operations, post-op, maintaining the patient in proper environment, like clean bed and proper aeration, air conditioning. These are also equally important. Because previously we were not having air conditioning in our department, where we were keeping our pacemakers or post ICD cases. And sometimes we were facing difficulties, and occasionally we also had infection. Because once there is infection in any implant, you cannot eradicate it unless you take out the implant and you eradicate the infection and do the procedure again. So these are the real challenges, but these can be overcome with precautions, and we can be much safer. The patient can be, much better with all the precautions. I thank the organizing team for inviting me here, and I'm sure that these deliberations will be very useful for the delegates, for the PG students, and all of us. Thank you very much.
Thank you so much, sir, for your kind words. Now, I would like to call upon stage our respected Vice President of Haryana Medical Council, Dr. Pankaj Mutneja, sir, to come on the dais and share a few words of wisdom.
Honorable and respected Director Principals, Dr. Singhal, Dean Academics, Dhruv Chaudhary, Dean Dr. Kuldeep Lalad, Chairperson Madam Kaushal, Jyoti Kaushal, and Co-Chairperson Madam Savita Verma. Coming to Rohtak is certainly not a duty for me. It is the affection which I get right from everybody, even the air. You really enjoy to be a part of this institution which was my alma mater, and I yet feel so young whenever I come here. When you look at this beautiful auditorium, Sushruth Auditorium, the first question I asked, where do you people play cricket, or where do you people play tennis? This was our. We could unhindered walk across to the girls' hostel and choose our spouses. But do they do this today also? Yes, I was told, yes, they do it. And they play cricket and things. Today, on this wonderful topic, pharmacology and the theme, the pharmacology beyond borders, happened to hear a great lecture, insightful lecture by Dhruv on superbugs. Actually, we are all worried. We in the practice, it's a scary atmosphere. I was the other day talking to somebody that we used to have, talking of early 80s or 85, 86, when we were house surgeons and residents at Department of Surgery, we would get a lot of enteric perforations. 4 days, 3 days old. We were never scared because we knew chloromycetin, amikacin and metrogyl will get them out. Today, believe me, even I have a peritonitis of 3 days. I really do not know if he would ever come out. Go on back into sepsis, have his wound essences, and we are very cautious in taking our consent also, because these are the days of documentation. And believe me, most of the time we do fail. I would love someday we go back to those days of chloromycetin and save ourselves. Today we are forced to use polymyxins, colistins, just to, not only to save ourselves, but also the patient. So a wonderful theme, and Dr. Dhruv said that HMC should take part. I tell you, yesterday I was in this meeting of HMC and we were talking to the DGHS. So I asked him, sir, what's new in health sector? I was happy and astonished to find that he said now they are working hard on antibiotic resistance. So the awareness is coming, is bound to permeate in the next 3-4 years. Till that happens, we do not know what is things. So thank you very much. Let's all really pay a lot of attention to this beautiful theme. Thank you.
Thank you so much, sir. Innovation, research and collaboration are teamwork of progressive medicine. With these words, I would like to call upon the dais respected Dean Academic Affairs, Dr. Dhruv Chaudhary sir, who always emphasizes on the need of scientific advancement and teamwork, to please share few words of wisdom.
Good noon. Thank you, Monica. Respected Dr. Singhal, our director, dear Kuldeep, Dean PJ, Dr. Pankaj Mutneja. He is more like a elder and a mentor also to me in my UG days, and still continues to do that. My colleagues, welcome Dr. Rakesh Gupta sir. I can see the whole Department of Pathology led by Dr. Sunita Singh. I also see Dr. Aparna, Madhu we have already seen, and all colleagues from various departments. And I welcome also Rohtak, IMA President, Aarti, who has been alumnus of PGI, who is alumnus of Pharmacology too. She's worked there, and I think she did DGU and then worked there. Dr. Rajiv Gupta also, our Director of Institute of Mental Health. I am very happy that when the subject was given to me, I was wondering what pharmacologists are doing. But then I realized our knowledge is inadequate till I started digging deep into it. And the one person, if I will give credit for the today, what I presented, what I am saying is, and the reason for talking about it is my DM fellow Vinita Surapaneni, who made the slides. She worked on it, she worked at it. The reason I am telling is, as a teacher, we need to involve our fellows, our residents in maintaining it. Helps me also, no doubt. But without reading, without knowing about it, it's just not possible. So please ensure it when we are coming up here. Topic is fine, fantastic. We need to have some sort of a white paper from the department, what we can do in terms of academics, in terms of research, what will you like, and that's how interdisciplinary, or even also in this is how we can look into Indian knowledge system. And the reason is that I got enlightened by it, by the neck. Because we never thought in terms of it. There's a huge wisdom lying with our ancient this thing. I'm not that I look simply at the back simply to prove a point, but I think time has come, we need to look at it. When Britishers can look at Ayurveda, when USA can look at an Ayurveda, I think it's a time to twins to meet, think, talk, and decide as far as the research is concerned. I'm not saying that you make a mixopathy, I'm not at all in favor of that. But what I say is we need a good Ayurvedic practitioner, we learn from them. You look at it half of the time, the practicing. When you have a small kid in the home, has a distension, what you do? You take hing, peet pe lagate ho, then it is there. If you know the content and give it, then it becomes allopath. If you do that, then it becomes Ayurveda. I think it's important for us, and as in charge of the research, I shall be very happy if these sort of proposals are put forward too, where we need to look at, we need to prove, document scientifically, because evidence is not what is in the trials, evidence is also what you have seen over years. I think that is one part I want to make it here. Secondly, also as a part of academics, I think we have been too rigid in terms of, I know the syllabus gives a little time, but we need to start talking interdisciplinary. And like the Department of Pharmacology, it's essential. You're looking at it in the Western world, and Dr. Pankaj must have seen himself, he's running an intensive care unit, Dr. Singhal is running it. There has to be presence of a pharmacist. And that's what we can start it from the Department of Pharmacology. Please see the number of drug interaction which is there. And today the number 3 cause of death in the world are the wrong prescriptions, is because of interaction which is taking place. I think you are not simply here to teach. You are here to part actively in clinical making, decision making, helping us out. the policies for the university, policies for the institution, and so that once you start doing it, we can go to the government what DGHS is doing. The university has to participate in the policy making. I think that's the way forward. And that also brings up, no doubt you people are excellent in teaching, but I request from this stage, Dr. Singhal, if agrees, will be that be participative more and more. Come check our prescriptions. You're all looking at the center of pharmacovigilance. I sometimes I wonder from where you get the data. So my request to you will be that please come, sit with us, tell us what is required. Don't cause blind a blind. Or one-eyed a one-eyed, call them surdas, so कहे साहब बहुत अच्छा सबको एक नज़र से देखता. Everybody will be receptive. अगर आप गाना कहोगे तो कोई नहीं सुनेगा. So my request to all of you is that please join us, and I'm very happy. It's an interdisciplinary subject which you have taken up, which is close to us, which is creating. So I expect Department of Pharmacology to participate actively in both academic research and clinical endeavors. And finally, again making a request to all of you, though this is not a platform, but making it up, and I hope Dr. Singhal will spare me with that. We had advertised for the undergraduate research schemes. We have got 28 for 5 from the dental. And for the 35 which we have kept for the UGs, we have only got 4. Either the Department of the Basic Sciences or other places, you are not basic. None of you is a basic science. All of you have a clinical role to play. My humble submission and request to all of you is, we are increasing the time period. We are extending it by another 2 weeks. Please ensure youngsters come and join the undergraduate research scheme of the university, where Dr. Pankaj, we are giving them, after selection, once they complete the project, 30,000 rupees and a certificate with the name of the Niti is sitting here. Am I right, Niti? So the person is from your department, so I request all of you to actually go to UG places. If you want, we will come and request all of you. And I want your active participation, because the future is innovation. Academia is fine. That's very important. But lateral thinking, lateral observation, innovation, that's the future if you want. In another 10 years, you will be so much of a number that जिस तरह पान की बनवारी मिलती है ना दुकानें हर जगह, वैसे डॉक्टर MBBS वाला मिलेगा. The only those will survive who will innovate, who will accept the technology, who will change with the time, who will learn, de-learn, relearn. Thank you very much.
Thank you so much, sir, for your insightful words. We must dare to dream big and strive for excellence in every aspect of education. With these words, I take this privilege to invite our worthy director, Sir Dr. S.K. Singhal, sir, who has always encouraged higher standards of learning amongst us, to share his invaluable insights.
Good afternoon. It's my pleasure to be here among you. First of all, I would extend the greeting on behalf of worthy Vice Chancellor, UHSR, who is not here today due to his some urgent commitment. He had to leave the city. So this Medipharmacon-2025 National Conference organized by the Department of Pharmacology, PGI MS Rohtak, with a theme nicely carved out like Pharmacology Beyond Borders, Harnessing Microbiome and Health for All. So we have in today's conference the pattern of our Vice Chancellor, then Dr. Dhruv Chaudhary, Dean Academic Affairs, who is among us and also had delivered a very nice talk on this topic. Dr. Kuldeep Lalad, Dean PGIMS, and Vice President of Haryana Medical Council, Dr. Pankaj Mutneja, who is always kind enough to give good credit over to any CME held by our institute. Dr. Rakesh Gupta, ex-Director PGIMS, Dr. Vivek Kaushal, ex-HOD Radiotherapy, better half of Dr. Jyoti Kaushal, who is organizing chairperson for this conference, Dr. Rajiv Gupta, CEO, SIMH, and many other heads of the department and faculty members from the PGIMS, the conference has advised also because you need to have, it is a multifactorial or with the inputs and from the various departments, they have a battery of advisors in their organizing team. Then the team is led by chairperson, none else, the head HOD of Pharma, Dr. Jyoti Kaushal, with co-chairperson Dr. Savita Verma, secretary Dr. Sunil Rohila, co-organizing secretary Dr. Jyoti Sharma, and they have two joint secretaries, Himani and Dr. Monica. So I can say that the theme focuses on microbiome therapeutics, on manipulating the gut microbiome to promote health and treat diseases. By restoring the balance, modulating the immune system, and addressing the drug non-responsiveness, fecal microbiota transplantation is one of the modality which has been worked into. Then probiotic therapies, dietary intervention, as rightly said, in the yoga, naturopathy, we use dietary intervention with the goal of improving conditions like recurrent clostridioids, difficile infection, cardiometabolic disorders, immune issues, and even neurological disorders. So there is a wider perspective of these microbiomes therapeutics in the present era, particularly when see around lot of drug resistance developing, and still we are not adhering to the protocols. So I was just looking into the literature when I came across a latest article in the Reproduction of Fertility Journal, which says that harnessing the power within, engineering the microbiome for enhanced gynecological health. Because as a indicator of national health, maternal health is very important, and we look into that as a major perspective. So microbiota transplant, probiotic, prebiotics, diet modification, and engineered microbiome strains have been used, and they have been seen in this review article, and it has highlighted the potential that microbiome manipulation can improve the female reproductive health. However, this field, as we are looking into today, is still in infancy. Much more research need to be done, and also you need to have funding for that, so that the role of microbiome, which is established in lot of conditions, it can wield its power in a real strength or in the real way, which we are looking for today. The conference today, we are there in since morning, going through the various sessions, and the topics they have tried to address to, think they have been nicely worked out, looking into the latest perspective, and also what we can give to the society at large, like superbugs, gut barriers, and also they have things to offer to the young fraternity, the budding pharmacologists, plus they have involved the faculty from all the concerned departments, surgery, pathology, microbiology, medicine, and PCCM, of course, ICU also they have involved the faculty. So I can see that the whole day deliberation are going to be very fruitful, and they are giving you insight and also sensitize you that in the coming, say maybe in the coming future, you can make up some guidelines, some protocol from SOP for the institute as such. Like we have infection control committee, we look for antibiotic stewardship. In that, somewhere the role of microbiome will also come in. And with that words, I wish the department a great success and best wishes to you all with this for this academic feast, and also greetings from my institute, PGIMS, and also from the University of Health Sciences, from the Honorable Vice Chancellor. Thank you very much.
Thank you, sir, for sharing your expertise with us.
May I now request all the respected dignitaries and core organizing team members to kindly release the souvenir.
round of applause.
Can we have a big round of applause, please?
We are highly thankful to all the worthy dignitaries for gracing the occasion and for sparing their valuable time from their scandid schedules and be with us today. I would request respected Dr. Jyoti Kaushal ma'am to kindly felicitate our worthy director sir, Dr. S.K. Singhal sir.
Can we have a warm round of applause, please? I would now request respected Dr. Savita Verma ma'am to kindly felicitate our worthy Dean Academic Affairs, Dr. Dhruv Chaudhary sir.
I will now request Dr. Jyoti Kaushal ma'am and Dr. Savita Verma ma'am to felicitate our worthy Dean, Dr. K.S. Lalad sir.
I would now request respected Dr. Jyoti Kaushal ma'am and Dr. Savita Verma ma'am to kindly felicitate our Haryana Medical Council Vice President Dr. Pankaj Mutneja sir.
Thank you, sir and ma'am. There could not have been a better platform than this to reward our outstanding students who made us proud with their brilliant performance in the annual examination of pharmacology. Every year, our alumni of MBBS batch 1993 have been rewarding the topper in pharmacology with the trophy, certificate of appreciation, and a check of Rs 5,000. I would like to call upon stage the alumni of 93 batch who are available here to please come on the stage. They all are carrying forward a proud tradition of honoring excellence. This thoughtful gesture of theirs is more than just an award. For us, it is a symbol of deep-rooted connection they continue to share with their alma mater. It reflects their belief in the power of education and the desire to motivate future generations to aim higher and shine brighter. May I request all the worthy dignitaries to join in appreciating the topper in pharmacology, MBBS 2022. Can we have a big round of applause for?
Can we have a big round of applause for
Yuval Krish Goyal?
heartfelt thank you to the alumni of 93 batch for consistently taking the time to join us and honor the student year after year. Your continued support and presence means a lot, and it serves a great inspiration to our students. We deeply appreciate your efforts and generosity, sir.
Now we'd like to fetch this opportunity in the presence of respected patrons to give token of appreciation to the core organizing team members. The event surely would not have been possible without their dedicated and consistent efforts. I would request worthy Director Sir, Dr. S.K. Singhal Sir, to kindly come forward and present a token of appreciation to our organizing chairperson, Dr. Jyoti Kaushal ma'am. Thank you so much, sir. I now request worthy Dean Academic Affairs, Dr. Dhruv Chaudhary, sir, to present a token of appreciation to our organizing co-chairperson, Dr. Savita Verma, ma'am. I request all the dignitaries to present token of appreciation to our organizing secretary, Dr. Sunil Kumar. A big round of applause for him. I also request all to give a token of appreciation to the co-organizing secretary, Dr. Jyoti Sharma. Their countless efforts are involved in organizing Medipharmacon-2025. A big round of applause. Now I invite respected members, so please have your seats for a few moments more. I invite respected Dr. Savita Verma ma'am to extend a vote of thanks.
Thank you, Jyoti. Thank you everyone for being here. As we conclude this academically enriching inaugural function on gut microbiome, it is my honor and privilege as co-chairperson to deliver vote of thanks. As Voltaire said, appreciation is a wonderful thing. It makes what is excellent in others belong to us as well, emphasizing the value of acknowledging the efforts of others. So on behalf of the organizing team, I would like to extend our deepest gratitude to our dignitaries, to the keynote speakers, invited faculty, and presenting researchers. Your contributions have brought cutting-edge science throughout critique and translational relevance to the forefront of our discussions. So, on behalf of the organizing team, I would like to extend a warm thank you to our Director, Sir, Dr. Professor K.S. Singhal. So, sir, your constant presence, calm demeanor, and supporting nature has made this conference a success. I'd also like to extend a heartfelt gratitude to Professor Dhruv Chaudhary, sir, as Dean Academic Affairs. So your leadership skills have always encouraged us to bring out the best in us. I'd also like to extend a heartfelt gratitude to Professor Dr. Lala, our Dean. Sir, your calm demeanor and again the encouraging nature has always encouraged us to do our best. Thanks a lot, sir. I would also like to thank Dr. Pankaj, who is Vice President, HMC, for gracing the occasion and encouraging us. And I will also like to extend my gratitude to our session chairs and moderators. Thank you for steering the conversations with such insightful and keeping the discussions intellectually stimulating. And we are indebted to our institutional partners and collaborators for their invaluable support in bringing this academic gathering to life. Your commitment in advancing microbiome science is truly appreciated. A very special thanks to the organizing team, Dr. Jyoti Kaushal ma'am, Sunil, Jyoti, and all our faculty members, our senior residents and residents, the logistics staff of the auditorium, and volunteers. Your behind-the-scene work ensured the smooth functioning of this conference. So, pardon me if I have forgotten anyone, but a heartfelt thank you to all the participants and dignitaries, keynote speakers. Thank you for gracing the occasion. Thank you so much, ma'am. May I now request everybody to please stand up for the national anthem?
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंग विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंग तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तब जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you so much, everyone. Now, I would like to request all the dignitaries and participants to kindly join us for the tea.
अरे आई के लिए
All are requested to please join in the hall.
ग्रुप पे मैसेज डाल देते हैं. डॉक्टर सीमा भी नहीं दिख रही वहाँ पे. कोई है ही नहीं. शुरू किसके लिए करो? हैं? कोई है ही नहीं. शुरू किसके लिए करें? ना डॉक्टर सीमा है ना सुरेखा डालना है.
वो सब लंच कर रहे होंगे ना.
देख क्या.
सुनील सर. सुनील सर से पूछना भी वो चेयरपर्सन है. सुनील सर यही है.
Welcome back, everyone. I, Dr. Himani, will join you for the further sessions. I hope you had a very refreshing tea break and a chance to connect with your colleagues and friends. We will now resume with the remaining lecture of session 2, which promised to be just as engaging and thought-provoking as the earlier ones. We request everyone to kindly settle down fast and take your seats as we move forward with the next segment of today's academic program. Who would have thought that the tiniest organism in our body could shape the future of medicine? From bugs to drugs, microbiome in drug discovery and development, our next speaker will take us on a journey from microbial ecosystem to the therapeutic breakthroughs. I now request our distinguished faculty members to kindly come up on the stage and chair the upcoming session. I request Dr. Seema Rani, Professor and Head Pharmacology, Government Medical College, Kanpur Kala, Sonipat. Dr. Abhishek, Associate Professor, Department of Radiation Oncology, PGIMS, Rohtak. Dr. Purushottam, Professor, Department of Psychiatry, PGIMS, Rohtak, to kindly come up off the stage and please have a seat. We welcome to all the chairpersons of this session. Now, it's my honor to invite our next esteemed speaker, Dr. Dinesh Badyal, sir, Professor and Head Pharmacology, CMC Ludhiana, to the stage. I request our respected chairpersons to introduce our esteemed speaker.
Good afternoon. Welcome Dr. Dinesh Badyal sir for your lecture on this very important and pertinent topic, that is the drug development and discovery through from bugs to drugs. So I think the delegates know him well. Dr. Dinesh Badyal is Professor and Head and Vice Principal, Department of Pharmacology, CMC Ludhiana. And his major achievements are, he's a Program Director, CMCL Famer Regional Institutor, Convener, NMC Nodal Center, National Convener, NMC Advanced Course in Medical Education, Member National Curriculum Committee, NMC, Chairman Pharmacology Expert Group for MBBS CBME 2024 curriculum, Convener Expert NMC for MD Pharmacology curriculum, Editor-in-Chief of NJPT Journal. He has been awarded Dr. APJ Kalam Memorial Oration Award, Dr. Rita Sood Memorial Oration, Visiting Fellowship by Jefferson University, Philadelphia, Scholarship by German Academic Exchange Service, and Professor G. Acharya Oration, Sri Gyani Satyanarayan Memorial Oration, and ML Gupta Award. And he has, to his credit, more than 170 publications and authored 4 books. So he has a rich experience, as we can see, and we welcome you, sir, for delivering this lecture. And after the lecture, we will take few questions and comments from the house. Thank you.
Thank you so much, sir. The presentation viewer. Switch करना पड़ेगा. Thank you so much, sir. As we discussed about, especially the role of microbiomes in the drug discovery and development. In the morning, you have heard about the microbiomes and how they are important nowadays. lot of things, as Dr. Dhruv said, we are coming back to our roots. We are not left with antimicrobials. We are trying extracts, we are trying plants, coming back to that component. That's really true also. As you see WHO prediction, which was in 2020, that by 2025, that was in 2025 released, by 2025 we will not have any effective antimicrobials. And that is coming out to be true now, we know that, how much is coming. But you know, usually whenever the challenges, solutions come up for that, maybe that is one of that thing which is coming up now. So, when we look at microbiomes, the spectrum which you have seen in the morning, also many examples of the diseases, we know one of the desire which separates us from other species is that we are constantly working to achieve something new. That brings us to that we have to look at that, how we put systematically microbiomes into the drug discovery. Remember that to put off, till now the system is planned for pure chemicals which we put as drugs. Maybe the definition also will have some updates there. And typically some of you, most of you are pharmacologists, I see, some of you from other specialties also. And we look at the drug development system here. You can see on this side pre-DCGI, which is the sort of preclinical or animal components. On the other side, left side, you see other components which are the human trials. If we have to put microbiomes to this process, you know, a lot of changes will happen. The regulatory process also is not so easy. But some of the things which are already available as foods, which we use, prebiotics, other substances, they already have established record. How to fit into that into a drug delivery when we are labeling them as a drugs. Some countries have no regulation for these things. For there you can simply label them as nutraceuticals. So this is the entire spectrum of the drug delivery you see here. And in this you will see it takes a lot of time, 12 to 15 years. For a single chemical to come out of the lab as a drug. Lot of investment, more than US billion, $1, about $1 US billion, more than that. And 10,000 compounds you start with. It means we are talking about microbiomes to include into mainstream of that. How we put into that? We'll slowly go into that. Lot of research has happened in the microbiomes. Animal studies as your preclinical studies, some data was available from the foods, for example, if I take on to that. And then there are clinical trials in the humans. For example, you might have heard about the Clostridium, and a lot of things are about that, FMT, fecal matter transplantation, which has happened. That is already known about that organism. So it means we have a preclinical data, then we have to go for the clinical trials. That is one option which happens into that, but that also takes a time. Although this is a change now, this diagram is going to be changed because of the vaccine development in COVID by India in less than 9 months. So what we have been talking about, a regular drug taking 12 to 15 years, this is going to be get revised. Okay, that is, you can say that was also a myth sort of thing, and the time definition, timelines which are changing. Lot of drugs which are getting into this system, new drug list system, because of we have some unmet needs which you can see here. Okay, these components, as well as somewhere cost to the therapy, individual countries, and microbiomes, especially we are talking about antimicrobial resistance, which is a major challenge to us everywhere throughout the world. Maybe they would fill up that, and also to sustain the industrial activity. Many industrial units, they started working on microbiomes around, you can say 2011 and 13. Then they got discouraged, they left it in between, then the COVID came. Okay, it picked up a bit, again the COVID came, again the focus shifted. So that is dwindling scenario in the new drug delivery, you can say. So presently, in the last 2-3 years again, there is a growing recognition of role of gut bacteria into the immune system. We already have many component immunological diseases where we don't have a standard of care as such. So, for example, one is probably contributing to the IBD, which doesn't have a standard of care as such. As has been told in the morning also, a lot of the things start from the gut. So that's what we are looking at that. And other immune mediated diseases where we are struggling with a lot of treatment options are there, but there are a lot of ADRs as far as allopathy is concerned. Maybe there also few things will come. So we need to integrate microbiome science into drug discovery and development. And usually it is often neglected till now, especially in the drug discovery and development. By chance, a lot of things have come into that. And remember that many of our drugs, major drugs, have come from this only. Right? Lot of success which has happened earlier. So now when we look at that, the first thing, as I told you, 2013, there was a lot of emphasis on that, exponential rise in the microbiome interest. That is the time when you heard a lot about prebiotics, probiotics. But you are hearing that only after that. Not much has happened. Food, it has penetrated into that. You have a lot of prebiotic food coming into the market. So first clinical trial, as I told you, it was in the fecal microbiota transplantation. Microbiota is the full load of microorganisms in the human body. When we have a genetic analysis, full genetic make of that, that is microbiome. So that way we are looking into that. So microbiota transplantations, more efficacious than the standard of care, vancomycin. The difference in various studies were 20%, 30%, even in some of the new ones. And but remember, 2013 after that, again, because a lot of money was needed and time was needed. And again, infectious diseases, remember, where the most of the drugs come from which countries, they do not suffer much of the infectious diseases. So their emphasis is not much. If more than 95% drugs are coming from a certain countries, their population is not suffering from infections, they will not invest more into that. Okay, that we have seen already that in the COVID, how we handled infections, how some of the developed countries could not handle infections. So this became a burden at that time, sort of. So components, especially if you see regulatory issues which are there at that time and now from 2013 onward. One is certain food products which already contain probiotics, probiotics, and which other medicines which are repurposed as microbiome mimetics. That is another area, microbiome mimetics. That doesn't need much of the regulatory authorities. They could have gone through it. But since regulations, as I told you, for microbiome, in some countries, few countries have, some have a moderate level of that, some countries have not at all. You can sell anything in the name of microbiomes. So in 2022, first market authorization came from microbiome drugs. This was for FMT only, for Clostridium, recurrent Clostridium, which was there by Australia. And few more came after that in the USA, but again for the same thing. Okay, more approvals were made. So drug delivery proper thing when they were put into that was these Australia and US FDA, they need the drugs or any chemical you are putting as a drug to go through all the steps of drug development to put them into the mainstream of drug development. So presently the strategies, if we look at these drug development strategies which are there in some countries and what is required is, one is we can look at microbial effect on the drug safety and efficacy. Then we can say effect of drugs on causing collateral restructuring of microbiome. So we are looking at two types of things. One is drugs from microbiomes, another is drugs for microbiomes. Both will fit into this category. And potential side effects of novel therapies targeting the microbiomes, how they are affecting that also. So already which are drugs available here, how we can make them more meaningful. And development of antibiotic prodrug for targeted pathogen elimination. So here we are using microbiomes as drugs. You can see some places we are using microbiome to improve the existing drugs, and some places we are using microbiomes as drugs. So both things are going in parallel, so that you can see regulatory people will have difficulties there in the drug development. So we need a systematic incorporation of microbiome analysis in early to late stages clinical trial. We will show you some examples. So I've shown you this already. So this is the opportunities for the microbiomes. If you see in the early stages, in silico methods to predict potential microbial metabolism, identifying the new chemical entities, then in vitro clearance, which will lot of data against whole microbiomes you need. Lot of models you need, animal models which have failed earlier, now there are few. Then conventional and germ-free rodent models. Okay. So one is there which we will show you later on. Then human data, you have to show mass balance and metabolites. Especially in these models you can have microbiomes, drugs or for drugs, but to resemblance or give a simulation of the environment in the body, how the microbiome reacts in your body, that is very difficult to simulate. That's why the differences are there. So in the early development, for example, if you look bacteria, which is a lot in the human body, Okay, even the more than the human genome examples which we have. And remember that the lot of bacterial enzymes which are there, all of them we can use in the new drug development process to have as them as drugs. Few examples are there. For example, micro-based certifications for the treatment which we can use, and inhibition of bacterial enzymes for the active drugs we can use there. Then even we can use pro-drug activation, which we have been thinking till now by other enzymes in the body, but microbiomes also has a role. Next example shows you that also, that some of the drugs which we have thought about, for example, they are metabolized levodopa, carbidopa, but there are other enzymes with the microbiome which we can use that. Okay, so very common example, but we can use that. So, for example, Crohn's disease, ulcerative colitis, where we are struggling for the standard of care. So, how this gut, these bacteria in the gut produce immunomodulatory molecule, which affect the specific inflammatory pathway IL-23. How gut bacteria target that pathway, this is known, but how it is done, that you need to work on that. And based on that, can we enhance beneficial bacterial activity so that a patient's system returns to a more balanced, healthier state, which we are struggling with. Right now, the vacuum is being filled by the prebiotics, probiotics, which are being sold as nutraceutical food supplements. So, there are two approaches in the new drug development process which can be done. Bacteria are identified, develop them as super probiotics. You have heard about the superbugs in the morning. You exploit that principle, you try to have super probiotics, then personalize the therapy based on the individual people. For example, collection of 20 bacteria you have taken for a certain person that can sort of quell that inflammatory activity in that person. Or another approach can be use bacterial compounds we identify to design drugs with high effectivity and activity against certain pathways, for example, IL-23. So that can also be done. Okay, so these are two approaches many people are using. Pharmaceutical industry was dwindling to one approach, another approach. They were confused where they will get more commercial benefits. So that is also one of the component. Because many of the things if already available in the market as food supplement, spending so much of money on the new drug development, putting them into that will be an issue. There is a clear link between an individual microbiome composition and disease development and treatment response. So it means we can consider them to be sort of personalized medicine approach. So that need to be done. Not all, anything you have labeled microbiome will suit other people, because microbiome population is different in the people and even in the regions, in the populations. And there's a lot of other targets right now in the new drug delivery. We have to identify the right target, which will become a blockbuster, looks like in this area also. So prebiotic, probiotic, you have seen a lot, symbiotics, antibiotics, we are struggling right now there. We are assuming something will happen there. And fecal FMT is already in the fashion, you can say. Phage therapy, right now struggling. Live biotherapeutics are there, and mimetics. Mimetics is a good area. If we develop chemicals mimicking that, maybe that can help a lot. So coming back to that, so we find somewhere the role might come here in between. So that can be the role somewhere. We are looking at both sides it will touch, preclinical, clinical. Some things which are already have good established efficacy in the market as food supplement, how to incorporate that substance as a main drug. So we just expand that preclinical part, target selection, validation, where we do. This is the initial stage when you are working on 10,000 chemicals. And now we are looking at where we put the microbiomes. Somewhere here, candidate for prioritization, the last three if you see, preclinical, safety, validation, testing. When we do these three things with the microbiomes, there have been many challenges. But fortunately, some processes have been streamlined. So there are SOPs now for the candidate prioritization, preclinical safety, and validation. Lot of this happened with the FMT for the Clostridium. So there the things have been prioritized now. So we are looking at after that, once you have identified a few of them, you will put that as a chemical matter and compound bank, microbiome bank will be there, which you will take further as a lead compound. Animal models, there have been issues. There were a lot of issues in the animal models, but presently we have one zoonotic mice with a defined microbiome. This helped to identify the T cell response integral to success of the FMT. FMT right now is the most successful microbiome based therapy. And another is human immortalized cell culture method for safety or validation the testing in the preclinical stage. But remember, these lack complex physical and mechanical interactions, all these models, between the microbiome and the host, which we see in the individual people. So that sometimes affects, I will show you that how it affects that. So later on that affects, and people have shifted now to cell-based models known as organoids and organ on a chip. Organoids are three-dimensional 3D cultures which are now maintainable, and organ on a chip is combined microfluids and cell culture to generate many human organs on a chip. Many human organs have been created on this already. FMT is a basis for many of that when they got structured. So mimics can actually accelerate new drug development process. There is a one, you can say, shortcut if you want to put many of the microbiomes into the mainstream drug development process where they are labeled as drugs. So they will mimic a structure like that, which is chemically you can compose, and same sort of actions which microbiomes are doing in the body, you will discover something which will have motivate, encourage, or you can say it stimulates same sort of processes in the body. And if you see a lot of things which right now are coming in up to 2023 in phase 1 and 2 clinical trial, many have come into the microbiome based studies compared to non-microbiome studies which are otherwise under drug discovery. So a lot of emphasis has shifted to that. But a word of caution here, lot of success has been achieved in the earlier stages, which is preclinical, somewhat also phase 1, 2 and 3. But there are common issues. One is data transparency in the microbiome discoveries which is happening, because everyone is trying to get that blockbuster molecule. And otherwise, some transparency in the industry till the compound reaches the regulatory phases, which is DCGI, FDA, phase 0 onward. Till now, there's no surety. We have seen with the rofecoxib, after withdrawal, they found animal data has the same toxicity. So success may be overestimated. In fact, presently the data available shows extraordinary high success rate for discovery and preclinical stage is much higher than the ones for the broader drug development sector later on. Means we are not getting the products into the market, although there is a lot of success in the early phases. No, that happens when the drug goes into humans. Their own host and immune interactions are very different for each individual. How that microbiome which you have labeled as a drug will act is very, very different. That's why there's a lot of reference now happening there. But a lot of efforts, one group in the Paris has collected many experts from various specialties. So stakeholders are large. They divided the whole process into 7 components. They made subcommittees. They have come with very significant reports on that, because right now it is not streamlined. Okay, so people are working together now, because when we say microbiomes, we are talking about already food which is available, regulatory process is there, but it needs to be changed for them, adapted from that. So we need many people together working. Otherwise, it will take a long time. So future areas in the new drug development process for microbiomes looks like anti-cancer drug development, a lot there through immune modulation, glycemic response in type 2 diabetes, so something in the anti-diabetic. Lot of other metabolic cardiovascular disorders are going on. Parkinson's, as I told you, another inhibitor for the something like carbidopa, which we are thinking about, which can be useful. And we are not aware of these things. There are other inhibitors also, which are already produced by microbiomes in the body. Tuberculosis, a lot is going on, so I'm not putting that extra, otherwise it will take much more space. A lot is needed here also, as we are struggling with MDR and XDR. But there are a lot of promising areas are coming up. And targeted design for antimicrobial prodrugs, which are activated by pathogen-specific enzymes. So you are not dependent on other biotransformation. So this can lead to development of pathogen-specific antibiotics, minimizing the collateral damage in the body, which is happening with other antimicrobials. So that can happen. We have certain advantage, which is in general for the discovery of the drugs, because of the number, which is in our favor right now. Okay, so that is a huge advantage which we have. Possible challenges, especially in the microbiome-based drug deliveries, the drug microbiome interaction data to produce predictive level is very limited right now. There's a lack of agreed upon standards for regulation, for discovery, for research. Difficult to culture and analyze gut bacteria at large scale. To identify the chemicals as mimetics, that is another challenge, only then ways. COVID pandemic derailed this process a bit, but then there is sudden rise in the interest because COVID also taught us that we need something in this area. And other is but other areas, some of the other areas, pharmaceutical industry diverted their efforts from microbiomes to where a lot of money was coming up. Monoclonal antibodies, which is, every disease coming up, oncolytic viruses, mRNA. So when they see two potential areas, one is more commercial benefit, they try to divert. Because microbiome discovery was suffering from 2013. Now there's a lot of push which is happening up. To sum up, the microbiome drug industry is still in its infancy. However, microbiome-based drugs tend to be safe and has shown promise in many areas, especially the major areas are GIT and infectious diseases, where fortunately or unfortunately in our country we need that. Emerging areas are more microbiome immune system relationship, microbiome immune therapy interaction, gut-brain axis, which is coming up after the lunch. So these are some of the references. There are a lot of things coming up. There's a gap. You will see in the references there's a gap in between, and suddenly now there's a spike. So thank you so much.
थैंक यू सर. मैं सबसे पहले बताना चाहूँगा कि it is my honor to chair this session because I am the chairperson of my teacher. लास्ट ईयर मैंने एक्ट में कोर्स ज्वाइन किया था, एडवांस कोर्स इन मेडिकल एजुकेशन, और सर ही मेरे गाइड थे वहाँ पर. सर ने पूरा गाइड किया और एकदम से मेरे पास मैम आए, अभी डॉक्टर ज्योति कौशल बोले कि यू हैव टू चेयरपर्सन दिस सेशन, एंड आई वाज वाओ. Sir, thank you, sir. Thank you, sir. And this is, sir,
it's an honor for us, for the teachers.
Thank you, sir. Thank you, sir. This was a very wonderful presentation, and you have summed up all the things for the drug discovery in a very beautiful manner. और सर I belong to radiation oncology, तो कैंसर एरिया, तो मेरे कान खड़े हो गए जैसे आपने बोला ट्रांसप्लांटेशन इज देयर. तो मेरी डिक्शनरी में एक ही वर्ड था BMT, बोन मैरो. नाउ another word is there, FMT. And sir, in the future development, you are saying about the anti-cancer drug development. Now I will keep in touch with you.
I think few days back there's a news about one person having treated himself with the urine drinking. I think we are coming back to a lot of things. Yeah.
Thank you.
Thank you.
Thank you, Dr. Dinesh sir, for a very thought-provoking lecture. Your presentation was very good. You covered all the areas from drug, how the drug delivery process, drug development, and the various complex issues that are there during the drug development, and it takes a lot of time, approximately 12-15 years, and huge money is involved. So we can understand that these developing drugs from microbiome is a huge challenge, especially for a low middle income countries like us. But having said that, these microbiomes, I personally feel that have a huge role to play. In future we will see many drugs that are being developed using these microbiomes, which are already present in the human GI tract, and I am working in the field of mental health, so we think that the GI tract in itself is the second brain.
Yes.
And we see many patients, the same drug we are giving to two different individuals who are suffering from the same disease, and the response is different. So what it is that is affecting that thing, and the one individual is getting the response, another is not getting the response. So there are many factors like these microbiomes which are existing in our body. They affect the drug pharmacokinetic, pharmacodynamics, as well as they lead to certain kind of drug interactions which are either the effect of the drug decreases because of that, or it leads to toxicity or side effects. So such kind of, and Another thing I would like to share with you that whenever even the color of the medication which we are using changes, the patient comes, doctor साहब ये दवाई तो इसका तो रंग नीला था लाल हो गया है और चाहे वो दवाई वही है उसके अंदर, but the patient belief system and the brain, we say it as a placebo effect. So even if we give B complex, for example, or folic acid, and saying that this will work, and sometimes it starts working for the patient. So exactly that drug lacked the exact molecule which is lacking, but still it is acting in the same way. So even the pharmacology has a psychology involved in it. So we need to, I think, teach our students and younger generations that drug dispensing is an art and there is a psychology involved in it, and there are many factors, and even we need to discover more and more regarding that. There are many things I think we don't still know. We are still discovering these things, and we'll come to know in the future that the human body is very complex as far as this drug, how they act, and various mechanisms, the interactions, pharmacodynamic, pharmacokinetic principles, and the changes from one individual to other as well. So thank you very much, sir, for enlightening the house.
Especially, sir, you are adding your part from the psychiatry point of view, where there is a well-established role. Microbiomes are coming up in the antidepressant area, so there is a lot of work going on that. But like you have said, futuristic things are coming up. I'm more worried. Most of us are, including everyone, is busy in our own self, social media and all. I'm worried that tomorrow we might come with another research or papers. Okay, talk to your microbiomes to improve your health. They have a brain and all that. Thank you so much.
Thank you, sir. Thanks, Dr. Udyal, for such an informative lecture. So now the session is open for the audience. If anyone want to ask any questions, so Dr. Udyal.
Specifically related to gut bacteria. So there are so many gut microbiome kits available in the market, which basically are the startups who does not, and when they present that they have done the clinical trial, but the trial has hardly 30 people in that. So do you recommend any reliable gut microbiome health testing available in India?
So as I told you, we have to put them into mainstream. For that, they have to go to preclinical stages, clinical stages. What people are coming to you till now, apart from FMT, which has been put into process, they are clinical studies, not trials. Okay, they are not marketing for that purpose. There's a small, you can say, loose ends in the regulation, which varies from country to country, that many of these substances which are not in the mainstream but which help any disorder, you can actually label them as nutraceuticals, food supplements, and add a word, this helps in autoimmune diseases. So that they are taking advantage of that.
Yes, because there are multiple things coming up every other day just in the name of good bug, good bacteria. But the problem is so deep that even when we prescribe medicine to our patient, we never look at the health as one. When we give any sort of antibiotic, it acts on the gut. And in many patients, there is a thing called die-off reactions also.
So as you are in the MD Pharmacology?
Sir, I'm a pediatric dentist.
Okay. So what happens are students who are in now industry and all, when there is a suppose, let's say hypothetically there's a meeting, presently what they are selling is antimicrobials, probiotics, a lot they are venture into. When a single person, they say the cost of pre-probiotics is more than the antimicrobial, they say okay, go in the market and sell more of this. That is one thing which is happening. We all of us We are now so, you say it's become a fashion to take prebiotics, probiotics.
Yes.
Now and then, even when you are normal, people are taking prebiotics, probiotics.
But then people are taking at least 5 to 6 prebiotics from different brands who
Yes.
does not have a scientific background. And then I know the government, the thing which we do on research level, that was my question. Like, is there any reliable gut microbiome health testing kit? Because the one available in the market, it comes at a cost of 10,000 rupees. There is a startup from Bangalore. So they claim that they test, they help us to test our gut microbiome, and even a few other startups also. But is it reliable?
No, because what we are talking about here, that was the issue. Microbiome as such, we can't label this is a good one or bad one for you. It depends upon how that microbiome is acting in your environment, in your body. Based on that interaction only we can decide. So we have not reached that stage even in the regulation where we are looking. Just drug is tested in 5,000 individuals, released into the market. We don't know how that will behave. With the microbiomes, that is also very variable. That's why their success rate is also very come from lab to the market.
Yes.
So you're very right. Right now we don't have anything regular process, SOPs for that. And that's why people are trying to encash that area right now.
There is a lot of money involved, but there is no R&D, and there is what I feel, or I want to take your suggestion, because I have few people who are actually struggling with it. They went to the best of doctors, but they say that we don't have any cure. They don't know what happens to them. And when they have specific medicine, even this prebiotic and probiotic also, not this single prebiotic or probiotic doesn't suit anyone. It doesn't suit every person.
They have ADRs like drugs.
Yes, sir.
And if you're not sure about their kinetics, if you're taking antibiotic, it's possible that antibiotic is killing that prebiotic you are taking. A lot of people are not aware
Yes, sir. So people with such problem, where should they go?
Pharmacologist right now. I think you are very right. That's what we have been talking for very long years. If we have a sort of multi-subject team to later to that issue, because they're not agreed upon. One line I use is no agreed upon guidelines we have.
Yes, sir.
Right? Even in the institution, antibiotic stewardship is started.
Yes, sir.
You, for example, as a pediatrician, you should get a biogram of your institution. Now you know biogram in your institution, you even know the wards and where it is coming up, you know the type of flora which is coming up. Okay, even that will tell you to help a lot in your region, your college, your wards, which type of microbiomes are coming up, which you can use also. But that need to be individualized.
Yes, sir. The problem within in a setup like ours, because we cater to huge population, we do see everything, but we don't have that sort of resources that we go deeper. But this is something which is a major concern, and people doesn't know whom to go, because whenever something happens, there is a problem in gut also. Brain fog also happens, which is one of the biggest symptom of this. People go to gastro, then they go to
I got your point. You are looking at some law regulations, but unfortunately in the medicine, a new law has come always after a medical disaster. So we are waiting for the one.
Okay.
And the new rule will come. This is unfortunately, till now, only law has come after a major medical disaster. Thank you so much.
Thank you so much.
I think there will be no other questions as the timing is already going forward. So we'll start with the next lecture. Thank you, Dr. Patel, sir. Thanks a lot.
Thank you so much, sir. It was a masterfully delivered lecture with a significant takeaways. Now I would like to call upon stage respected Dr. Jyoti Kaushal ma'am, Dr. Savita Verma ma'am, Dr. Sunil sir, and respected Dr. Rakesh Mittal sir to kindly come on stage and felicitate our speakers and chairperson. I request Dr. Badyal sir to kindly come on the stage.
Dr. Seema Rani ma'am, Dr. Abhishek sir, Dr. Purushottam sir, kindly join the stage. Give round round of applause for Dr. Dinesh Padayal, sir.
Thank you so much, everyone. Human disease are marked by an identifiable group of symptoms arising from certain abnormalities in biological pathways. But patients with similar disease are not identical, as we all know one size doesn't fit all. Let us delve into the intricate relationship between host and microbiota and how this dynamic interface is shaping the future of individualized therapeutic strategies. I would now request Dr. Suresh Kanta Rathi, Senior Professor and Head Anatomy, Dr. Kiran Daya Ma'am, Professor Biochemistry, and Dr. Seema Satija Ma'am, Professor and Head Pharmacology, MAMC Agroha, to kindly come on the stage and chair this session. It's my honor to invite our next esteemed speaker, Dr. Vandana Roy Ma'am, Director, Professor and Head of Pharmacology, to stage, who will be addressing a pivotal topic. I request respected chairpersons to introduce our esteemed speaker.
Put it on that slideshow. कहाँ से होगा? इससे just wait. This is the slideshow option. And slideshow. आगे के लिए यहाँ से होगा? नहीं यहाँ से कर देखो तो यहाँ से हो जाएगा ना?
Good afternoon, everyone. It's an honor for me to introduce our next speaker, Dr. Vandana Roy. She did her MBBS, MD, PhD, MBA from Faculty of Management Sciences, Management Studies, DU. She is also a Famer Fellow in Medical Education, has been a former Dean, Faculty of Medical Sciences, University of Delhi. She has 30 years of experience in medical education, clinical pharmacology, public health, drug policy for improving safe and rational use of medicines. She has been, she's a member, Signal Review Committee, PVPI, Minister of Health and Family Welfare, GOI, former member, Core Training Panel, PVPI, again from in Minister of Health and Family Welfare, Government of India. She's a coordinator, Adverse Drug Reaction Monitoring Center, MAMC and Associated Hospitals. She is a coordinator of Regional Training Center, PVPI, Delhi NCR. She is a coordinator for antimicrobial surveillance in MAMC and Associated Hospitals. She is an expert member committee to review new drugs for clinical trials in India. She is also an expert member of National and Delhi State Committees for Health Programs. She has over 100 publications and she has got awards for distinguished surveys and many other awards. So now I welcome Dr. Vandana Roy to deliver her talk.
Thank you, ma'am. Good afternoon, namaskar. I know I'm standing between lunch and
you, so bear with me for the next few minutes. I wish to thank Dr. Jyoti Kaushal, Dr. Sunil Kumar, and the whole organizing committee of Department of Pharmacology, Rohtak Medical, Pandit B.D. Sharma Medical College for their kind invitation, and I want to congratulate the department on their choice of themes for the conferences they are organizing. Last year it was on artificial intelligence, and this year it is harnessing microbiome as a source of for future health. So very contemporary, very futuristic topics. So congratulations, ma'am, and your whole department. We aim like we've been seeing a lot of slides which said that everybody wants to take medicines. You know, William Osler, one slide showed the desire to take medicines is very intense. But as doctors, we are aiming for the right medicine in the right dose at the right time for the right indication for the right person, and which produces the right response. But does it happen? No. The variability in the individual variability in drug response is tremendous, and it has been seen that it is least with drugs used in chemotherapy, about 25%, and the direct response is the least with chemotherapy drugs, only in 25%, and the direct response is maximum with COX inhibitors, about 80%. And the range of direct responses with the drugs given to different people ranges from 50 to 75%. That means there is a lot of variability in the way people are responding to the same medicines which are being given as regards responses, as regards adverse reactions. Now, it was thought that it's the genes which are doing this, that the genes are different and they are determining what is happening when we give a medicine to a person. And evolution of pharmacogenomics over the last 60 years, well, has given us some proof, but pharmacogenomics can only account for about 20 to 95% of the variability in drug response. There is still a large area where pharmacogenomics is unable to explain the drug variability. Now, causes the variability in drug response, there are many causes. We are well aware of them, besides genetics, in which a lot of work has gone on. In the last 6 decades, microbiome is receiving a lot of attention. And the human gut microbiome is being sourced as and being looked at as a source of answering the variability in drug responses. So we are moving, or we are increasingly, we have been in the era of pharmacogenomics. We are still there. Discovery of the microbiome, studies in the area of microbiome, and now to answer the variability, efficacy, and safety of drugs, we are going into the era of microbiomics. It's a new term. Now, I'll just quickly kind of give a background of human microbiome in health and disease. I'm sure some of it must have been covered in the morning, but just to set the tone for microbiome in precision medicine. Now, the human microbiome is an intricate, diverse group of microorganisms which are there in our body. They are inside our body, they are on the body, they comprise of bacteria, viruses, fungi, and so many other microorganisms. There are about 100 trillion microorganisms in the body, and the genome, the microbiome genome is about 150, has about 150 times more genes than the human genome. And you can imagine the number of the number of microbial products, microbiomial products that are being expressed by this microbiomal genome is in millions. Now, this microbiome is dynamic. It is not static. It's like a living factory inside our body and on our body. It's evolutionary. It's changing all the time. It's huge. I've just told you that. There is mobility intra and inter-individual. It can move from the gut to the respiratory tract, into the bloodstream, and in other reproductive areas, and in the bacteria, the microorganisms can move. And of course, they can get transferred from one individual to another. The microbiome exhibits a lot of resilience. You know, the gut microbiome, so the microbiome is not only present in the gut, but it's the main site, it's there in the brain, it's there in the respiratory tract, the reproductive organs, etc. But when we talk in general, we are usually referring to the gut microbiome. So a lot of resilience. These microbiomes are exposed to dietary factors, lifestyle factors, disease, antibiotics, other medicines, but they remain. They remain stable to some extent, but they also exhibit plasticity in that in the onslaught of all these exposures, diet, disease, drugs, etc., they also mutate, they also show a change. So they exhibit both resilience and plasticity. Any disturbance of the microbiome content in number and quality can result in breakdown of homeostasis, resulting in dysbiosis, and which will result in disease. Now, more than 8 decades since 1937, we have been working on the microbiome. The first idea that there is a microbiome was when Prontosil was discovered, and it was seen that it exhibited antibacterial action because it got converted into sulfanilamide by bacterial action. So that was the first microorganism that we could relate to in terms of having an action, converting an inactive drug into a proper drug. Now, a lot of things have happened. 2003, the Human Genome Project was completed. 2007, the Human Microbiome Project started. 2012, it was completed. 2014, the second phase of the Human Microbiome Project started. It is still going on, and we are in phase 2 of the Human Microbiome Project, which is still underway. 2012, the National Research Council proposed the term precision medicine. So, genomics, Human Genome Project, Human Microbiome Project, phase 1 finished, phase 2 going on, coining of the term precision medicine somewhere in between all this. So what is the functions this microbiome is doing in our body? Most important, digestion, immune functions. It is involved in metabolism. It is a metabolic factory. They are metabolizing 36% of all the small molecules, which is a huge number, involved in the immune functions and protection against pathogens. This is a very, very basic categorization of all that the microbiome is doing. So the green area is the microbiome helping us in maintaining health, while if dysbiosis occurs, disease occurs. If an imbalance in our microbiome occurs, we are going to cross over and get diseases, and manifested by cytotoxicity, host protein, hormone degradation, pro-inflammatory effects, etc. Now, this is just to show you how important the gut microbiome is and what is happening. So you know the gut, the histology of the gut, the anatomy and the histology of the gut. There is a mucus lining which covers it, and the microbiome is over there. The eubiotic microbiome is there, and this is helping in maintaining the balance in the gut. What is getting absorbed, what is getting digested, what is entering the bloodstream, and what are the toxic chemicals which are coming, what pathogens are coming. This gut microbiome protects us and helps in maintaining homeostasis. But if the junction breaks down, if it becomes leaky, if the intracellular junctions between the cells start becoming loose and the junctions become leaky, the intestinal contents, the microbiomal contents start moving into the bloodstream, and they reach distant sites of the distant organs, resulting in disease. So microbiome imbalances have been extensively studied in these diseases of the gut: inflammatory bowel disease, irritable bowel syndrome, metabolism, diabetes, obesity, neurological disorders, depression, anxiety, cancers, many cancers, liver cirrhosis, rheumatoid arthritis, Clostridium difficile infection. There are many others. I've just picked up some of the main ones because I am going to try and show you how precision medicine may work in these areas. Sorry. Okay. So this is not to confuse you. This is just to show how much we know, the extent we know about how microbiome is working and how dysbiosis can cause disease. So the three graphs pictures are of what is happening at the gut lumen level in alcoholic liver disease, in non-alcoholic fatty liver disease, and in cirrhosis. The layer is disturbed. There is dysbiosis. Mediators are entering the bloodstream, inflammatory mediators, they are reaching the organs and causing damage. So all these have been identified, they have been marked, and many of them are considered biomarkers for identifying these diseases. So this, which are the microorganisms causing these imbalances have been identified, where they are acting have been identified, which are the mediators causing the imbalances have been identified. So you can see where we are going. If so much has been identified, where can we go for targeted therapy? So again, this is just showing the three: alcoholic liver disease, non-alcoholic liver disease, and cirrhosis. Comparison, what all has been discovered, which are the microorganisms which are increasing, decreasing, mediators, etc. Now, with that background of what is the microbiome and how much we know about it, I'm just going to take you towards microbiome and precision medicine. So microbiome and medicines, there is a lot of interaction, and this has resulted in a new field known as pharmacomicrobiomics, which is seeking to understand how inter-individual differences in the microbiome shape drug effects and toxicity. It is also leading to another subspecialty of pharmacometabolomics, where you're understanding drugs, microbiome, and the metabolites which are getting secreted. Pharmacometagenomics, again medicines, microbiome, and the genes in the bacteria and in the host. So the interplay between all these is being studied in these specialities. The next few slides I will just run you through. Please don't read it, just to show you that in these diseases, what has been a lot of studies in animal models, some in human, have been done to identify what is the role of microbiome. What is the role of these microorganisms in the etiology, in the pathogenesis of these diseases. And if we have discovered these microorganisms with these diseases, can they be used for diagnosing these diseases? Can they be used for predicting treatments? So pharmacomicrobiomics has been studied for drugs in all the systems. So I'll just quickly give you one example of a few of them. In cancers, cyclophosphamide gets converted into an active form. It increases anti-tumor cells. Microbiota improve the anti-tumor T cell response. Okay, and cyclophosphamide mediated translocation of certain microbiota into the lymphocytes enhances the T cell lymphocyte response. Okay, so cyclophosphamide, direct action we know as pharmacologists, but it's interplay, it's playing with the microbiota, and it's increasing the T cell lymphocyte response exhibited by the microbiota. It's helping in translocation of the relevant microbiota to the lymphatic organs where the T cell response is getting enhanced. Reducing microbiota diversity by using antibiotics has been seen to decrease the action of cyclophosphamide, and antibiotic-treated mice, of course, have naturally had a reduced tumor response. So that was for efficacy, how efficacy of an anti-cancer drug was getting affected. Irinotecan, toxicity, and microbiota. So it has a very limiting side effect of diarrhea, and it's glucurinated metabolite. It gets glucuronized, it gets glucurinated, and in the intestine, the microbiota deconjugates it again, setting the free drug and some metabolites free. This results in diarrhea, which is very, very severe, and it's a limiting side effect of this drug. So antibiotic therapy to eliminate the bacteria, microbiota causing this conversion is being explored. Immune therapy, microbiota, as you've seen with all the speakers, immune axis, gut immune was one of the main lines of the themes in all the talks. So has been explored in a number of cancers, skin, lung, renal cell, An improved efficacy of chemotherapy, immunotherapy has been seen when the mycobacteria, I've written it in blue in italics, when these were present. The efficacy decreased when certain other microbiota were present. And this interaction between the immunotherapy and the microbiota are enhancing the anti-tumor response of the immune system. Translocating the gut microbiome of a person exposed to this anti-cancer drug into another who's not, or into an animal who's not exposed, is being seen to transfer the effect of the drug. Tacrolimus, another immunosuppressant, its dose varies, and some people need a very, very high dose. What is the reason for this? It was seen that the gut of some people have these bacteria which metabolize it into an inactive compound. So intestinal microbiota influences efficacy of these PD-1 blockade, and they are doing this by the drug is interacting with the microbiota and enhancing the immune response of the microbiota, that is the anti-tumor response. So cancers is a very big group where microbiome therapies are being evaluated. Then cardiovascular system, microbiomes and dysfunctioning of the microbiomes are being increasingly seen to be evolved in the etiopathogenesis of hypertension, coronary artery disease, atherosclerosis, congestive heart failure. And so just to show you an example of a drug which is affected by microbiota, warfarin has 35% variability, which is not explained by genetic factors. Presence of certain bacteria is present in low responders to warfarin. Okay, so Bacteroid, Shigella, Klebsiella are present. These people respond poorly to warfarin, and Enterococcus, the response to warfarin was much more. Digoxin, in 10% people there is no response. Why? There is a microorganism, E. lenta, which produces a reductase, cardiac glycoside reductase, which inactivates digoxin. So can we develop inhibitors of this enzyme which can enhance efficacy of digoxin in the non-responders? ACE inhibitors. Captopril still retains its antihypertensive effect in people where the therapy is discontinued because it has been seen to bring about changes in the microbiome, in the gut microbiome. Abundance of certain microbiota have been seen to result in retaining the antihypertensive effect of captopril. Enalapril reduces the levels of trimethylamine N oxide. This is involved in the genesis of atherosclerosis. So can this be the reason, one of the reasons how enalapril is being, survival improving drug in congestive heart failure and ischemia, myocardial ischemia? Okay, coming to endocrine system, one example, metformin. Reduces the blood sugar, many mechanisms, but many are still not known. Some of the mechanisms which have been elucidated and are related to the microbiome are, it acts through this pathway, bacteroids, fragilis, GUDCA, intestinal, phamosoid, X receptor axis. A mouthful, very difficult to remember. Metformin reduces the levels of B. fragilis, preventing degradation of GUDCA. Okay, so when that increases, the blood sugar lowering effect, one of the ways in which at the microscopic level metformin is exerting its hypoglycemic, its blood sugar lowering effect. So metformin is altering the gut microbiota, and this was proven when the gut microbiota from people who were taking metformin was taken and transferred into the gut of mice. Okay, so this transference resulted in a blood sugar lowering effect, while transferring the gut microbiota from people who had not been exposed to metformin in mice had no blood sugar lowering effect. So this is what this graph shows. Gut microbiota of healthy people does not lower the blood sugar level, the brown line, but the gut microbiota of people exposed to metformin is lowering the blood sugar, the green line, improved glucose tolerance. So, can we play with the gut microbiota in diabetic people who need metformin? Okay, GIT, digestive system, sulfasalazine, we all know it's used in inflammatory bowel disease. It needs to be activated into sulfapyridine and 5-aminosalicylate. It produces, when you give sulfasalazine with a probiotic containing these bacteria, its activation increases. But while its activation increases, its ADAs resulting because of 5-aminosalicylate also increase, nausea, skin rash, anorexia. Okay, so sulfasalazine activation by gut microbiota, and giving sulfasalazine with probiotics enhances activation but also enhances the ADAs which are occurring. Another example, digestive system. I thought this is important because everybody is getting PPIs. I'm sure even in our government college in Rohtak, this is the practice. So PPIs lower blood, they lower the pH in the gut, but what happens then is the gut microbiota changes. It starts getting replaced by the oral microbiota, and this results in an imbalance and predisposing people to Clostridium difficile, liver cirrhosis, obesity. You know, these are being thought of in the genesis, the theories which are coming up. So a few more examples, gemcitabine. Resistance to its anti-cancer effect was seen in cell lines having this bacteria, microbacteria, gamma proteobacteria, because it was secreting an enzyme deaminase leading to resistance. Clonazepam, flunitrazepam, converted by bacterial nitroreductases into inactive metabolites. Can we use this in benzodiazepine overdose? Okay, bioavailability. Levodopa, bioavailability, levodopa acts by getting converted into dopamine in the brain. But levodopa also gets converted into dopamine in the periphery by the action of a bacterial tyrosine decarboxylase. And this bacterial tyrosine decarboxylase is not inhibited by carbidopa. So it's different. And Dr. Badial in his presentation was talking about a tyrosine hydroxylase inhibitor, not carbidopa, another inhibitor. So that's where it comes from. Levodopa bioavailability, H. Helicobacter pylori also binds to levodopa and decreases its bioavailability. So can giving antibacterial drugs, anti-H. pylori drugs improve levodopa bioavailability? Toxicology, we saw it with irinotecan. How is the microbiome affecting drug toxicity? Indomethacin, again, it gets deconjugated by bacterial microbiome. Morphine gets deconjugated by intestinal microbiome, resulting in free drug levels, resulting in toxic metabolites, which enhance the ADAs with these drugs. Pharmacodynamic drug microbiome pharmacodynamic actions, inflammatory bowel disease, and integrin therapy. It was seen that remission was much higher in people who had a greater diversity of microorganisms. Enrichment for certain specific microorganisms enhanced the remission rate when this therapy was given in patients of inflammatory bowel disease. Rheumatoid arthritis. Methotrexate alters gut microbiome. Its immunological action is also because it is modifying the gut microbiota. And this is the bacteria which has been identified in people with rheumatoid arthritis. Methotrexate also has a lot of ADAs. So the bacteria which is associated with GIT ADAs has also been identified. Antibiotics. Antibiotics are going to suppress the gut microbiome. Okay, so the actions being exhibited or by the balance, the homeostasis, the actions being exhibited by the gut microbiome are going to be affected. So can we use, so antibiotic stewardship is also going to be needed to preserve our gut microbiome. And I already told you Helicobacter pylori and L-Dopa role. Okay, so with that background, extensive background of how much work is going on in the area of medicines, microbiomics, and disease. Let's just go on to where is it leading to precision medicine? So precision medicine is it's a very precise definition. It is an innovative approach that aims to develop tailored medical interventions on the basis of an individual's genetic, environmental, and lifestyle elements. It's based on the patient's own genetic, molecular, phenotypic, or psychosocial characteristics. The aim of precision medicine, 2011 the term was coined, is enhance efficacy for the person, enhance efficacy, enhance safety, decrease toxicity of the medical intervention that we are giving the patient. So what is the role of microbiome? As a diagnostic therapeutic marker, microbiome is also a modulator of the traditional therapies we are taking. You just saw that when we are giving cyclophosphamide, how the microbiome is enhancing its action. So many medicines we saw the microbiota are enhancing the actions of pharmacological interventions that we take for granted. And microbiome itself can be a target for specific therapies. So quickly, microbiome biomarkers. So we already have signatures, and that in these diseases, these are the microbiomes which are present. Okay, RA, this may be the microbiome. This in in MI, this may be the form. In cancers, this is what we are expecting. So once you have it, it can help us in early diagnosis of the disease. The microbiome signature of a person may be able to help us in early detection, personalized interventions, assessing disease risk and progression, and predicting therapy responses. So some examples of biomarkers which have been identified, I won't read it out, but metabolic syndrome, autoimmune, RA, type 2 diabetes, celiac disease. So they have these markers which are coming up. And again, this table is just showing 5 minutes, okay. This is also just showing it's the biomarkers involved in immune cancer therapy. So it's going to help us in inflammatory bowel disease. The microbiome, which comprises of ulcerative colitis, Crohn's disease, indeterminate colitis, the microbiome is very, very different in all of them. And they have worked it out for Crohn's disease, and they've also been able to identify which are the microbiota which can enhance the treatment outcomes. Vaccine response, they have studied which are the microbiota which are enhancing vaccine response. Systemic disorders, I've already told you, rheumatoid arthritis, which are the biomarkers have been identified. Coming to the second part of, microbiome in precision therapy, in making precise or precision diagnosis. The second component is precision management and treatment. So we have targeted interventions which will enhance efficacy and decrease toxicity. I'm just going to tell the approaches because some of things may have already been told. So for precision therapy, utilizing the microbiota, the strategies are inhibit the enzymes which the microbiota are secreting, remove the specific bacterial species or strains, engraft or engineer better bacteria. If something is missing, let's get that gene into the bacteria in the gut, and directly modifying bacterial cells. So work is going on in inhibiting microbial enzymes, bacteriophages for removing bacterial species or strains. New engineered strains in the gut have been studied for many diseases, phenylketonuria, hyperammonia, animal studies, of course, very positive results. In vivo genetic modification, directly inserting bacteria with genes modified into the individual's microbiome. And of course, a very personalized diet. What diet will enhance the hypoglycemic actions? What diet will result in decreased inflammation? What diet may help in cardiovascular disorders? All is being, a lot of work is coming on and happening there. So microbiome therapeutics are untargeted approaches. You have this list. I won't repeat it. I won't go on into details for paucity of time. Targeted approaches, this is very interesting, and I suggest at least the postgraduates and all the people interested read all the work that is going on in all these areas. Live biotherapeutics, where they're actually inserting and using live individual bacteria. So now we need to work with genomics and microbiomics together. It's not just pharmacogenomics alone. Warfarin is a classic case. Just going to finish. Vitamin K is present in our diet. It's also synthesized by a bacteria. Okay, so microbiome and warfarin K action, vitamin K epoxide reductase, metabolism affected by the genome. Okay. So pharmacomicrobiomics is leading towards precision medicine. All these are stages and steps which are happening. Challenges, many challenges, identifying key bacterial species. There is a lot of inter-individual variability, complex host-microbe interactions, standardization, very big issue, quality of the products coming out, safety standards to be set up, regulatory frameworks, ethical and technical barriers. So the 6 P's of precision medicine is personalized, preventive, predictive, participatory, promising, but it is also problematic, as you must have realized. Now, this slide is just showing how the microbiome signature of a person. If I have a card, like we were saying, our human genome card, my genome card, if I have my own microbiome card, I can give it to the doctor. They can help decide, make a diagnosis and decide what therapy to give me. They screen me for a diagnosis or screen a person for diagnosis based on the microbiome, and then stratify the person based on the microbiome for treatment and monitoring. So we are moving towards this era: human genome, metallobome, proteobome, microbiome, and clinical data. A combination of all these, put it in your computers, and we will get what is precision medicine. AI has coming up in a big way to identify patterns, composition, and therapeutic outcomes. Personalized vaccines are being looked into. So there is a lot of work going on in precision medicines. Just want to conclude by saying that microbiome-based precision medicine has the potential to revolutionize diagnostics, treatment strategies, and disease prevention, ultimately improving patient outcomes and contributing to the evolution of healthcare into a more personalized and effective system, tailoring therapy from within. Thank you.
Thank you, ma'am. First of all, I should congratulate my congratulations to Dr. Jyoti Kaushal, madam, for organizing the national conference. And the topic you have chosen is very futuristic, emerging. It was very interesting also, as so many things are coming up. Thanks, Vandana Roy, madam, for enlightening us so much, a nice topic. As precision medicine is there for many diseases, but you have elaborately concluded the microbiome as a precision medicine with beautiful examples. As a role of pharmacologist, you have given so many drugs, example of drugs, which we can relate to. So thanks for your lecture, ma'am.
A very nice and lucid presentation. In this era of personalized medicine, these microbiomes are indeed the key players. Ma'am, are there any means to quantitate the effect of these players, these microbiomes?
Quantitate, you mean what is present in the body?
To regulate or control their effect in the body.
They are working in that. They are looking how can we biocontain the microbiome where they are not needed, where they are becoming pathological. So there is work going on in this area, ma'am.
Yes, ma'am.
Thank you, Dr. Vanna, for excellent presentation. And especially the way you have converted complex things in a very simplified manner. And it is very useful for our audience. Thank you for your contribution, ma'am.
Thank you, ma'am.
house is open for discussion. If any queries are there.
Thank you, ma'am. Ma'am, you have mentioned leaky gut. So, ma'am, I want to ask, is this leaky gut, is this a byproduct of dysbiosis or it is the etiology of dysbiosis?
Actually, both.
Okay.
It is both. So what is happening? So if there are some gut imbalances, it is going to result in a leaky gut, right? If
Yes.
there is inflammation. But dysbiosis would be the greater contributor to causing the leaky gut. And I want to just go back and tell you this is that in Ayurveda, this science is not new. We are for pharmacologists and modern medicine, it is only 8 decades. In Ayurveda, the basis of maintaining the human balance is the gut immune system.
Yes, ma'am.
And what you eat, how you eat, when you eat, so this is a 2000-old science. I mean, if I wish we could actually read those texts, it is nothing new. And the gut has been seen to be related to the immune system, and immune system affects all the other systems. No?
Yes, ma'am. I have read the reports about it. West talks about this thing a lot, but in India there are only 3 or 4 this corporate hospital, and there also their lobby is divided. Some clinician they outrightly discard this, and some clinician maybe 1 or 2 in their hospital they say yes it exists, and the reason is because they had to go so deep. They have to take the history, they have to understand and then reach the diagnosis. So such thing does not happen. Ma'am, what do you think, like when can we have a place, or is there any place in India where they do the proper diagnosis, they are more interested in history?
Okay, so you're speaking from the allopathic doctor's point of view.
Yes,
Ayurveda people, the old ones, always took a history.
Yes,
they did not know anything about microbiota. They just knew कि पेट ठीक होना चाहिए.
Yes.
जो हम खा रहे हैं ठीक होना चाहिए. That's all they knew. But the reasoning and all behind it is now coming up via evidence-based science, and it's coming up sadly from the West.
Yes, ma'am.
You know, so if you want, in Bombay there are institutes modern institutes who have been working in Ayurveda, collaborative work for years.
Okay, ma'am.
Okay, you would have to go and talk to people who are working there to help you in your whatever you're doing. There is an All India Institute of Ayurveda in Delhi, but they are not working like this. What is happening is the Ayush colleges which are coming up, they are working in the modern way of working. They are not working in their the roots. You know, their philosophy, their theory, they're not working. So, but Bombay, Gujarat are the two places, Maharashtra and Gujarat are the 2 states where there is a lot of work going on. US is doing a lot of work.
Yes, ma'am.
50 drugs have already been approved, 50 FDA approved drugs already have information of drug microbiota interactions. 50.
Yes.
I mean, I had just a 30 minutes, so I could, didn't. But that was a 2023 article reference which I read. So that is the amount of work they have done. They're already writing drug microbiota interactions.
Yes, ma'am. Ma'am, how long does it take to heal it? Like report says, like if you correct everything, maybe 1 year or 2 year. Do you support this?
Collect what?
Correct this, your dietary, because here in India, we have not reached at a stage of precision microbiome products. So what people do, they go to who understands and who wants to treat it. They try various dietary formulation to get those microbiota at a place. So how long does it take to treat this, if it is treatable?
See, that what you're asking, again, duration and dose and all, it's not standardized. We need all that work. All these biotics, probiotics and all, clinical trials have not shown too much efficacy.
Yes,
but symbiotics, yes, something is coming up, okay? So that is number one. But what I would like to tell you is that if you go to an old Ayurvedic doctor, the old ones, and they prescribe and you follow, my gut feeling is if you've got the right Ayurvedic doctor, it would help.
One last question, ma'am. When we talk about microbiome, how important is the role of fungus?
Oh, fungus is a part of microbiome.
Okay, ma'am.
I didn't show that slide. Bacteria, viruses, fungi, actinomyces, some other microorganisms, they're all part of microbiome. Is not only bacteria.
Yes, ma'am.
It's all fungus, everything.
Thank you, ma'am.
Yes, sir.
I have been studying Ayurveda out of my interest for last 15 years. And I think the original precision medicine was Ayurveda.
Yes.
Because they do it by Vat, Pitta, Kapha constitution, VPK.
Yes,
I think microbiome is the interface.
Yes.
Maybe what they were doing through VPK, I think they were indirectly tracking the microbiome and treating the patients.
Most likely, sir.
That is, I think, the link,
Yes.
perhaps. Because they also looked at gut. We are also looking at gut. So there is a meeting point.
Yes.
Microbiome may be the meeting point of modern medicine and Ayurveda if we are with an open mind. Thank you.
Absolutely, sir.
Wonderfully delivered talk, ma'am. Actually, you have given a lot of examples. I have also a comment to make. The point here is, don't you think that we busy clinician, should engage ourselves in telling the patient some natural ways of improving microbiota in diseases like cancers, or like in busy clinical settings we just go about the drugs. But what I feel that we should promote, because I'm a pediatrician, there are a lot of ways in children in which we can improve microbiota. So I think we should focus on that. What is your say about that?
Absolutely right, ma'am. I 100% agree. Diet is extremely important. And the good old Indian diet, what our parents took, what our grandparents took, nothing can replace it. वो सिंपल चीज़ें खाते थे, 7 बजे के बाद डिनर्स नहीं होते थे, there were no dinners, and we were not eating processed foods. So Western processed foods are destroying the microbiome, leading to a lot of dysbiosis, and maybe that, again, this is my own contributing to the increase in cardiovascular problems, cancers, so many things which are happening. The dietary pattern change is one of the contributory factors.
One more comment, madam. ICMR has published a study in which COVID mortality in India was one of the lowest compared to the others, and they say it was the Indian diet. The idli dosa, the chawal rajma, such things, it is published in Indian Journal of Medical Research, and they say that Indian diet was one of the protecting factor in COVID. It's a very high-class paper. Thank you.
So there's a lot of work which has happened, lot of work in India which was already there, which is not documented, or it's there in a language we can't understand. But it goes back over 2,000 years. We are getting the evidence from the West, and
Thank you, ma'am. Thank you, everyone.
I took just 35 minutes.
Thank you so much, ma'am, for such an informative session. It was really very captivating. Now, I would like to request Dr. Jyoti Koshal ma'am, Dr. Savata Parma ma'am, Dr. Sunil Kumar sir, and Dr. Neeti Mittal ma'am to felicitate our speaker and chairpersons. Ma'am, kindly come. Give a big round of applause to Dr. Vandana Roy ma'am for sparing the time for this platform. Thank you so much, ma'am. A very thank you to our chairpersons, Dr. Suresh Kanta Rathi ma'am, Dr. Kiran Dhaya ma'am, and Dr. Seema Satija ma'am. Thank you so much for joining with us. We now invite all the delegates and guests to proceed for lunch. We hope you enjoy the meal and take this opportunity to relax and engage in the meaningful conversations with your fellow attendees. I request presenters of oral and poster presentation to finish the lunch at a faster pace and join the presentation sessions by 3 o'clock. I also request judges to please join our respective sessions after lunch. Please join us in the dining area and we'll meet and get back to auditorium at 3 p.m. Thank you so much, everyone.
Shubham He's a big help. Yes, ma'am. He is a big help. Shubham?
पॉइंटर है मैम कोई प्रॉब्लम नहीं
full to dive into our third and very exciting session of today's event. Jaisa An Vaisa Man. What we eat shapes not just our body but also our thoughts. Imagine a conversation, silent, invisible, but constant, between your brain and your gut. Not through words, but through molecules, nerves, and microbes. For years, the brain was thought to be the command center acting alone. But now, science is revealing a powerful partner, the gut. I now request the following esteemed dignitaries to kindly come up on the stage and chair the session. Dr. Jagat Singh, Professor and Head, Department of ENT, PGIMS Rohtak. Dr. Alok Khanna, Professor, Department of Pediatrics, PGIMS Rohtak. Dr. Shurbi Gupta, Professor and Head, Department of Pharmacology, Subharti Medical College. We are honored to have your presence and leadership for this session. The chairpersons are requested to kindly come up on the stage and take the seats. Now it's time to welcome our esteemed speaker, Dr. R.K. Dikshit Sir, Professor and Head Pharmacology, KGMC Lucknow, who will explore the gut-brain axis, bridging neuropharmacology and the microbiome. We welcome you, sir.
Thank you for giving the opportunity of chairpersons from all of us, of Dr. Jyoti and all of the Department of Pharmacology. And it's a very new topic and very important topic. Dr. K.K. Dikshit from KGMU Lucknow, HOD. Anji, so we welcome you, sir, and
Thank
please carry on.
Thank you. So good afternoon. Good afternoon. I can think, and I am sure that nobody wants to hear after post lunch. And sir, you are great that you chair the session. Otherwise, after lunch means khatam. And that's how the hall is witnessing. मेरी और डॉक्टर दिनेश की बात हुई थी कि मेरे में तुम रहोगे, तुम्हारे में मैं रहूँगा. डॉक्टर दिनेश चले गए, देखो है बाहर. वंदना मैडम से बात हुई थी, तुम्हारे में मैं रहूँगी, मेरे में तुम रहोगे. अरे बेईमानी कर लिया ना अब तुम. So if you get a session after post lunch, you have two things. One is pros, another is. So one is that whatever you want to, you just speak. Nobody is going to listen. The message is, the second part is that we have only limited persons. Now, thank you. हमने जो था तो बेईमानी कर लिया तुम. बिकॉज सुबह से जो लोग पढ़ रहे हैं, सुबह से वही चीज़ माइक्रोबायोम. सो अल्टीमेटली एक लिमिट है हर चीज़ का. ठीक है. सो नाउ द लिमिट इज क्रॉस्ड. And now we will go with the crisp messages within few minutes with some joy. So please don't have any strain over the upper brain, because now we are going to strike to the lower brain. So topic allotted was my bridging the brain to the GIT, but I make a bridge between the KGMU and PGIMS Rohtak. So thank you, madam, for giving my opportunity, and that's the beauty. And then now that we are here, that bridge has been created between our institute and your institute. So thank you, Chairperson. I start with these contents we will try to cover. That is, what is gut-brain axis, what has been additionally added over the gut-brain axis, importance of microbiomes, altered microbiomes leading to the pathological, and now I will be focusing over the neurological diseases more. Regulating microbiome, how we can regulate with the older method and the newer coming methods. Therapeutic potentials of regulation of gut and brain axis, and very few take-home messages with the research potential. So, सुबेरे मेरा था मैडम, बेईमानी करी गई इसमें भी. I was supposed to take before 12, so I put good morning. So बेईमानी started from this place. Okay. Okay. So I am grateful to all the faculty and administration from the PGIMS Rohtak, all the PGs, and everybody who is supporting this conference. So what is this? Those who are saying, anybody, just say, what is this? Stop. Wonderful. Madam, you told stop, that shows that the lunch was wonderful. And the microbiome have done their actions. What is this? स्पेलिंग रॉन्ग है, जानबूझ के करी गई है कि आपको जगाना है मुझको. अगर आप स्टॉप बोल रहे हो इसका मतलब अभी भी आपका चल रहा है वहीं पे. So that's how this has been wrongly placed, so that we can become at least 10-12 जितने भी हैं, 12-14 हैं सर, इनको तो कम से कम जगा के रख के, मैंने पीजी बुलाते तो अच्छा लगता है उनको. So they may be हाँ, तो उनको थोड़ा सा अच्छा लगता. So always I put this picture. Why? Because that shows whether you are listening or attentive to the presentation or not. So our ancestors were great scientists. Yes or no? Nobody can deny. Nobody can deny. Only thing was that their documentation was not such with the proofs and the scientific evidences they created that was published in their era, but unfortunately they were vanished during the time. And that's how, but ultimately what they have told, now that cannot be denied. Amazing sciences discoveries by our ancestors. So the style is जैसा मन, जैसा खाना वैसा मन, जैसा अन्न वैसा मन. ये आज नहीं बोला किसी ने बहुत पहले 10,000 20,000 साल पहले बोला था, जो आज हम प्रूव करने जा रहे हैं. Now that is how they were doing wonderful things, and he was the person who gave that कि जैसा भोजन खाइए वैसा मन पाइए, जैसा पानी पीजिए वैसा वाणी बोलिए. Now that is how they were observing the things, everything, and ultimately came to the some certain conclusion without these evidences of microbiomes and other things. Hippocrates, way back, he told all diseases begin in the gut. So gut became the central part of every disease. And then came the advertisement. पेट सफा तो सब थफा. ठीक है, इसका कहने का मतलब ये था कि पेट अगर सही रहेगा तो you will be having away from the illness. Gut brain connection is there, and from that this came gut feeling. सोचे कब ये सब चल रहा है, nobody thought कि मेरे gut feeling आ रही, gut में कौन सी feeling आ रही, but gut feeling आ रही कि ये मर जाएगा. कैसे हो गया? Because he thought, and ultimately everything occurs, and that told कि prognosis of this patient is poor. So what happens? There is a connection between the gut and the brain, which was unexplored till now. Now the time is to explore through the, so little bit explore has been there. Now the further category is exploration between the bridge. So what does the gut microbiota do? They protect against the pathogens, produce essential vitamins, metabolism, gut-brain communication, and very important for the immune system. Thousands of trillions of bacteria biomes are there, and wonders are there that any alteration may lead to the pathology, and the conversion of the normal can lead to the treatment. And that's how we can expect that many diseases can be treated or managed by the normalization of the microbiomes. So researchers are focusing the strong link between the gut health and the mental health. And ultimately there is a possibility, strong possibility to maintain the gut health, to maintain the mental health. So there are thousands of theories why this happens. The simplest one is that any alteration in the gut microbiome leading to the altered permeability of the gut intestinal and then ultimately the toxin and everything that reaches into the blood, that goes into the brain. And anyhow, this is one other connection. And second is what the message comes from the brain towards the gut through the vagus and other parasympathetic system. So these are the interactions, very crude things, which very minor, now crude to minor, and ultimately it is not time to pinpoint each and every molecule or chemokines, everything. Just in a brief sense, something happens to the microbiome, something alters in the intestine, something goes into the blood and other part, and ultimately that alters the pathway of metabolism at every system, including the CNS. So the reshaping of the gut microbiome with the diet may present a new therapeutic approach. And when I say diet, it is not diet only. Diet with microbiome. Because when anybody says the diet achhi kar lo, diet achhi karna is one thing, along with the balance with the microbiome is the second thing. So diet with microbiome balance is the crux of the treatment. Dysbiosis leads to number of CNS diseases. I am focusing on the CNS, Alzheimer's, Parkinson's, depressive disorders, and other neurodevelopmental disorders. So, gut-brain axis. Now, this is one term given by the WHO and other authorities. The term has been coined into the newer one, MGBA. What is MGBA? GBA is gut-brain axis. What is MGBA? Microbiota brain, gut-brain axis. Now, this is again a new term. But my concern is this has to be changed. Why? Because microbiota are in the bridge. Gut, brain. In between there is microbiota. So that should be GMBA. If you think you start with the gut, within the gut there is microbiota, then comes to the brain, and then that axis is there. So ultimately GBA has been turned into the MGBA. Actually it is nothing but the GMBA. That is gut. That is my topic. That is only that microbiota, they are actually bridging the gap between the gut and the brain. So gut-brain axis to the microbiota gut-brain axis. A network of connections, and it is bidirectional. The gut sends some signals to the brain, and the brain sends some signals to the gut, and ultimately normal homeostasis occurs and leads to the normal physiology, leading to the gut bacteria, gut, brain, and all these, what I have told earlier. So linking of the first brain to the second brain, it has been called the second brain. What is second brain? Like second heart is there, like second brain is also there. The first brain is what is here. The second brain is what is we are having in the GIT in the form of enteric system, enteric nervous system. So second brain is this one. central nervous system and second brain. The enteric system has been called as a second brain, and linking of those two through the biome, through the microbiota is the topic of the discussion today. So microbiota and gut-brain axis is bidirectional, and this is the formula which will click you. That is through the signaling from the gut microbiota to the brain and from brain to the gut microbiota in a nice combination. What is nice? Through the neural pathway. Vagus, enteric nervous system, immune system, immunological system, chemical mediators, and endocrinal. So these communications are very nicely communicated through the nice. So one is neural, another is immune, third is chemical mediators, and the fourth is endocrine. So these nice, if becomes nice, remains nice, this is symbiosis, not having diseases. When it becomes nice to opposite, now this becomes dysbiosis, leading to the diseases. So evidences are there, and many evidences have been created using the technological strategies like germ-free animal. Now, rat model has been created without germs within the intestine, and then they saw what happens. So this is the model which has given evidences. If the germs are removed from the GIT of the mice, what happens in the CNS of the mice? So gut-free animals, culture-independent method, prebiotic, postbiotic, synbiotic, paraprobiotic, and postbiotic. These two terms are new, which I got when I searched the literature for this presentation. I was knowing prebiotic as you, probiotic, everybody knows, synbiotic, combination of these two terms they came new. One is paraprobiotic, another is postbiotic. What is this? Paraprobiotic and postbiotics are the chemicals released by microorganism. Now they are utilized for this particular purpose. So that is how these two terms are also there. Then antibiotics, sequencing technologies, and infectious diseases. Particular infection has been created in the GIT, and then saw what is happening in the brain. So ultimately, these are the two new terms which you can Google and you can find. These are the chemicals released from the microbiomes which are utilized as a treatment part. This is the summary of all what is happening, breach in the GI mucosa and everything. And now if you see here, gut microbiota, immune and brain axis ultimately leads to the all sort of diseases and more focus over the diseases of the brain. Neurotransmitters which are involved mainly are more correlated with particular type of microbiome. GABA is more correlated with the lactobacillus. Now suppose anybody is having stress and you want to increase GABA for as an anti-anxiety neurotransmitter. Now then it can be sterilized to increase the lactobacillus and other bacteria, norepinephrine related to the Escherichia bacillus, acetylcholine, again lactobacillus, serotonin. So all these, they have been proved, but the actual therapeutic potential is lacking. Now that needs lot of research, lot of clinical application, lot of clinical evidences, only then we can go further. So evidences, I have told that whenever symbiosis, it's good. Dysbiosis ultimately leads to diseases. Beyond the correlative studies, the time is, till now, it was just a correlation, association. This happens because of this, this may happen because of this you do because, and this may happen. But now we have to go more in depth for the mechanistic exploration, why this is happening. And that's why we have to go in depth, in more deeper place to get the actual mechanism behind the microbiome, gut and brain axis, and ultimately dysbiosis leading to the diseases. So extension of gut-brain axis to the microbiota gut-brain axis. So these have been already told. And one thing interesting is that all the microbiota which are carrying at this age, now they have been stabilized at 6 years. Very early. Now here comes the very importance for the parenting. Now here comes the very important part, role by the parents in parenting the child. 3 to 6 years. Now, and it is documented. What is the brain time, maximum brain development? What is the maximum brain development of child? 5 year, 7 year. Now see the correlation, wonderful correlation. Till now it was not 6 years, 7 years child. Now that has maximum brain development. Simultaneously, the maximum microbiota development is species and everything. Now, within the intestine, again that is correlated. Again, it is a correlative evidence that the microbiomes are related to the what is happening in the brain. So that is how the maturity of the child and regarding the other organ, including the brain, is related to the microbiomes. So microbiomes in the gut, they are responsible, and most important is short chain fatty acids. Now they have actually shown that there is a very much correlation with these fatty acids to the diseases. So microbiomes, most important is the dysbiosis, and have been, neurotransmitters which are involved, they are serotonin, dopamine, GABA. In the intricate involvement of the gut microbiome is regulation of the social behavior. Child learns social behavior at what time? Just correlate. Child learns social behavior within that 6-7 years. Microbiomes are developing in that year. The brain is developing at that year, and that's how most of the speakers, which are motivator speakers, they say, spend your life alone, but give 7 years of your child life with you. 7 साल का जब तक आपको बच्चा न हो जाए, तब तक आप उससे अलग न हो जाए, because that is the time when everything is being, given to the child. After that, what habits he develops, this will persist throughout the life, and that's how. And unfortunately, because of this, scenario of overwork, the childs are with the maid. They give some ready-made food. The ready-made food alters the biome alters the brain, and ultimately everything, and psychology also changes. So why the psychology changes? Because of this. Because we are not giving 7 years of precious time of the child with us. And I have seen many parents who have given enough time after that, but not, unfortunately the time has lapsed, and that 7 years is during that the regular social behavior, depression, physical performance, motivation, everything occurs. Most important, the cells are CNS cells are vectored are glial cells, and we have been taught that glial cells is nothing but the supportive cells. Unfortunately, we have been taught that glial cells are supportive cells. But mind it, glial cells are not only supportive cells. They do lot of functions. And ultimately, the glial cells are the target for the neurotransmitter, this gut and brain axis. And because of this, the alteration of the glial cells leads to the pathological conditions. So, role of microglia in the neurodegenerative diseases. Microglia are primary innate immune system in the CNS, 10% are in the CNS, and ultimately they are not only the supportive cell, they are involved in the neurogenesis, angiogenesis, blood-brain barrier integrity, which is very important. Then synaptic pruning, synaptic transmission, myelin health, etc., etc. So microglia-mediated neurotransmission, neuroinflammation ultimately leads to the adaptive changes. And once the microglia loses its homeostasis process, leads to the brain dysfunction. So ultimately the clue is that we are having the active cortex, active nerve cells, along with the microglia. Microglia are not only for the support, they are doing more than the support for the normal physiological function of the brain. And chronic microglial activation ultimately leads to the neurodegeneration. So role of microbiota in the gut-brain axis is, it can be locally, it can be directly to the CNS. So disruption occurs in the gut-brain axis, determines the change in the intestinal motility, visceral hypersensitivity, cellular alteration, intraendocrine and immune system alteration, and other multiple pathological conditions. So gut-brain axis is structure I have told, and one more thing. One is I have emphasized the microglia. The second I am emphasizing the HPA axis. Now HPA axis is also disturbed by the altered microbiome. And this again, if you alter the HPA axis, you are actually giving a gate, opening the gate for multiple diseases. Just you alter one axis, HPA axis, and you open the gate for the thousands of the diseases. And that's how this microbiome gut axis becomes very important. So the entire microbiota, bidirectional communication, again it is emphasizing, and it can be itself modulated. So it's strange but true. There is development and maturation of the both ENS and CNS by the microbiomes. And the most important is that whatever we teach to our student and we think this is of less importance, that is brain-derived neurotrophic factor. Now this is the most important things which can occur, which can be dearranged by the these. So I will give three messages. One is microglia, second is HPA exchange, third is this. If you remember three, more than enough. My job is done. So from gut to the microbiota, these things are happening, and from brain to the gut microbiota, these things are happening. Means in the reverse direction, both sides. So everything, every message is conveyed from the gut to the brain and brain to the gut in this fashion. So microbiota can interact with the gut-brain axis. Local neurotransmitters generate nitric oxide. Now, one time was there, around 2000, when everything was around, suddenly it came, nitric oxide, nitric oxide, nitric oxide. खाना खा लिया, nitric oxide. आँख से कम दिख रहा, nitric oxide. नाक से कम सूंघ रहा, nitric oxide. Everything is nitric oxide. Now see the beauty. Nitric oxide is affected by this also. So ultimately, you can see that this nitric oxide, which was the core pinpoint for any disease, now again this is correlated with the microbiota. So I have again told you salt chain fatty acid, and to convert the bad fat into this, and that leads to the again potential for the development of the diseases. So microbiota can affect mucosal immune system and all these, which are the most important that I will touch, otherwise I will skip. So CNS effects and bacteria is there, and our microbiota alteration can give the chance for the alteration of the or overexpression of the other non-needed type of microbiota. So nothing to have, just one line that this can be a potential adjuvant therapy for the treatment of the CNS diseases and other diseases. So microbiota based therapy, they can be prebiotics, probiotic, symbiotic, combination of these two, fecal microbiota transfers. When I was reading this for the presentation, I just remember one prime minister from this place only, India, who was actually known for something, and nobody was knowing why he is doing this. Now that time I clicked, my mind clicked, whoa, that was the reason. Can you imagine? Can you know? What is the name? Morarji Desai. Now Morarji Desai was famous for drinking the own urine. Now see, what was the reason? Nobody can imagine कि ये किस लिए कर रहे थे. Now this was the reason. When you can take medicine in the form of medicine, the fecal matter of the other person, taking the urine to balance our microbiota is more acceptable. And he was knowing the science behind. And that's why he was, and mind it, अब जब ये पढ़ रहे थे, then I thought कि यो हो, अगर आपका अच्छा है, मतलब you can have a good business also, provided you have, हाँ, अब यही तो होने जा रहा है, बोले, बोले आपके घर में हम आएंगे, कै बजे करते हैं? सच में सर क्या होगा? एक लोटे में जा रहे हैं, लेके चले आ रहे हैं, फिर उसका कैप्सूल बना रहे हैं. And that is how this thing is to happen. Fecal microbiota transplant. Transplant का कोई काट के थोड़ी निकाल रहे हैं, कुछ नहीं कर रहे हैं. ट्रांसप्लांट का पहले मैं भी सोच रहा था कि ट्रांसप्लांट जैसे किडनी ट्रांसप्लांट है, काट के निकालेंगे, उसमें काट के निकाल के डालेंगे, फिर चिपकाएंगे, ऐसा कुछ नहीं है. इट इज जस्ट नेम हैज बीन गिवन ट्रांसप्लांट. व्हाई जस्ट एनीबॉडी टेल व्हाई नेम हैज बीन गिवन ट्रांसप्लांट? हाँ बहुत बड़ी. और जिनको एक्सेप्ट हो जाता है वो छोड़ते नहीं है. नहीं सच में यही रीजन है. आपने आधा आंसर दिया. ट्रांसप्लांट नाम इसको इसलिए दिया गया, इसको ऐसे कर देते फीकल म्यूकोबायोटा सप्लीमेंट. ठीक है, ट्रांसप्लांट नाम इसलिए दिया गया बिकॉज दिस इज इम्यूनोजेनिक. नाउ दिस कैन नॉट बी एक्सेप्टेड बाय एवरीबॉडी, सो फॉर दैट यू हैव टू मैच. Now this match if occurs and that fecal matter goes and is stuck, now this remains permanent. Transplant remains permanent. ऐसा नहीं होता कि आज किडनी कराई फिर करा दी. So like that, this is the difference between the prebiotics, postbiotic, symbiotic and the fecal microbiota transplant. Because here the bacteria will go, this will make the colony and it will stick, remain for long time. And that is how this is there. So, thank you madam, I learned many things. Prime Minister was doing this, then why it is transplant, because हमको ना देते आप topic तो हम क्यों जानते हैं, ठीक है? And then we can explore a business also, ठीक है? So, standardized FMT products are coming, and ability to transform the microbes and integrate supporting ecosystem. This is the timeline of FMT. It started in the 4th century in China. China is every time, whether it is COVID or whether it is FMT. It started in the 4th century and now it is at the verge of the regulatory approval. So, and in between something happened. So is FMT is just another probiotic? No. FMT provides and engrafts for the longer changes for the gut microbe. FMT and probiotic difference are more effective in the restoring the diversity and richness, whereas probiotics are transient. Complete sample of the donor's microbes, typically only 1 or 2 types. Provides full engraftment, whereas doesn't full engraftment of the gut microbe, and it is more significant and long lasting where it is not. So microbiota gut-brain axis from motility to mood. So not only motility to mood. 2 brains they talk together. New gut understanding equals new treatment opportunities. And gastroenterologists are like counselors, looking for ways to soothe the second brain. And psychological intervention like CBT may also help to improve the communication between the big brain and the brain of the gut. So these are the gaps which can be fulfilled by the research. Any PG can take, thesis over this, like immunological effect of the human gut, microbes and their role, mapping of the microbiota, contribution of the specific microbe to the brain, and others. There are need for better and more targeted clinical studies and evidences, and emphasize on sharing and collaboration of the research. Not one pharmacologist and not one person is going to do anything. So future research point on the gut-brain action may be like this: rapidly developing safe and effective metagenomics, metabolomics, animal models, human intervention studies, and we using the big data analysis. World has data, and data. But unfortunately, these data are not in the form of analysis. So first thing is that data should be, segregated, and ultimately these data should be analyzed through the whatever we are having, through the machine learning and other AI. And if possible, the longitudinal studies of from the child to the old one. Now that is how these studies can give the evidence for that second brain and the first brain through the microbiota, and intervention studies if possible, provided the ethical approval of the institute and other they are given. So perspective are there, many more, and we are focusing from the first brain to the second brain to correct the first brain. So these are the key messages. And the most important key term which I found, that is psychobiotics. Now when we convert these microbiota into the normal, and the psychology or the depression and everything changes in the person, now they can be called as a psychobiotic. So this term has been coined, this term is there. And FMT is upcoming neurobiological therapeutic strategy. And HPA axis, I told you 2, 3 just to remember. One is GIT damage, second is that, and the third is SPA axis, microglia, nothing more. Just focus over these 4 terms, and most other things will be known. So thank you for your kind attention. And any question, any comment, most welcome. Any offer for this FMT, most welcome. Yes, please. लड़कों के लिए ही है ये, एक्चुअली लड़कों के लिए ही था. तुम लोग मिस कर गए, तुम लोग खाना खा के निकल गए. ठीक है.
Sir, you have told about the case of Morarji Desai, sir. Sir, will it not cause infections when it there? Or any, for example, while doing this, will it not disturb our homeostasis, like causing water loss or some kind of?
खाना खाया है?
Yes, sir.
खाना नहीं इन्फेक्शन कर सकता.
No, sir, but the chances are.
अरे यार तेरी अपनी है, उसमें तेरा ही तो सब माल है, उसमें क्या इन्फेक्शन करेगा? वो तो प्रूवन है तुम्हारा है. इससे बढ़िया साफ पानी कहाँ रखा है? इतनी बड़ी फिल्टर से निकल के आ रहा, नेचुरल फिल्टर.
Sir, and what about homeostasis? Sir, we are body is excreting those things and we are.
कोई बात नहीं, फिर से निकाल देगा, काम भर कर ले लेगा, फिर निकाल देगा, उसमें कौन सा आफत है?
सर किडनी पे लोड ज्यादा नहीं
अरे कहाँ से लोड पड़ रहा है? पी रहे हो ना, वो किडनी में थोड़ी डाल रहे हो. वो पी रहे हो, वो पीते थे, किडनी में थोड़ी डालते थे लोग, किडनी मॉडल दिया.
वही दोबारा सर जो
वही दोबारा
एक्सक्रीट करना.
यस, रिसाइकलिंग.
किडनी को दोबारा वर्क करना पड़ेगा.
रिसाइकलिंग. इट इज नोन एज रिसाइकलिंग. अच्छी चीज फिर से ले लो. ठीक है. सारी चीजें घर से जब निकाली जाती हैं, जब तुम निकाल के रखते हो तो वो तो तुमने फेंकने के लिए रखा हुआ है ना, फिर क्या होता है बताओ?
सर पर जो हमने
तुमने फेंकने के लिए रखा हुआ है, फिर क्या होता है? वो फेंकने के लिए जब रखे हो तो मम्मी आती हैं, ठीक है, उसमें से 90% फिर रख लेती हैं, क्योंकि उनका पैसा लगा होता है. जब तुम बाप बन जाओगे तुम भी रख लोगे. ठीक है, तुम्हारे लिए बेकार है. ठीक है. अब उनके लिए तो उनका पैसा लगा, सोचती चलो कुछ नहीं तो ये इसमें काम आ जाएगा, इसमें. अरे और कुछ नहीं है, प्लास्टिक की जो झोली है वो उठा के रख लेंगी. ठीक है, अभी सब्जी के काम आ जाएगी. डब्बा है, इसमें गमला लगा लेंगे. रिसाइकलिंग. बैठ जाओ.
यस सर, थैंक यू.
हाँ बोलो
सर. ये जो इसने बताया, अमृत ने बताया कि
अबे तुम उसका चक्कर ना जाओ. देखो सर, ये कुछ नया पूछो.
ठीक है सर. हाँ सर, ये चीज तो पहले भी अपने तो आयुर्वेदिक के हिसाब से भी चल रही है, वो गौमूत्र का वो.
अरे तुम यार कहाँ थे अभी तक? तुम गौमूत्र पीने के लिए तैयार हो, अपूर्ण मूत्र नहीं पूछ रहे हो. जबकि अपूर्ण मूत्र में तो आपका सब कुछ अपना ही है. अब बोलो. हाँ,
सर ये वही आइडिया
यही हम चाहते थे यार, ये लड़के मिले, तुम लोग लड़के सब है नहीं, बुड्ढे को क्या पढ़ाओ, चलो ठीक है। हाँ बोलो बोलो। हाँ
सर ये आइडिया वहीं से लिया गया है क्या? कि जो जैसे गौमूत्र का था कि वो सेम इफेक्ट वही करता है, मतलब जैसे कि
यार
प्रोबायोटिक का से।
हाँ यही है, यही है, यही है। एक हाइपोथेसिस ये है, और एक चीज सुन लो, एमबीबीएस कर रहे हो?
जैसे मैं फिजियोथेरेपी।
हाँ, कोई चीज, यही तो मेडिकल साइंस की ब्यूटी है, कोई चीज है और कोई चीज नहीं है उसी समय, ठीक है। 100% कुछ नहीं है। गौमूत्र कैसे करती है? माइक्रोबायोटा ठीक करती, 100% नहीं, ठीक है। गौमूत्र कैसे करती? इलेक्ट्रोलाइट बैलेंस करती, 100% नहीं, सब मिला के कुछ ना कुछ करती है और हो रहा है, ठीक है। और कुछ?
थैंक यू सर।
ठीक, और कोई? अरे बोलो यार, जग जाओगे इसी बहाने, जग गए हो बल्कि, ठीक है। हाँ मैडम कुछ बोलेंगे, चलो आप बोलोगे कुछ? हैं? नहीं कुछ तो बोल रही थी उससे। अरे हम सब देख रहे थे।
थैंक
यस यस, न्यू कॉन्सेप्ट एंड एक चीज बताएं, ये जब कॉन्सेप्ट डिलीवर होते हैं तो ये कॉन्सेप्ट कहीं ना कहीं से पैदा होते हैं, और मजे की बात है जो दिमाग में पैदा होती हो जाती है, होती है। हम लोग हो सकता है तब तक न रहे, ठीक है। लोग जो है जाके 180 रुपए का कैप्सूल ले रहे हो FMT का, और बड़े गर्व कर, आई एम टेकिंग FMT, आई एम टेकिंग FMT, ठीक है। तो ये आएगा, कॉन्सेप्ट आएगा, बिकॉज व्हेन द थिंग्स आर प्रूव्ड एंड दिस इज नेचुरल, तो नेचुरली आएगा। बताइए मैडम, और कोई? हाँ मैडम पूछिए।
नहीं सर, आई बस जस्ट वांट टू थैंक यू फॉर गिविंग अस दिस टॉपिक फॉर फूड ऑफ थॉट। इससे मैं आई वांट टू कमेंट कि जब हमारा 2-3 दिन तक पेट ठीक नहीं रहता तो मूड खराब हो जाता है।
बहुत सही,
और
बहुत
अगर
सही।
नींद नहीं आती ठीक से 2-3 दिन तक तो हमारा पेट खराब हो जाता है।
बहुत सही, देखिए कितना बढ़िया कोरिलेशन है, कितना बढ़िया कोरिलेशन, बहुत बढ़िया, बहुत बढ़िया।
थैंक यू सर, थैंक यू।
और हेडेक का सबसे बड़ा कारण यही है, कहते हैं कि हमारा आज पेट नहीं साफ हुआ, जब पेट नहीं साफ हुआ तो हेडेक हो रहा है, और पेट साफ हो गया तो ठीक हो गया। पता नहीं कहाँ से जादू होता है, कुछ ना कुछ होता है, एंड नोबडी नोज कि कैसे होता है। तक हम भी सोचते थे कि ऐसा कैसे हो रहा है, लेकिन होता है, सबके साथ होता है। बहुत बढ़िया सर।
Thank you, sir. It's a quite energetic and new topic, and you delivered in a very basic and simple way. There are 2-3
खाना खाने के बाद अगर सर हम इनको ट्रांसमीटर बढ़ाते, जो ये 12 हैं ये भी चले जाते।
सर 2-3 पॉइंट मैं भी जोड़ देता हूँ। मैं ENT से रिलेटेड करता हूँ।
जी सर, जी सर।
आई एम रिलेटेड टू ENT डिपार्टमेंट।
जी सर।
एंड आई एम इन कॉन्टैक्ट विद पेशेंट्स सिंस 1986। जो मैं ये बताना चाहता था कि जो हमारे जैसे लोकेलिटी में जो मोस्ट इलिटरेट पर्सन्स होते हैं, बिल्कुल अनपढ़ होते हैं, जो पढ़े लिखे हैं तो वो तो शर्माते हैं थोड़े, अनपढ़ आदमी एक कंप्लेन किया करते थे ओपीडी में भी कि जी मैं वैसे, क्योंकि ENT का और थोड़ा GI का थोड़ा संबंध होता है, भाई हाइपर एसिडिटी है तो थ्रोट प्रॉब्लम्स और लैरिंग्स की फेरिंग्स की प्रॉब्लम्स है, तो मैं पूछ लेता था कि भैया पेट ठीक है, तो वो इन्वेरेबली जो इलिटरेट और बिल्कुल ऐसे पेशेंट हो वो सीधा कहते हैं, बोला जी पेट में गैस बनती है, वो सीधा दिमाग में टक्कर मारती है।
यस सर, यस सर, यस सर। और यहाँ
कहता है जी अपना जो खोपड़ी है ना ये बिल्कुल ठीक नहीं रहती, तो ये मैंने आपको लाइव बताया है। तो डायरेक्ट कोरिलेशन एंड टोटली एग्रीड विथ यू।
यस सर, यस।
एंड सेकंड कमेंट जो सदियों से चलता रहा, जो नेचुरोथेरेपी है, जो बिल्कुल जैसे गांव में भी कोई वैद्य है या कोई भी है तो पुराने स्टाइल से, जैसे हम बच्चे थे तब भी, राइट, तो वो उनका जो ट्रीटमेंट करने का तरीका था तो वो कहते थे जुलाब लगाओ, पेट साफ करो। पहले 1-2 दिन तो वो पेट को साफ करते थे या भाई आपका जुलाब लगाते थे, उसके बाद फिर उसको रीसेट करते थे। और जो आपने जो ट्रांसप्लांट का बात किया ना, मैं कहता हूँ वो इम्प्लांट है।
यस सर, यस सर।
जो पहले आपको GIT और आपका यूरिनरी सिस्टम वगैरह सारा जुलाब लगा के पहले सारा डिफ़ॉल्ट पे लिया है, उसके बाद री इम्प्लांट किया, तो जो आपका कैप्सूल है ना वो इम्प्लांट है,
बहुत बढ़िया,
एट दैट स्टेज.
वेरी नाइस.
So you can give that another term also. Thank you very much.
Thank you.
Okay, sir.
Thank you for waking everybody up. Since gut-brain axis was making everybody sleep, but your excellent way of interaction woke everybody up. So in a way you were more effective than the microbiome that was inside people, and that was making them sleep. But your way of telling was even more impressive more effective than the microbiome.
Thank you, sir. Thank you.
Sir, one thing I want to say is that since in the previous session also Madam said that it is a very ancient science of Ayurveda which we should follow. And what I find is a dichotomy that we are trying to follow Ayurveda but trying to follow it through allopathy. So it will be a holistic kind of thing. If we want to change it, we want to improve our microbiome. So finding the neurotransmitters like interleukin, tumor necrosis and similar factors, it will be very difficult. The only thing is that we should research into the older texts, go to the Ayurveda and try to adopt to that lifestyle. Because fecal matter transplant and similar allopathic type of trend, it will be very difficult to practically take it into the allopathic medicine, because there will be again many issues related to it. So in it the microbiome concept is superb, but the method will be also different than the allopathic pattern of finding evidence and including in the pharmacopoeia and giving it to the patients. Thank you, sir.
Thank you, sir. Thank you.
सर एक क्वेश्चन है मेरा आपसे, इधर सर. सर पहले तो आपका प्रेजेंटेशन के लिए मैं मतलब थोड़ा बताना चाहूँगा, काफ़ी अच्छा प्रेजेंटेशन था. आई गेस मैं MBBS थर्ड ईयर स्टूडेंट हूँ एंड मुझे ऐसा लगता है कि अभी तक मैंने पहला कोई ऐसा लेक्चर है जो पूरा फोकस होकर सुना है. मैं काइंड ऑफ स्टूडेंट हूँ जो मतलब हो जाता हूँ डिस्ट्रैक्ट एंड बोर होके, मेरा ध्यान डिस्ट्रैक्ट हो जाता हूँ, मेरा फोकस
मिल जाना यार थोड़ी देर बाद हमसे.
सर क्वेश्चन मेरा ये है कि क्या अपना यूरिन पीने से इसका कोई कोरिलेशन है अपनी नी हेल्थ से?
तुम देर से आए हो क्या? अभी देर से आए हो?
नो सर.
अच्छा, एक्चुअली क्या है ना कि nobody can say कि this is doing this. There is some correlation which if proven, प्रूव नहीं है, बट आयुर्वेद में इसीलिए तो हम लोग जैसे सर कह रहे हैं आयुर्वेद की टेक्स्ट के साथ जाओ ना. आयुर्वेद में जो लिखा है उस समय प्रूव किया होगा उन्होंने या ऑब्जर्व किया होगा, बट अनफॉर्चुनेटली जिस तरह की स्टडी उन्होंने करी या जो भी किया जैसे भी है वो डॉक्यूमेंटेशन गायब है बिकॉज ऑफ मेनी रीजन. ठीक है. सो अब हम अगर हम चाहते भी हैं, क्योंकि आज की साइंस क्या है, एविडेंस बेस्ड मेडिसिन. नाउ नोबडी विल एक्सेप्ट एनीथिंग विच इज रिटन इन द textbook in the Ayurveda. Nobody, no science will accept till the evidence are generated. Now here comes the gap. The results are there, the drug is there, the evidence are lacking. अब ये लैकिंग एविडेंस है तो इनको साइंटिफिक ढंग से ही बनाना पड़ेगा, देन ओनली दिस ड्रग विल बी एक्सेप्टेबल इन आवर सोसाइटी, जिसमें हम लोग कहते हैं हम लोग वी फॉलो मॉडर्न मेडिसिन. मॉडर्न मेडिसिन की जितनी भी ड्रग्स हैं सर, दे आर फ्रॉम आयुर्वेदा. 90% ड्रग्स. ओनली थिंग इज दैट आयुर्वेदा वाज अ वन थिंग, क्रूड मेडिसिन मीन्स होल ऑफ द थिंग्स आर गिवन. Second is the evidences were there at that time, but unfortunately at this time they are just known as a correlation. So this evidence has to be, now suppose you say what is the evidence that urine intake will produce better health. There may be, provided we have to do a very good blind study, a clinical trial, and then we have to do all sort of clinical methods, and then if you can create the evidence, 4 साल में 10 साल में प्रूव हो जाएगा कि दिस यूरिन कैन बी अ बेटर थिंग फॉर द नॉर्मल फिजियोलॉजी और नॉर्मल हेल्थ.
यस सर, एक्चुअली मैंने क्वेश्चन इसलिए पूछा क्योंकि अभी रिसेंट में जैसे अनुपम खेर सर है, उन्होंने एक पॉडकास्ट में बताया कि उनको नी प्रॉब्लम थी और उनको बेड रेस्ट दिया गया था बहुत टाइम के लिए, बट एज किसी ने उनको एडवाइस किया और उन्होंने अपना यूरिन पिया 1 महीने के लिए और वो ठीक हो गए। तो वो एक फेमस पर्सनालिटी है, लोग उन्हें फॉलो करते हैं। तो इस तरह के लोग अगर पब्लिक में कुछ बोलते हैं ना, तो उन्हें लोग फॉलो करने लग जाते हैं।
यही पे गड़बड़ है। फेमस पर्सनालिटी जो करते हैं वो हमको फॉलो करना है कि नहीं करना है, उसके लिए बीच में है एविडेंस।
यस सर।
जुबा केसरी जुबा केसरी कौन सा है वो?
बोलो जुबा केसरी।
बोलो जुबा केसरी कौन कहता है?
अजय देवगन।
अजय देवगन। और कौन कहता है?
शाहरुख खान।
शाहरुख खान। अब शाहरुख खान है ना, वो कहते हैं बोलो जुआ केसरी, तुम भी करो। अब वो क्या, वो एडवर्टीजमेंट किसके लिए कर रहे हैं? इलायची के लिए। तुम कौन सा जुबा केसरी करोगे? तुम कौन सा करोगे?
गुटका।
गुटका। वेरी नाइस। नाउ दिस गुटका विल पटका। ठीक है। एंड दैट्स हाउ एवरीथिंग इज पॉडकास्ट बाय द सेलिब्रिटी शुड नॉट बी फॉलोड एज सच। ठीक है। ये उनकी जिंदगी है, ये उनका परसेप्शन है, ये उनका परसेप्शन है। ठीक है। देखो सर ने धीरे से कहा बंद करो। ठीक है। देखो ऐसे रखा, बोले यार चुप रहो, बस बंद करो। ठीक। बड़ी अच्छी स्टाइल थी। ठीक है। उधर से घूम के आया ऐसे। ठीक है। क्योंकि अपने को मजा आ रहा, लेकिन फिर भी जो है चुप रहो। ठीक, समझ में आया? किसी एक का नहीं, एक पे नहीं जाना कभी। ठीक है।
थैंक यू सर।
ठीक। One person experience doesn't mean any treatment, any generalization. ठीक है। चलें? ठीक सर। वो मोमेंटो दिला दो।
उसी के लिए आ रहा हूँ सर।
Thank you so much, sir. It was truly an enlightening and intellectually stimulating session, and we had very animated discussion over here. So I would now like to request Dr. Jyoti Kaushal ma'am, Dr. Savita Verma ma'am, Dr. Sunil sir, and Dr. Jyoti Khanna ma'am to kindly come on stage and felicitate our speakers and chairpersons. A big round of applause for sir. Thank you so much, everyone. We will now commence with a much awaited session for the today, and that is panel discussion. For that, I would like to respectfully invite Dr. Jayant Kumar Carey sir, Senior Professor and Head Department of Pharmacology, Kalpana Chawla, Government Medical College, Karnal, and Dr. Preeti Gehlot, Professor, Department of Anesthesia, PGIMS, Rohtak. I request both of them to lead us forward.
Thank you so much.
While the chairs are being set for the panelists, good afternoon everyone. Myself Dr. Preeti. I am professor in Department of Anesthesiology at PGIMS Rohtak, and I welcome you all to this highly awaited panel discussion like she rightly pointed out. The topic for today's panel discussion is microbiota medicine towards clinical revolution, and rightly so. But before that, first of all, I would like to thank Dr. Jyoti Kaushal ma'am and the organizing team for providing me this opportunity. And I congratulate the Department of Pharmacology for selection of this highly relevant theme that focuses on the microbiota. Ladies and gentlemen, we are standing at the forefront of a transformative era in healthcare, where our understanding of the human microbiome is reshaping the way we approach diagnosis, treatment, and prevention. From gut health to mental health, the microbiota's influence is profound and increasingly undeniable. So, first of all, I invite Dr. Jayant Carey, Head of Department Pharmacology at KGMC Karnal, my co-moderator, on the stage. So I welcome you, and I request all the persons here, please welcome our panelist and our moderator with a loud round of applause. Over to you, sir.
Thank you, madam, for the introduction, and my heartfelt thanks to Dr. Jyoti Kaushal ma'am for giving us an opportunity to host this panel discussion. And we'd like to invite now our panelists, Dr. Sunita Singh, Senior Professor and Head of Pathology Department, PGIMS Rohtak. Ma'am, please. Dr. Savita Singhal, Senior Professor and Unit Head, Obstetrics and Gynecology, PGIMS Rohtak. Ma'am, please come over. Dr. Praveen Malhotra, Senior Professor and Head, Gastroenterology, PGIMS Rohtak. Dr. Madhu Sharma, Professor Microbiology, PGIMS Rohtak. Dr. Yogender Malik, Professor Forensic Medicine, BPS, Government Medical College for Women, Khanpur, Kala, Sonipat, and Chairman, Ethics Board, National Medical Commission. Welcome all the panelists, sir.
We all know that gut microbiota is a community of trillions of microorganisms living in the digestive tract that affects our gut health and overall health. So, we begin the session with all our panelists. With due permission from the panelists, if they are ready, we'll begin with the moderation.
To open the discussion on this interesting topic, we'd like to know from Dr. Madhu ma'am regarding what is the microbiota composition in health, and what are the lab testing techniques, and how do they change during various pathological states and disease states?
Yeah, good afternoon, everyone. Actually, good evening. After Dr. Dikshit's lecture, I think I'm not going to make it boring by telling you what is the normal flora. Since morning we have been discussing on what normal microbiome is, and it mainly constitutes of most of the anaerobic organisms and other bacteria and fungus and other things. If you have changes in your normal flora, and if there is some pathology, it leads to disease, dysbiosis. So whenever there is some dysbiosis or there is change, the pathology or the pathogen which increases in number, it leads to infection. So there are various parameters which are there. You can go for detection of whether there is change or dysbiosis which is occurring or not. You can go for the metabolite detection. You can look for what is a normal microbiome which is present, whether the commensal is there or not, if it has been replaced by a pathogen, or if there are resistance genes which are present which can indirectly point to that there is some dysfunction which is going on in the body.
Ma'am, What are the resistance patterns and fungal infections when affected by these, affecting these microbiota or the normal microbiome? How do the disease process affects them?
The disease process affects the organism. They are replacing the normal flora, and when the pathogen number increases, so naturally the normal metabolic pathways are replaced by different pathways. So there is increase in the metabolites by the pathogen. The long chain fatty acids, they are increased. The toxins produced by the pathogens, they are increased, leading to dysfunction in the GI tract.
Thank you, ma'am. Sunita, ma'am, coming to you, ma'am just mentioned dysbiosis in the microbiota. So, ma'am, what are the histopathological changes due to this dysbiosis that affect things like chronic inflammation or epithelial injury? What's the mechanism?
Good afternoon. If you want to know the pathology, I think this is basic that you should know the physiology. So one should know that what these microbiota are doing in the body. So foremost, as Dr. Dikshit was covering it all, that they regulate basically the immune system, both the innate immunity as well as the adaptive immunity. Both immunities are regulated. So once this immunity is dysregulated by dysbiosis, so what happens is that it will lead on to immune destruction of the tissues or immune imbalance, which will cause the damage to the tissues and inflammation. Secondly, another thing which this microbiota is doing, microbe, they are acting as a physical as well as chemical barrier in the intestine. So once this is disturbed, so this barrier is lost, this is leading on to epithelial tissue cell injury. The epithelium becomes injured, the tissue becomes leaky, so that the toxins, they all can travel from the gut to the bloodstream and to the various organs. So that is how from the gut it is going on to the various organs and causing the damage.
Thank you, ma'am. Moving on to the role of the gut flora in certain gastrointestinal diseases, my question to Dr. Praveen sir is, sir, how does the gut flora or the microbiome change in conditions like irritable bowel syndrome and inflammatory bowel disease?
अभी हम डॉक्टर दीक्षित साहब के लेक्चर पे सुन रहे थे जी, हेडेक होती है लोगों को बैक्टीरिया से, पेट खराब हो गया, ये गैस्ट्रो की कॉन्फ्रेंस में सबसे बड़ा मुद्दा है। वो हर कोई ये ढूंढता है कि ऐसी कौन सी गैस है जो पेट से दिमाग पे पहुंच सकती है। रियलिटी है नहीं पहुंच सकती। अगर किसी की गैस पेट से बाहर आ गई, दैट मीन्स आपकी डेथ होने वाली है, आप पेरिटोनाइटिस के अंदर है। आपके गैस निकलने के दो ही आउटलेट्स हैं, या तो माउथ है या एनस है, बाकी सब जगह बोन्स हैं। बेसिकली इट इज़ अ एंग्जाइटी रिलेटेड। आप स्ट्रेस में है, एंग्जाइटी है आपको, इस वजह से IBS। हर गैस्ट्रो की OPD में 30% ऑफ द पेशेंट एट प्रेजेंट सीन इन डिफरेंट मेडिकल कॉलेजेस और प्राइवेट सेक्टर इज इरिटेबल बाउल सिंड्रोम। और उसका सबसे गट लीवर एक्सिस ओबेसिटी आपको मिलेगी, आपको उसके अंदर IBS मिलेगा, उसके अंदर आपको फैटी लीवर मिलेगा। बिकॉज वो गट के जो माइक्रोबायोटा हैं वो इन्फ्लामेशन सेट इन कर रहे हैं आपकी, और इस वजह से वो लीवर के ऊपर भी अटैक कर रहे हैं। तो बहुत सारे एक्सेस हैं, गट ब्रेन एक्सेस है, गट लीवर एक्सेस है। IBD इंडिया के अंदर अब्रॉड दो मेन हैं आपका, क्रोन्स है और UC अल्सरेटिव कोलाइटिस। वी आर लकी इन इंडिया कि हमारा UC प्रीडोमिनेंट है। 95% पेशेंट जो इंडिया के अंदर वो अल्सरेटिव कोलाइटिस है। क्रोन्स का प्रोग्नोसिस गंदा है एज कंपेयर टू UC। अब्रॉड के अंदर 50-50 है। गट के अंदर कोई भी माइक्रोबायोटा आएगा, बॉडी क्या बैलेंस है, अच्छा बैक्टीरिया, गंदा बैक्टीरिया। बॉडी क्या चाहेगी, द नंबर ऑफ गुड बैक्टीरिया शुड बी मोर देन द बैड बैक्टीरिया जो आपकी बॉडी को डैमेज करेंगे। डिसबियोसिस क्या है, आपका बैलेंस हिल गया बॉडी का। आपने बेशक वो डाइट्स खराब जा रही हैं या इन्फेक्शंस हो रहे हैं आपके, आपका हार्मफुल बैक्टीरिया बढ़ रहा है, और वो क्या करेगा, इंटेस्टीन की वॉल है उसके ऊपर उसने डैमेज पहुंचाना है। डैमेज पहुंचेगा, उसके टॉक्सिन्स लगा लो, एंजाइम्स लगा लो, वो इन्फिल्ट्रेट करेंगे और एक क्रॉनिक इन्फ्लामेटरी सिस्टम्स को एक्टिवेट कर देंगे और अल्टीमेटली बॉडी में जब भी रिपीटेड कहीं भी डैमेज होता है और रिपेयर होता है वो मैलिग्नेंसी का हार्बिंगर होता है। दिस इज द वे क्रॉनिक इन्फ्लामेशन होएगी और यही चक्का अल्टीमेटली जाके आपकी मैलिग्नेंसी में जाके कन्वर्ट होगा। सो IBS और IBD दोनों के अंदर गट माइक्रोबायोटा का रोल है। IBD के अंदर तो यस इतनी बार पेशेंट मिस होता है, वो ब्लीडिंग पर रेक्टम करके हेमरॉइड्स करके ट्रीट हो रहे होते हैं और जब हम एटलीस्ट एक पेशेंट रोज हम पकड़ते हैं IBD का जिसके अंदर 95% वो UC का निकलता है। सो दिस इज माय आंसर।
थैंक यू सर। आपने बहुत अच्छे से जो अभी हम बात कर रहे थे, जैसा अन्न वैसा मन और शायद वैसा तन भी आपने बता दिया बहुत ही साफ शब्दों में। सविता सिंघल मैम, आपसे मेरा नेक्स्ट क्वेश्चन है। अभी वी हैव बीन टॉकिंग अबाउट द गट माइक्रोबायोटा. So in females, we all know there's another microbiome in our bodies, which is vaginal microbiome, and a very important one. तो मैम उसकी क्या implications हैं in terms of fertility, pregnancy, and infections in women?
At the outset, I'd like to thank Dr. Jyoti and the organizing team for giving me this opportunity. और आज सुबह से यहाँ माइक्रोबियोटा पे सुन रहे हैं और बेसिकली हम कहते हैं लर्निंग, डी लर्निंग एंड री लर्निंग, पर इसमें तो लगता है वी हैव डी लर्न द थिंग्स, नॉट लर्न, डी लर्न द थिंग्स एंड नाउ इट टुवर्ड्स री लर्निंग. About 50 years back, our lifestyle were very different. Fixed type of diet was there, time interval in the diet was there, so the microbiome was, I think, little towards normal thing. But over these 50, 60 years, so much changes are in the dietary pattern, lifestyle. So that has led to change in the microbiome and these type of conferences and multiple diseases. So main thing, this gut microbiome are mainly, it can affect each and every system of the body. Now we're coming because immunomodulation is there, immunity is affected, and then hypersensitivity is there, hypothalamic pituitary axis, which controls so many systems. So every system is being affected by this dysbiosis or the abnormality in microbiome. Similarly, the gynae part, reproductive science and this obstetrics, they are not free from the effects of dysbiosis or the microbiome. So as far as the vaginal microbiome are concerned, the vagina is in close proximity with the anus and the urethra. So whatever gut microbiome is there, directly or indirectly, they are having effect on the vaginal microbiome. The mostly commonly, but a good microbiome is lactobacillus, which leads to negative, this lower pH of about 4.2, and that is good for the health. Once this is affected, the pH will be little on the higher side. So if we talk of what can happen, various infections, most common bacterial vaginosis can be there if normal microbiome is not there in the vagina. And that bacterial vaginosis is sort of, you can say, STD we can say. And trichomoniasis can be there with this. So this STD can be there in these infections. Once the microbiome of vagina is changed, ascending form, it can change the microbiome of endometrium. And now recent studies are saying that follicular fluid, means in the ovaries, that is also being affected by the microbiomes. So these can be, infections can be there, and so many, it is connected with the vagina. If I can divide into basically three parts. It can be the gynecological condition, it can be reproductive health, and it can be a obstetric implication. So first I can discuss with the gynecological implication which can be there. The gynecological, is it right to discuss the gynecological implications?
Yes, mainly fertility, pregnancy.
So, okay, if you think of the fertility, everything is affected by this. If you think of fertility, starting from the sperm, once the pH of the vagina is changed, the half-life of the life of sperm is affected. Then comes to the endometrium, where the fertilization takes place and implantation takes place. The endometrium will be affected due to some inflammation, due to chronic changes. So that will lead on to the effect in the implantation and fertilization and sperm movement. And once the hypothalamic pituitary axis is affected, so that will lead to poor quality of the oocyte. So not only the normal conceivement, but if the patients on ART, means artificial techniques are being followed, that are also subfertility there, results are poor due to these changes. And again, so many hormonal changes are there in this that can lead to PCOS, that can again affect the fertility in the patients.
Thank you, ma'am. The next question or rather discussion is directed towards Dr. Yogender. Sir, how does gut microbiota is utilized for post-mortem interval estimation, toxicological studies on the dead, and the pharmacokinetics that are associated with it?
Before I come to your question, thank you for asking this. Let me thank the Department of Pharmacology, the head of department, and obviously my childhood friend Dr. Sunil for giving me this opportunity to be here amongst you. And second thing, something related to Dr. Dikshit, that sir, before your lecture, I was very sure FMT means only forensic medicine toxicology. Now, this FMT, the kind of FMT you told, we'll have to, clarify to our students every time we tell them that we are from FMT, what we are, we have to specify. Second thing is, I was reading one book. The name of the book is Civilized Death. And it starts from a sentence which says, "Call me ungrateful." Because he is writing everything like we are in a world where we say we are very developed, and we are actually, when we go through the history of our civilization, we say that we are in the best of the civilizational side of development. And he says that I'm writing all this on a laptop and sitting in a air-conditioned room. But still he says that at some point of time, we need to reflect back and see whether this development is good or bad for us. And I think this generation of this concept of microbiome, it relates, because all of us are discussing that we have to go back to what our ancestor did in the form of Ayurveda, and they were very concerned about that every disease has its origin in the gut. So with this, I'll start answering your question that even in forensic medicine, this has got a relevance, and the relevance is more because we are living in a world of artificial intelligence. Why I'm saying so is, this is not even the clinicians require a particular kind of evidence to bring something into a therapy, but in forensic medicine, we look, because we have to prove it beyond, it's always the criminal justice system, and we have to prove things beyond, probability. It cannot be a probability. So, when you ask me about postmortem interval, this is a very important thing in many cases where we have to tell when this person died. So, there are multiple methods we use. But after this microbiome, we are very clear that we know what exists in a living body and what happens when he dies, and we know various enzymatic changes taking place in the body. But now we know that even the microbiome changes after death. So the way it changes, it helps us, it can help us determine the postmortem interval in the best kind of way, but it cannot be done by simple human beings like us, because there are so many, microbiome, bacteria, fungi, and viruses. So we need to, consider the data which we can generate from the dead bodies over a period of time, and then use various deep machine learning methods to find out the real cause of real time since death, we call postmortem interval. That's what preliminary I want to say, that we'll have to have some data. Till date, we are not using any of the AI application in forensic medicine, but with time, I think when we have such data with us, and algorithms will be generated, and I think after that, we'll be able to have, and this will be one of the very important thing, that postmortem interval can be generated through microbiome change.
Thank you, sir. What wonderful insights from all the panelists. So, ladies and gentlemen, we also know now that alterations in microbiota composition have been implicated in development of metabolic disorders. Metabolic disorders like obesity, PCOD, insulin resistance, so many things that the whole world is suffering from. In fact, number one in non-communicable diseases. So let's find out from our panelists the hows and whys of these metabolic disorders.
To Madhu ma'am, ma'am, in metabolic disorders, what kinds of shifts do we see in Fermi suits or bacteroides ratio, short chain fatty acid producing bacteria, and what are the advances in microbiome based therapies related to it?
We do see the shifts, like as I told you, normal flora जो है वो हमारा totally shift हो जाएगा जब भी कोई भी metabolic disorder होगा, dysbiosis होगा, naturally the pathogen will replace. तो shifting ऐसा नहीं है कि धीरे धीरे होता है. You start slow. It depends upon how much is the multiplication of the organism which is taking place. It's not in totality it is occurring. हो सकता है सिर्फ एक पैथोजन है और वो रिप्लेस कर रहा है आपको जो आपका नॉर्मल कमेंसाल है. फॉर एग्जाम्पल लाइक जस्ट टेक एरोबिक ऑर्गेनिज्म इकोलाई which is the normal flora, which is the normal commensal. Now it is, if you have an infection from Salmonella or Shigella, so the organism will start multiplying. They have a high tendency to multiply faster, so that E. coli will be replaced. And then it will start releasing its toxins and its metabolites. So these can be detected, and these can be taken up for the lab diagnosis. So.
And short chain fatty acid producing bacteria, ma'am, their implication in the roles of metabolic disorders?
Yeah, they can be seen. They are the indirect indicators, and you can look for the metabolites which are produced by the organisms, and it can be done for the laboratory diagnosis to see whether there is some dysbiosis which is occurring or not.
Okay, ma'am. Thank you, ma'am. Ma'am, my question to you, Dr. Sunita, ma'am. In terms of inflammation, there are so many inflammatory markers which are related to the cardiometabolic disorders. Then we know about adipose tissue pathology, which is so important in creation of this inflammation at tissue level. And then the concept of metabolic inflammation, also called as meta-inflammation. So ma'am, what is this meta-inflammation and the role of all of these markers in development of the metabolic disorders?
When we call a meta-inflammation, it is a state when it's a state progression of a very slow, low level of, like we call acute inflammation, we call chronic inflammation acute, like which is coming acutely, and it is a low-grade type of inflammation which is occurring in the body, and this is central to the whole of the pathology. Now, what is happening is this inflammation is occurring in the various organs or the tissues or the vessels. So, this inflammatory process is leading to one thing. One, it is causing inflammation, like vascular damage is causing. So, that is this vascular inflammation. This is central to atherosclerosis. So this is causing atherosclerosis leading to cardiovascular diseases further. And similarly, these adipocytes, you talked about adipocytes. These adipocytes, there is a gut adipocyte nexus also. Like we had brain, we had lung, we had everything. There is gut adipocyte nexus. This gut adipocyte nexus is central to the obesity and also to the insulin resistance, because it is changing, it is causing inflammation of the adipocytes. More of the adipocytes are being produced, adipokines are being produced, which is leading on to insulin resistance. So all these factors leading on to metabolic syndromes like insulin resistance, obesity, atherosclerosis, myocardial infarction, stroke, all those cardiovascular diseases to this. And specific markers, they are same as we are doing for any inflammation, like we do CRP, we do these interleukins, we do ESR, all these will be raised in these individuals.
Thank you, ma'am. During the previous talks today, we have heard about many axes, such as gut-liver axis has also been referred to by the previous speakers. We would like to know from Dr. Praveen sir, what is the role of microbiota in non-alcoholic fatty liver disease, and what is metabolic endotoxemia?
Basically, right now, it's a national project of non-communicable diseases, which includes this non-alcoholic fatty liver disease, which is now termed as metabolic syndrome associated liver disease. NAFLD has changed to MEFLD. Now there is no term like NAFLD, we say MEFLD, because we know it is not a separate entity, it is an arm of a metabolic syndrome in which diabetes is there, dyslipidemia is there, PCOS is there. So this is one part. And everything goes back to insulin resistance for a MEFLD But the contributory role comes from the microbiota also, what I was telling before also, कि irritable bowel syndrome, it proves the gut-liver axis. They say the starting of normally 5% fat is present in the liver of everyone. Once it goes more than 5%, then you start terming it as a fatty liver. But earliest modality to detect is ultrasound, जो 30% फैट आने के बाद मेजॉरिटी पेशेंट में पकड़ता है. तो अल्ट्रासाउंड में फैट नहीं दिख रहा, डिस्पाइट दैट यू कैन हैव अ फैटी लीवर. वो 5 से 30% के लोग बीच के रह जाएंगे. रिफ्लेक्सली जो इसका मार्कर आता है, दैट इज द रेज्ड AST एंड ALT. इतने सारे मरीज आपको आते हैं जिनका अनएक्सप्लेन्ड ट्रांसमिनाइटिस है, और आप जब सब कुछ एक्सक्लूड कर देते हैं उसके अंदर, तो आपकी टर्म बचती है कि ये मेफल्ड है, उसकी वजह से OTPT आपके रेज हो रहे हैं. तो लेटेस्ट जो इसके ऊपर कहा जाता है कि गट के जो माइक्रोबायोटा हैं, अच्छे वाले आपके कम हो चुके हैं, बुरे वाले बढ़ चुके हैं. वो इन्फ्लामेशन सिर्फ इंटेस्टीन की वॉल में सेट इन नहीं करेंगे, वो अल्टीमेटली लीवर में जाके इन्फ्लामेशन को सेट इन करेंगे, जिससे फैट का इन्फिल्ट्रेशन बढ़ेगा. अल्टीमेटली फिर वो चक्का स्टार्ट होगा आपका फैटी लीवर से हेपेटाइटिस के ऊपर, हेपेटाइटिस से सिरोसिस के ऊपर, और सिरोसिस से अल्टीमेटली कुछ पेशेंट के अंदर HCC. इट इज़ कॉल्ड एज सुनामी. 25 to 30% प्रेवलेंस है फैटी लीवर का, नॉट ओनली इन हरियाणा और इंडिया और वर्ल्ड, इट्स द सेम फिगर. तभी अगर आपने पीछे सुना हो नरेंद्र मोदी जी का कि हमें 10% वेट लॉस करो, फैट को रिस्ट्रिक्ट करो, उस पार्ट पे, दैट इज द रीजन द कल्चर ऑफ प्रॉन्टास हैव चेंज टू उपमा एंड इडली. आप उसके ऊपर आए हैं बिकॉज आपका यू डिक्रीज योर वेट, आपका अंदर से फाइब्रोसिस, इन्फ्लामेशन, सिर्फ OTPT कम नहीं होते हैं. इफ़ यू लूज योर 10% ऑफ बॉडी वेट बेस लाइन, आपका फाइब्रोसिस रिवर्स होना शुरू होता है. ओबेसिटी इज जड़ फॉर एवरीथिंग. सो आजकल का टैग लाइन है लिव स्लिम लिव लॉन्ग. आपने कितने 100 साल के लोग देखे होंगे जो मोटे होंगे, मरे होंगे. पतले लोग जीते हैं 100 साल तक, मोटे लोग नहीं जिएंगे उस पार्ट के ऊपर. सो राइट नाउ डेफिनेटली माइक्रोबायोटा हैज़ अ रोल फैटी लीवर के अंदर, बट जो मेन प्रिंसिपल अभी भी फैटी लीवर का है वो इंसुलिन रेजिस्टेंस है. मेजॉरिटी हमारे ओबीस होते हैं, वन टर्म इज कॉल्ड एज लीन मेफिल्ड. 17% के अंदर एक नॉर्मल बॉडी वेट के ऊपर भी आपका मेफिल्ड हो सकता है.
Thank you, sir. Savita ma'am, coming to you regarding the microbiota, we just spoke of its role in fertility, infertility of the vaginal microbiome. But now, ma'am, since we're discussing metabolic disorders, so a lot of metabolic disorders, I mean, the baseline is obesity, like sir just pointed out. हर चीज़ के शायद नीचे जो base है वो obesity से start होता है, fat से. But things like polycystic ovarian syndrome, infertility and gestational diabetes, इन सब में मैम क्या रोल है?
बेसिकली आई थिंक दी PCOS एक एपिडेमिक टाइप हो गया है. लास्ट 20 years हार्डली इंसिडेंस ऑफ 1 to 2%. नाउ इंसिडेंस इंक्रीज सो मच दैट 10 to 20%, मे बी 20 to 30% in adolescent age. The girls are coming with PCOS. So we were saying that we don't know the reason. There is no definite reason. It may be due to dietary changes. And this is, I think, this is the main reason of change in microbiome that is leading to PCOS during adolescent. And also now it has been seen extended to 35, 40 years of the age group also. Previously it started only in the adolescent about 20 years back. Now in the 35, 40 years of age, we are seeing so many patients of PCOS. So the main cause in the PCOS, main is a hyperinsulinemia or insulin resistance. So the microbiome, as already discussed since morning, that it affects the permeability in the gut, change in the dysbiosis is there, leading to insulin resistance, and also effectivity of insulin is being decreased. So this is the main cause for the PCOS, which is increasing due to this. The second, pregnancy is also not free from the effect of the microbiome. In pregnancy, gestational hypertension. Again, 5 years back, hardly 1 or 2 patients in the ward was admitted with gestational hypertension. Now it is again rose to about 5 to 10 times more, the incident gestational diabetes. So again, the reason is a hypersensitivity due to the change in the microbiome. And secondly, the newborn are also not free from the effects. because it has been observed placenta itself are having its own microbiomes. And few of the microbiomes of placenta, if they're raised, that can be responsible for obesity in the newborn, not in the newborn, obesity on the later on in the children. So these three things are being related to metabolic, PCOS, and gestational hypertension, not gestational diabetes, and the obesity in the children.
Thank you, ma'am. We'd like to know from Dr. Yogender, what is the status of knowledge or use of microbiome analysis for cause of death analysis and obesity-related mortality trends, sir?
Like I said earlier, these trends in even in mortality or in obesity, we know something from the clinicians, like sir said, but we do not have much of the data right now related to the forensic medicine, and we are yet to actually explore how this microbiome will help us in deducing the cause of death and all.
Which means we have a lot of data, but we don't have any protocol or any translatable information as yet.
Absolutely. Like I told you, like forensic medicine is not something which is related to only doctors. You have, if you say something, you do something, the lawyers have, they have to be convinced, and more than that, the judges should know, and the evidence you are generating has to be beyond reasonable doubt if you want to prove that. So this microbiome, like for clinicians, for us also, it's in experimental stage. We know about it. We are trying to. There are a few papers about it, but we are yet to use it as a cause of death or something like that. We use microbiology department to find out in some of the cases like septicemia and all that we are doing, but as a whole, coming out with comprehensive this thing about microbiome, we have not done yet as of now.
Thank you, sir. So the gist of this round, if I summarize, is basically watch your weight. Like sir said, that minusing 10% of your own body weight can have immense benefits. And for watching your weight, I'm sure you have to watch your food first. So then we go back to the baseline that watching your food is the ultimate thing to live a happy life. Moving on, cancer is one of the most dreaded disease that I think everybody dreads, and it's on rise, of course. So in fact, as per National Cancer Registry Program, the number of new cancer cases will increase to about 15.7 lakhs in 2025 in India, and about 20 lakhs by 2040. This is the number of new cases that I'm talking of, not the existing one. So let's have some insight from our experts on the role of microbiota with regards to cancer.
My question to Dr. Madhu ma'am is, what is the current status of knowledge about oncogenic bacteria, their role which affects the microbiome, and microbiome modulating interventions in cancer therapy?
It's already known fact that the organisms, they are responsible for causing cancers. There are certain viruses which are there, the bacteria which are there, which are known or linked with the cancer causing. For example, H. pylori, if you know, it is one of the leading, one of the important, not leading, important cause for causing gastric carcinoma. Similarly, there are other cancers also which are there. So any change in your, again we come back to same that any change in your normal flora, if there any pathogen which is there, it is changing totality, your everything is getting changed. The things it is producing, your way of living, then what effect it is causing. Obesity is linked with like cancers, and same way the organisms, they lead to different types of cancers. So it is a known fact. So there are multiple viruses which are linked. For example, hepatitis and H. pylori, Campylobacter, all these, even parasitic infections, they lead to carcinoma. Schistosoma is known for causing carcinoma.
Are there any treatment model? Ma'am, any interventions, microbiome related interventions currently accepted or they are under trial? If you could throw some light on that?
Yeah, what Dr. Dikshit was talking about, yes, the fecal transplant, microbiota transplant, which is in the way, which people are thinking that it might work later on, because it is like we are trying to replace the pathogen and we are trying to put in back the normal flora which is there for the human beings. But again, then you have to keep in mind what type of people are there, what is the sex, age, everything. So you should know what you are dealing with and in which region the person is living. Everything affects. Okay, so there has to be a detailed trials are going on, but not exactly. Then you can go for prebiotics and probiotics, which can help and maintain the normal flora, and they do affect the change, and they bring about to the normalcy.
Thank you, ma'am. So coming over to you, Sunita ma'am. Ma'am, how is a tumor microenvironment affected by these microbiota? Also, microbiome-induced DNA damage, how true is that, and how is it affecting the rate of cancers?
We call them genotoxins. When dysbiosis is occurring, they are producing certain toxins which are called genotoxins. One of them, as I already discussed, is nitric oxide. Right. Then there are certain sulfates which are being produced by these harmful bacteria. So when they cross the gut barrier, they go to the circulation and then naturally cause the DNA damage. That's why they are called genotoxins. Now the tumor microenvironment is also affected. What is in tumor microenvironment? It is the angiogenesis, means new blood vessels are formed in the tumor. There is more promotion of oncogenes. Oncogenes, they becomes activated. So more of the tumor cell proliferation, signaling pathways goes on. So they will lead on to proliferation of the cells. So there will be proliferation of the cells, proliferation of extracellular matrix, angiogenesis. All this will lead on to progression of the tumor and also can cause the metastasis. This is important in the metastasis when there is change in the microenvironment of the tumor. And that is by the genotoxins which are being produced.
Thank you, ma'am. It is known that many cancers are related, or at least they have some relationship with the changes in microbiome. So from Dr. Praveen, we would like to know, sir, what is the current state of knowledge regarding colorectal carcinogenesis and their relationship with microbiomes? And are there any screening implications? Can we use microbiome related data for screening for tumorous or pretumorous conditions?
See, a microbiota in the body can lead to cancer formation in many ways. First, foremost, it can be the direct effect, what you are asking from a colon. If you go in a stomach, H. pylori, it's a well proven. In developing country like India, 70% of us are having H. pylori. It's a normal commensal. You label it as an active infection once clinical manifestations are there, endoscopic finding is there, and you prove it histopathologically. But if you calculate how many people can develop malignancy due to that, 70% normal commensal is a big chunk. Other thing for colon, it comes from the, as madam was saying, genotoxins, E. coli. It can lead to that. So one mechanism of causing cancer is a direct effect. Other, we know the same path of a setting in of a chronic inflammation by increasing the number of pro-inflammatory cytokines, IL-17, TNF, or a decreased number of good cytokines, regulators T-alpha. Other can be environment what we are getting, metabolism, maybe a hormone metabolism, or certain things or toxins directly bacteria inside is producing down. Other important thing is a DNA repair, because we know damage is going on, they can impact that. So ultimately, the spread also depends upon the gut microbiota also. Okay? What environment they are getting, how much they can spread, where they can spread, the extent of it. And the last part, can we have such data which can predict? Right now, it is an open box. More research has to be done before labeling it at yes, these are the exact figures, in which amount they are there, then it can be significant. Right now, for clone screening, it is mainly a colonoscopy, what we advise. If somebody is having ulcerative colitis, he or she is on a treatment, we say if it is a pancolitis, go for a screening colonoscopy at 7 years of age. If it is a diverticulitis, then go for a 10 years of age. In certain countries, there were high incidence of CA stomach. So they went after 30 years or 40 years, start screening for the endoscopy for the CA stomach. In India, as of now, or maybe out in the world, these data have to be collected before reaching to a final conclusion for that.
Thank you, sir. So as of now, colonoscopy is the only screening method, and we're not using any microbiomes as such for screening. Thank you, sir. Ma'am, coming to you, Dr. Savita Singhal, ma'am. We spoke of vaginal microbiome. Ma'am, then there's another virus that is responsible for cancers, human papilloma virus. So ma'am, these vaginal microbiomes, do they kind of affect the HPV persistence in cervical cancer? Also, apart from that, ma'am, any role of this microbiota in the endometrial pathology?
Basically, in gynae, there are 3 cancers, which one is cervical cancer, endometrial, and ovarian cancer. Though so many theories are there what can be affected, so HPV is the main culprit for the CA cervix. So though we say so many reasons are there that HPV can be infested in the vagina, and it is normally present in most of the women, but doesn't lead to CA cervix. And what can happen, though it is again a theory, it is not proved that change in the microbiota can lead to these changes for the cervical cancer. But one of the proposed theory is that once the microbiota is disturbed, and the HPV, which usually if it is present and after 80% of the women, it will disappear after 1 to 2 years. It can cause persistence of the HPV virus in the vagina. And if persists for a longer period, it can lead to CIN, means cervical intraneoplasia, means precancerous lesion, which can progress on to the CA cervix. So this is one theory, though it is not proved. We cannot say the proper data is there for that. And similarly, for the endometrial cancer, there are 2 things. One is this theory is a hyperestrogenemia. So these microbioma can be correlated that one of the estrobiloma are there in the gut, and that estrobiloma can lead to more and more of the estrogen production. And these hyperestrogenemia, and moreover the chronic inflammatory changes in the endometrium and change in the endometrial microbioma sometimes that can lead to the high chances of endometrial cancer. And one thing I want to add, not related to this, and this our infants and toddlers are also not free from the effects of microbioma, especially the breast milk. The infants, the newborn born to the mothers who deliver by the cesarean section and who are not the breastfeeding, they are poor in the microbioma and can have immunological effects, and neurological department development is also affected in these kids. So vaginal delivery and breast milk is a protective for the newborn and the children.
Thank you, ma'am, for your elaborate answer. Coming towards the end of the panel discussion, we would like to know from Dr. Yogender regarding microbiome in tumor lysis syndrome and cancer cachexia, forensic histopathology or malignancy. What is the state of present knowledge in its relationship with microbiome, sir?
To be truthful, in forensic medicine, we generally do only medico-legal autopsies. We don't do pathological autopsies, unfortunately. The rate has come down even all over world. So if you theoretically ask me, there are papers I can tell you, but to be practical, we are not doing much in this field. Even if like a medico-legal case come to us in mortuary, it's always brought by the police. So cancer research and this all I think we don't do. Right now we are not doing it.
Hello, can I answer this?
Yes, ma'am, please.
Actually, we were talking about all the cytokines like interleukins, interleukin 6, 10, 17. All these interleukins, tumor necrosis factors which are released, they all lead on to cancer cachexia, and this muscle wastage and all those things in cancer patients because of those cytokines.
Thank you, ma'am, for adding to it. So with that, we come to the end of this panel discussion. I thank my co-moderator, Dr. Jayant Carey, sir.
Thank you, ma'am.
And I thank all the panelists having such expert people with such crisp, concise and time-bound answers. I'm so thankful to each and every panelist. Thank you, ma'am. Thank you, sirs. And with that, I thank everyone. We'll come to the closure of this session. And if time allows, I think we can have one or two concise questions if we have from the audience. Okay, I have one question from Dr. Praveen, sir. Sir, the role of probiotics, how far can we go? Like, it is being publicized so much. So should a person just go to a pharmacy store, buy as much and take as much?
See, प्रोबायोटिक्स आप अगर जापान में जाएंगे ना योगर्ट बटता है साइकिलों पे सुबह क्या चीज उसके अंदर है प्रोबायोटिक है इट्स नॉट ऑलवेज कि आप उसको बाहर से सप्लीमेंट कर रहे हैं आप अपने डाइट में लीजिए उस पार्ट के ऊपर तो कर्ड इज अ ब्लेसिंग नथिंग लाइक इट आपकी एसिडिटी को न्यूट्रलाइज करेगा
राइट
इतनी सारी मिथ्याएं हैं गैस्ट्रोंटोलॉजी के अंदर लोगों को होता है जी हम तो दही लेते हैं दूध लेते हैं हमारे पेट में ना एसिड फट जाती है द मोस्ट कॉमन थिंग व्हाट वी हैव मिल्क प्रोडक्ट्स आईबीएस के अंदर भी हम मिल्क को रोकते हैं पहले कर्ड को नहीं रोकते हैं लस्सी को नहीं रोकते हैं ड्यू टू दिस प्रोबायोटिक्स कि वो आपके स्टमक को तो हेल्प करेगा कोलोन को भी हेल्प करेगा 30% रोल है प्रोबायोटिक्स का आपका जो लिटरेचर प्रूव करता है तो अपने डाइट में लीजिए आप सप्लीमेंट कहाँ करेंगे आप एक शॉर्ट कोर्स अगर किसी को देना चाहते हैं एक्यूट गैस्ट्रोएंटराइटिस में कई लोग यूज़ करते हैं आईबीएस में देंगे आपको रिस्पॉन्ड नहीं कर रहा है तो आप उसके अंदर आईबीडी के अंदर देंगे बट मैं फिर भी हमेशा मानता हूं कि ड्रग से पहले आप अपनी डाइट को रिफाइन कीजिए दैट इज वन ऑफ द बेस्ट वे टू लिव
Thank you, sir.
इस पे लाइफ लॉन्ग चले
So I asked specifically this question because I wanted this fact to be reiterated.
मैम सुनीता wants to
मैं कह रही हूँ हरियाणा में तो वैसे ही दूध दही का
Exactly, ma'am. But ma'am, coming from an expert, it makes sense. If I had said it, that curd is better than the market-driven probiotics, probably, people won't take it as such. But I believe personally, like rightly sir said, that we have all the power in our own food, especially in a state like Haryana, like ma'am rightly pointed out. We are blessed with still some amount of purity of food. Thank you so much. With that, we come to the end.
Thanks everyone. Have a good.
I hand over the mic to the organizers, please. Yeah.
Thank you, ma'am. Thank you, sir. Thank you to all the panelists for this wonderful panel discussion session. And I request our core committee members, Dr. Jyoti Kaushal ma'am, Dr. Savita Verma ma'am, Dr. Sunil sir, to please come and felicitate the panelists. A big round of applause for all the panelists for this wonderful discussion. Thank you so much for sparing your time and be with us and give your wonderful, enlightful discussion for this platform, Medipharmacon. Thank you all. I request ma'am to felicitate Dr. Sunita Singh, Senior Professor and Head Pathology, PGIMS Rohtak. Dr. Madhu Sharma, Professor Microbiology. Thank you so much, ma'am. Dr. Savita Singhal, ma'am. Thank you so much. Dr. Praveen Malhotra, sir, thank you so much. Dr. Yogender Malik sir, thank you so much. Now I request Jyoti Kaushal ma'am, Savita ma'am to kindly felicitate Dr. Jayant Carey sir for being the part of this panel discussion. Thank you so much, sir. Dr. Preeti Galot ma'am, Professor Anesthesia, to be with us within a short time span. Thank you so much, ma'am. I request Jyoti Kaushal ma'am, Savita ma'am, Sunil sir to be on the stage, ma'am, please. We are about to begin our valedictory session. As we draw the curtains of this remarkable event, I am filled with gratitude for the shared insights and meaningful connections we have cultivated.
I would now like to request Dr. Jyoti Kaushal ma'am to give a token of appreciation to our entire team. I hope it was an enriching event and we are going back today with a food for thought. Can we have Dr. Savita Verma ma'am on the stage, please? Now it's time to felicitate our organizing team. I would request the core committee members, Dr. Jyoti Kaushal ma'am, Dr. Savita Verma ma'am, and Dr. Sunil Kumar sir. Can we have Dr. Jyoti Sharma ma'am on stage, please, if she is here? Please do come, ma'am.
Can we request Dr. Vandana ma'am and Dr. Dikshit sir also to please join us on the stage?
I would request Dr. Himani Deswal, Joint Secretary of the conference, to come forward and have her token of appreciation. Can we have a big round of applause, please? So much, ma'am.
Now I request Dr. Monica Verma, also the Joint Secretary of the conference, who worked very hard for this day. Give her a round of applause, please.
team members to kindly present the token of appreciation to all the organizers. So starting with our scientific coordinator, Dr. Neeti Mittal ma'am. If she is here, ma'am, please kindly come forward. I would now request other members, Dr. Karthik, Dr. Ekta, Dr. Raghav, please come forward. Dr. Shanmuga Priya and Dr. Sumit. Can we have all of you on the stage, please? A big round of applause for everybody.
कार्तिक का करवा दो।
Dr. Ekta. Now moving on to the registration and reception committee. It was headed by Dr. Rakesh Mittal sir, but sir is not here. So other members were Dr. Rasita. Can we have Dr. Rasita on the stage? Dr. Falguni, Dr. Sapna and Dr. Nikita. A big round of applause for reception and registration committee.
Now I request our committee members to give Dr. Sarita Goyal ma'am a token of appreciation as she headed the souvenir committee. Please welcome ma'am.
A big round of applause for ma'am.
Other team members for the souvenir committee, Dr. Rashi, Dr. Pavan, Dr. Neetu, kindly come forward and have your token of appreciation. Thank you all.
call upon stage our treasurer Dr. Priyanka and Dr. Babita for coordinating with her and managing the things very well. A big round of applause for Dr. Priyanka and Dr. Babita.
Now moving on to the Accommodation and Transport Committee headed by Dr. Janelle sir. I think he's left. Dr. Janelle sir. He's not there. Okay, I would like to call other members of the committee, Dr. Jishnu, Dr. Shubham and Dr. Anchika to come forward and have their token of appreciation.
A big round of applause for the Accommodation and Transport Committee. Now it's time for extending thanks to the team that made sure that we didn't go hypoglycemic during such an lauded event. Food and Logistics Committee was headed by Dr. Vivek Sharma. Sir, kindly come forward if you are here. Other team members were Dr. Adarsh and Dr. Madhumita. Please come forward. Dr. Adarsh and Dr. Madhumita.
Thank you all for managing the event. Now, let's call upon stage Dr. Jyoti Khanna ma'am. She headed the stage and decoration committee as well as the inauguration ceremony. Without you, this can't be possible, ma'am. Thank you so much. I request Jyoti Koshal ma'am to facilitate her. Other members were Dr. Sonal, Dr. Garima, Dr. Prince. Dr. Shanmuga Priya, Dr. Raghav. बोलना तो था साइंटिफिक. Okay. Thank you all for working day and night for making this day wonderful.
Shall I announce your name?
Thank you, ma'am.
Thank you. अभी ये चीज़ का फिर उसके बाद बोलना ये वो तो thanks. Dr. Adarsh, come on the stage and take your token of appreciation.
Now, we do have some MBBS students amongst us who were busy in one and other work during the conference. Vanshika, Navdeep, Arman, Ravina. Are they here? Navdeep? Navdeep? Can we have you on stage, please? Vanshika, Navdeep, Arman, Ravina. volunteer?
These are the UG volunteers. Please give a big round of applause for them for helping and managing the event. Sir Saraswati Vandana, Lok Kulgeet, they sang.
थैंक यू एवरीवन। सभी के धन्यवाद के बिना किसी भी कार्य का समापन करना उचित नहीं होता। सो आई वुड लाइक टू कॉल अपॉन स्टेज डॉक्टर सुनील कुमार सर फॉर वोट ऑफ थैंक्स।
Jyoti Sharma ma'am, for the vote of thanks.
First of all, I would like to thank Dr. Jyoti Kaushal ma'am for giving us the opportunity to organize such an event. Thank you, Savita Verma ma'am. Thank you, Dr. Sunil sir, for working day and night. Thank you all the department members, Dr. Rasita, Dr. Falguni, Dr. Priyanka, Dr. Sonal, all the postgraduates, Dr. Sarita ma'am for preparing the souvenir, Dr. Jyoti Khanna ma'am for handling the stage so well. Food and Transport Committee, Dr. Janelle Singh, Dr. Vivek Sharma sir, and Monica, Himani, everyone. Sorry if I forgot someone's name. And I would also like to thank our speakers for sparing their time and giving so much information and educating us all. And last but not the least, thank you all the delegates who have come here and had made this conference a success. Thank you everyone. Thank you so much.
मैडम